Good morning, everyone. I want to welcome all of you. So I'm Steve Wang. I'm the chair here at the Department of Laryngology at the University of Arizona. And on behalf of my co-conference director, Dr. Eugene Chang, I want to issue a warm welcome to all of you to sunny, warm Southern Arizona. We're so excited to have you all here for this, our 10th annual ENT in the Desert Symposium. This is going to be a great conference, I already know. We have more than 140 registered participants for this conference. And so over the next 2.5 days, my colleagues in the faculty of the Department of Laryngology look forward to meeting you, and along with really an outstanding slate of invited speakers that draw from not only all over the country, but some of the experts here in our local area as well. So we really look forward to an outstanding, not only educational offering, but also a chance to meet and talk and interact with all of you. I think that's really the best part of these in-person conferences, which I'm still starting to get used to doing again, but boy, I really do miss them, and I know all of you do as well. I also want to issue a welcome as well as special thanks to our sponsors. Really, this meeting couldn't happen without you, and so I just want to thank we have 7 sponsors this year: Acclarent, GSK, Sanofi Regeneron, Castle Biosciences, Fusion Specialty Pharmacy, KLS Martin, and Medtronic. They all have booths in the room next door, and I encourage you to all meet and talk with them during the breaks or anytime. So as I said, we've got a great group of lectures and panel discussions for this, but I also want to highlight a few of the kind of fun activities that we also have. So when you picked up your badge, you got a sheet on a scavenger hunt that we're doing, and it's really just a little way to engage you, but also maybe to make sure you're paying attention during the conference. And so we have a list of kind of fun trivia questions. All the answers will be provided during the sessions. So we'd like you to, if you want, fill out those questions and then submit those by Saturday morning. And then we actually have some prizes. We'll have a drawing of those who answered, I guess, all of them correctly. But we'll have prizes, and they include everything from free registration for our next year's meeting to a 2-night stay at the Lowe's Ventana, as well as some nice paraphernalia from the University of Arizona. We have a golf outing which has filled up and closed, so I'm sorry we don't have any more spaces available. But for those of you who did sign up for it, you should have gotten messaging that will leave at 1 o'clock tomorrow afternoon, and that's led by Dr. Eugene Chang. There's still room if anyone wants to join the hike, which is going to be led by Sonia and some of our other staff. That's also going to be leaving from here around 1:30 tomorrow. So if you're interested in that, please let Sonia or one of the people at the registration desk know about that. So just a bit to go over the schedule. So today the sessions pretty much go all day. We have lunch provided. And during the lunch, there's a non-CME product theater, which is set up just in the other room in those chairs, and really hope that you will attend that, but that's not for CME credit. After the end of the session this afternoon, we also have a cocktail hour, which is also another product theater. Also will be in that same location. There will be drinks available. If you are planning to attend that, go ahead and let anyone at the registration desk know we have some additional drink tickets in addition to the ones you received for the welcome reception, which will follow that cocktail hour. The welcome reception is from 6:30 to 8:30, and that'll be in the main hotel building. And so that'll be a great time also to interact and talk with your fellow participants as well as some of us. So we really look forward and hope you can all make the welcome reception this evening. Tomorrow are a bit shorter. We just have, for both Friday and Saturday, we'll again have breakfast provided here in the morning, and the sessions will go from 7:30 to 12:30, and there'll be lunch. And for those that aren't going on the golfing, we'll spend some time in the patio outside, hopefully for that, and then it's on your own on Friday until Saturday. So again, welcome everyone. Look forward to getting to talk with all of you over the next 2.5 days. But first, let's go on to our first session. It's my pleasure to welcome my colleague, Dr. David Chen, who will introduce the first slate of speakers for the panel.
Thanks. All right, good morning, everyone, and welcome. My name is David Chen. I'm the facial plastic and reconstructive surgeon here at the University of Arizona. I'm super excited to be kicking off our conference this morning with our first session in facial plastics. We have some really great talks lined up for you this morning. Doctors Olson and Ostrom are two of our wonderful facial plastic surgeons and my colleagues in the community who have been nothing short of warm and welcoming as a newcomer here to Tucson in the past year and a half. And then later this morning, Dr. Fred Mennick will also be joining us to talk about some of his contributions to the field of nasal reconstruction. So without further ado, here's Dr. Jerry Olson.
Thank you. Good morning, everyone. I'm going to spend a few minutes this morning talking about a procedure that I don't do very often. I wish I did more frequently. About 70% of my practice currently is cosmetic. The other 30% is skin cancer reconstruction and some trauma. This is, of the cosmetic group, this is probably the least frequently thing I do, but maybe the most fun. This is a procedure like other things like lip lifting that's been around for a long time, but is kind of experiencing some resurgence in the cosmetic community. So the patients who come to me and the patients who I think might benefit from this procedure are those that have a good hairline, meaning dense hair. They have congenitally high hairline. They'll tell you they've had the same hairline since they were teenagers. I always ask about family history, especially, first order relatives, because even in young people, even in women, there's some chance that hairline is going to elevate in a male pattern over time. And then we want them, of course, not to have any other underlying problems like traction alopecia or any other issues like that. And the ideal patient for this is somebody who would cosmetically benefit from a 2 to 3 centimeter advancement. If they need more than that, there are people who would suggest that a tissue expander placed preoperatively would be a useful thing, and certainly that works, but I just think that's excessive for a cosmetic procedure. I mean, reconstruction is one thing, but this is designed to be an hour-and-a-half outpatient procedure. So if you're interested in this, there's 2 papers that are worth looking at. Sheldon Kabacher is I'm assuming now retired facial plastic surgeon in the Bay Area. He published that paper in 2013, but in the paper mentions that he's been doing it for 20 years. And I heard him talk about it maybe 18 or 19 years ago, but never really had an opportunity to do it until about 6 or 7 years ago. And the second article was written by Tim Martin. He's a well-known plastic surgeon in San Francisco. He wrote about combining this hairline advancement procedure with a high forehead brow lift. The incisions are the same, and you can do 2 things at once. I've not done that. So here's a patient that I saw recently, and of course, you'd be reasonable to ask, why are we doing anything to this young, arguably attractive young woman? But this is what she sees. She sees, in photos in particular, where's the pointer here? So there we go. She sees this up here. It's magnified, I'll show you in a minute, in cell phone photos. Even at this age, occasionally your friends will comment on this. When you see the hairline starting above this region, forehead, vertical, when you get to that horizontal part of the scalp and the hairline starts up there, it starts to catch shadowing that you don't appreciate, and it pulls your eye there. So this diagram from Dr. Martin's paper talks about our ideal ratios of thirds. We've all seen this diagram before. the one on the right-hand side, you know, demonstrates what a little hair loss will do and perhaps a little bone loss here. It changes these facial dimensions. So, you know, we're striving for this kind of look. But really, this explains it more. There's a similar diagram in Dr. Mennick's book, but this tracks eye movements when people are looking at photographs. And, you know, this is where we go centrally. You look here, there must have been something a little more interesting here because she's a younger woman. There must have been something going on out here. When our eye gets pulled peripherally, that's the sort of thing we don't like when we look at faces. And the other thing for me is, even with rhinoplasty or other procedures we do, when we see a shadow or a highlight where we're not expecting it, our eye gets drawn to those areas. You know, the nose can look great, but there's a little concavity on the nasal sidewall. At least for me, my eye goes right to it. So that's that kind of eliminating light reflex up here where you don't want to see it is sort of the goal here. And then the last thing that drives this kind of new interest in this is cell phones. I mean, this is the same patient. Her forehead looks like it's a mile wide and a mile high. I mean, that's not what she looks like in real life, but that's how she sees herself often in photos. All of our cell phone cameras have that fixed focal length lens, which tends to magnify the center part of the photo. It makes noses look bigger, it makes foreheads look bigger. It's been good for business, but it's not reality. So this is what's important to know for the operation. What keeps the flap alive is going to be occipital artery. You might get some branches of postauricular artery, but everything anteriorly up here is going to be cut. Everything coming from forehead is going to be cut. In the same way, this is not a painful operation because you're going to take away a fair amount of innervation too. Lesser occipital and greater occipital nerves will be preserved, but auricular temporal is almost certainly going to be cut with this procedure. Surprisingly, patients don't mind that much, and a lot of the sensation will come back. When I was a fellow in the mid-90s, we did, you know, every brow lift essentially was open, so a lot of them were coronal lifts, but with people who had a high hairline, we would do pretrichal or trichophytic. There's a lot of names for the same procedure. So this was something I was familiar with before I ever did this operation. And so the point of the diagram is that you're cutting through skin and then you're really skiving this incision forward, trying to preserve the fat where the hair bulbs live. If you preserve that and you treat it kindly, when we advance the flap forward, that's going to get tucked under the incision and allow those hairs to eventually grow up in front of the scar. And then the other important thing is to not make it a straight line. You know, the hairlines aren't straight, and so we kind of weave this in and out of the first 2 to 3 hairs. So this is that same young woman. From above, you can see we're just within the vellus hairs of her hairline, respecting the normal curvature of her hair. So here from the side, I've injected her. I inject a fair amount of local anesthetic with epinephrine. I also, Dr. Osterman and I were just speaking, is a tumescent. We'll use a TXA solution liberally before we start. The posterior aspect of this incision stops just behind, here's her ear, so it's just behind the ear. And this line is right along the temporal line, so just at the top of the origin of the temporalis muscle, undermining back to the nuchal ridge to about here. So here's that skin incision, and I've really made this thinner than I would make it if I were just doing a forehead lift, because this skin's going away. We don't really care if this is too thin or if it gets injured, because it's going away. What I'm worried about, what I want to preserve, is this fat. And I don't know if you can make out the hair bulbs that are here, but if you preserve those and you're gentle with them, they will survive, almost always. So then the next step is, after I've made that incision, there's going to be some inevitable bleeding from supratrochlear infraorbital vessels coming upward, and those get cauterized. But I try not to cauterize the flap side of it at all. I stop bleeding there by holding pressure. And then from the lateral aspect of that forehead incision, I'll start the undermining. And once I've established that subgaleal plane, I use this instrument. And if you do scalp flaps or do work in the neck, this instrument is great. I didn't always know about it. It was developed by a French plastic surgeon. It's got a sort of a sharp end here that allows you to insert it under tissue, and then you spread it like this, and it makes really quick work of elevating the flap. And so I'll elevate the entire flap before I make any incisions into the hair-bearing scalp, which makes this procedure less bloody, not non-bloody, but less bloody. And then once I've done that, I slide a malleable under the temporal incision, and that allows me to cut all the way through the scalp down to periosteum in one fell swoop, both sides. Again, you do that more quickly and there's going to be less bleeding to deal with. And then the scalp gets inverted. So this is arguably the most important part of it. You need to cross-hatch the galea to get it to expand. Every one of these little cuts will give you 1 to 2 millimeters. And so, I've just started this part of the procedure in this photograph, and this one's good. Out here, I haven't gone all the way through. I'll keep going probably 10 to 12 times across the scalp to get our expansion. And then after I've done it, then I go back and look, because there's always a little bit here that you didn't get quite through. If you go, you want to just see subcutaneous fat when you make this incision. If you see hair bulbs, then you're too deep. And then once I've done this, I will bring the scalp back out to the forehead, and I'll stand there with a couple of perforating towel clamps and just kind of stretch the scalp for a couple of minutes. I don't really know if that helps, but I do it every time anyway. And then I drape the flap down and measure. So this is, again, the same patient. This is 2.5 centimeters. That's what we were hoping to get. The most I've ever gotten out of one of these flaps was 3. There's been 1 or 2 patients where we only got 2. And the patients need to understand that up front, that there's some unpredictability about how much advancement you're going to achieve. And then I bring the scalp forward and repair it. Some people who do this procedure will use the endotine anchors that have been popular for endoscopic brow lifting. They're absorbable. I don't really have any experience with those. I haven't fixated this flap with anything other than deep sutures that go from the temporalis right at the temporal line up to the galea of the flap. And I'll place multiple of those because I want all that tension to be taken up on the lateral aspect of the flap that's back in the hairline and very little tension up in front. And then I will put some deeper monocrural sutures from periosteum of the forehead, which is relatively flimsy, to the dermis of the flap, being, again, careful not to get sub-Q because you don't want to injure those hair bulbs that you've worked so hard to preserve. So that's her at repair. It's tedious, this part, a bunch of little stitches. Again, we try to make this hairline kind of weave in and out of those first few hairs. And there she is, suture removal day. I use this Duoderm material. I use it frequently for all kinds of incisions. It's silicone sheeting, but easier. You cut a piece, you put it on, it stays on for a week. I like patients to wear it for 6 weeks after surgery. Not so easily done here, but I do think it's helpful. So complications, fortunately very few. I've not seen anybody have postoperative bleeding or infection. I've got no one, fortunately, who's had tissue loss. I mean, it's a flap, and so that front edge of the flap is vulnerable. That would be a disaster if somebody had tissue loss there. But I have had shock loss and a scar that I didn't like, both in the same patient, and I'll show you those to you. This is shock loss. This is along the temporal incision, the most posterior part. It just occurred on one side. It came back in about 4 to 5 months. She has a nice head of hair, so it was easy to hide. This is my wife's friend, so there was a little more emotional overlay, but it turned out okay. But then her forehead didn't really heal that well either. She didn't get any hairs out in front of the scar. So now we've hair grafted her. So it's nice to know that there's a fallback plan. We don't plan to add hair grafts to these. This is the only one we've had to do that with. But it's nice to know that there's an option if things don't work out quite the way you anticipated. The other thing I should mention looking at this photo is that, patients ask, well, could I just get hair grafting to bring my hairline down, you know, that 2.5 centimeters, that would be about 3,000 grafts for most foreheads. That's a lot of hair grafts. It could be done for sure. It's expensive, it's a long day. And you're gonna have to hide this. You know, imagine if that were all the way down here. So, you know, most of these patients, young, working, college students, it's gonna be hard to hide that for 6 months until it looks good. So here are a few other results that turned out well. This is a 30-ish-year-old woman and with a really high forehead. And here she is, she's 3 or 4 months out, I think, from her procedure. I've got a close-up of her hairline. But it really just changed your whole facial axis. Instead of your eye being drawn up here, you see this. You might notice her nose, which is the bad thing. So again, post-op, this operation does everything. Look, her skin's better, her nose is better. It's a great operation. Everyone should do it. That's her up close. You can see she's got hair grafts coming up right in the scar and just in front. You know, with a year, that'll look even better. Here's one of the earlier patients I did, you know, not like, oh wow result, but still I think, again, your eye goes up here less. Here's somebody we did recently. This is suture removal day. She lives in Southern California. She flew here to have it done. This was the day sutures came out. The interesting thing about this patient group, I hardly ever see them again. It's not like rhinoplasty patients that you see forever. These people the sutures come out, they heal. They're young, of course, which helps. And long-term follow-up is unusual. And then another woman, again, same story, she lives in Phoenix. So I saw her at 6 weeks after surgery and then never again. And that's her hairline up close. And again, you can see hairs out in front of the scar, hairs right in the scar, and that's early on. And then one more patient. You know, it just changes the whole kind of feel for their frontal view. That's all I have. Thanks for your time.
Any questions? Testing. Good. Testing. All right. Any questions for Dr. Olson? So I actually have a question just about scalp flaps in general. You know, it always impresses me how little give you get anytime you try to advance a scalp. And so whenever I make those Galen incisions, I'm always scared that I'm going to mess up the vascularity of the flap. I'm just going to get distal necrosis. In your experience, has that ever been an issue? Can you kind of just go hog on those, or is there like a limit?
No, excuse me, I worry about it every time. But I know that if I'm just through the galea and I'm not seeing hair bulbs, that it should be fine. I've had one, I remember a flap. I hate to throw the resident under the bus, but I was doing a flap with one of our residents here for skin cancer reconstruction, and I said, go ahead and crosshatch the galea, and he went, phew, and I went, and part of that flap didn't do so well. But I mean, we were with that like clearly at the hair bulbs and beyond, and it was at the distal edge. But no, I think if you don't undermine this particular flap overly far and you're just through the galea, you shouldn't be seeing any vessels that are really feeding the flap. To the nuchal ridge, so, you know, here, yeah.
So next up we have Dr. Janae Ostrom. She's going to be talking to us about TXA.
Good morning. Thank you, Dr. Chen, for having me today. My name is Janae Ostrom. I am a facial plastic surgeon here in town in private practice. I'm a former resident of the University of Arizona, so it's nice to be back here. And then I went on after residency and did a fellowship at the University of Washington in Seattle. So today I'm going to talk about something that's useful to everybody in practice, whether you're a facial plastic surgeon or general ENT. Does everybody here in the audience use TXA, or does anybody? Not that many people? Okay, good. So let me introduce you to the wonderful world of TXA. We're going to briefly go over what TXA is, what does it do in the body, its history and use in medicine, which spans decades, use in general ENT, facial plastics, and then some controversies surrounding the medication. So tranexamic acid is a synthetic analog to lysine. As you can see up here in the right-hand corner, it looks almost identical chemically. And because of this, it acts really well within the fibrinolysis pathway. So it's an antifibrinolytic, and the way it works is it binds competitively to plasminogen instead of lysine. Once it binds to plasminogen, it blocks the further transformation of plasminogen into plasmin, which breaks down fibrin in the clot. This was first discovered in the 1940s in World War II by a married couple of researchers in Japan, the Okamotos. After World War II, blood products in Japan were very scarce, and the leading cause of death over there was postpartum hemorrhage. So they were working really hard to find a drug that could help preserve these blood products and help decrease the mortality rate over there. The chemical compound was first identified in 1962, and then in 2011, it was added to the WHO's list of essential medications. There's high-grade evidence for this drug in high-volume blood loss surgeries, specifically in trauma and OBGYN and cardiac surgeries. The evidence in these fields typically use very high-dose TXA, more than we would ever use in general ENT practice. But there's really good evidence that it works in decreasing perioperative transfusion rates and also death in patients. There's also moderate grade evidence for its use in other fields such as heavy menstrual bleeding for OBGYN patients, intracranial hemorrhage, hemoptysis, orthopedic surgeries with high blood loss. It's used topically quite frequently for things like epistaxis and also for treatment of HHT. There are some side effects, and again, this is more common with the very high dose systemic use of TXA, but some things like headache, nasal symptoms, nausea, vomiting, diarrhea, musculoskeletal pain, fatigue, and then more serious complications, temporary impaired or blurred vision, seizure, or hypersensitivity reactions have also been reported. All of the more serious side effects, however, are very rare and usually in very sick patients. TXA can be administered systemically, and when used prophylactically before a surgery has been shown to decrease blood loss significantly by about 30 to 40%. These studies, again, were mostly in trauma patients and OBGYN patients where high blood loss was expected. It can also be used topically and locally, which is the way that I use it mostly. And there has been really no reported increase in adverse events when used in this manner. And still, it does significantly reduce blood loss. It also comes in an oral form, which I have not used, but is useful in treating long-term skin conditions like melasma. When we're using it systemically, the concentration within the tissues has to be above 10 micrograms per milliliter to inhibit the fibrinolysis pathway. To get to a dose of 10 micrograms per milliliter, you need to inject or have your anesthesiologist inject about 10 to 15 milligrams per kilogram, and that'll keep the tissue concentrations high enough for about 1 to 3 hours to have a notable effect. If you go higher than that, there's really no added benefit to decreasing blood loss. So if you took a 90 kilogram man and you calculated what his dose would be for 15 milligrams per kilogram, you're well above the well-researched dose of 1 gram IV, which is thought to be kind of the threshold for maximal inhibition of the fibrinolysis pathway. So, you know, when I'm operating on adults and I want to consider using TXA, I don't even do the calculations. I just ask the anesthesiologist to give 1 gram IV. It's a very quick and easy thing to do, and there's no added benefit to go any higher than that. Traditionally in cardiac surgery, they were using about 80 to 100 milligrams per kilogram. These practice patterns are changing, however, because of that dose-dependent increase in seizure risk that I mentioned earlier. Topically, this is where I use it mostly in my facial plastics practice. These are not my patients, but they are two patients who probably would have benefited from TXA preoperatively. The gentleman in the upper right-hand corner had a blepharoplasty, has extensive bruising. The lady in the bottom right-hand corner has a hematoma post-op after her facelift. And even after the hematoma has been evacuated, she has extensive bruising. Cosmetic patients don't like this. It delays their return to their normal life. It alerts family members and friends that they had an intervention done, and all that bruising can cause significant pain. So, even though we're not talking about using it in high volume blood loss surgeries, it really can increase the patient's satisfaction post-op if you use it in even these smaller blood loss procedures. Topically, the lowest effective concentration isn't known. There was one study in ENT done on adenoidectomy where the surgeon poured about 10 mLs into the nasopharynx after adenoidectomy, let it sit for 5 minutes, and then measured blood loss. And they did see a significant blood loss even in a simple procedure such as that. There have been some studies in soft tissue surgeries as well, blepharoplasty being one of them, and also Mohs surgery, where the TXA was injected one-to-one mixture with the local. And again, they saw a significant decrease in post-operative interventions needed for the patients in the TXA group. And then there's also a bunch of cocktails you can come up with, which I'll go over in a minute, including mixing it into your tumescent. In general ENT, I take general ENT call. It has been a complete game changer for me when it comes to tonsil bleeds. I'm in a 9-physician group, and there's a lot of tonsils being done in my group. When these patients come back to the ED, my first question is, can you give them TXA? By the time I get to the hospital to evaluate the patient, almost all of them have stopped bleeding. I haven't taken a post-tonsil bleed back to the OR in over 3 years. So it's a complete game changer. I do modify the dose for children. I give the same dose that they give in craniosynostosis surgery, which is 10 milligrams per kilogram. And I've not had any complications in that regard. Our ED colleagues use it a lot for epistaxis. They often soak pledgets in TXA and put it into the nose. And then again, by the time I get to the ED to evaluate the patient, the bleeding is often stopped. My sinus colleagues use this frequently. Not only does it decrease the use of blood transfusion in high blood loss surgeries like tumors or HHT cases, but it increases their visibility during the surgeries. So very popular with them. And then, like I mentioned, craniosynostosis, where the patient is very low volume and you want to preserve all the blood that you can. It's routinely given preoperatively for these patients. And again, that dose for kids is about 10 milligrams per kilogram. There are some studied regimens with some evidence behind them. These are just the ones that I found in my literature review. People are using it quite frequently in von Willebrand disease, patients with HHT. Our dermatologist colleagues use it a lot for melasma. I will use it in a patient with a lot of pigmentation for prophylaxis if I'm worried about hyperpigmentation, post-inflammatory changes to the skin after procedures. And then again, it can be used frequently with epistaxis patients. In facial plastics, these are the ways that I use it. In my tumescence, this is the recipe that I stole from Dr. Giacono. He's been using TXA for over a decade. And I didn't use it in fellowship, but I now use it in practice, and I can tell you it is completely different. My patients have significantly less bruising. They're much more comfortable, and it's really, really helpful. Topically for Mohs recon, if you're doing a lot of Mohs recon in the office, this can be helpful, either mixed with your local before you start, or if you just soak some pledgets and lay it over the wound, especially in these elderly patients who can't stop their blood thinners. It is really helpful. And then I use it in every single rhinoplasty case, again, mixed with my local. I inject it over the planned osteotomy sites, and my postoperative bruising rate for these patients has gone down quite a bit. There are some things you need to be careful about with TXA, the main one being TXA-associated seizure. This, again, is with really high-dose TXA. It's mostly documented in the open chamber cardiac surgery type literature where they're using greater than 80 to 100 milligrams per kilogram. But TXA is a competitive antagonist to the GABA and glycine receptors in the CNS. And once those receptors are inhibited, the inhibitory current in the CNS goes down, which increases risk of seizure. You never want to apply this directly to the CNS, like on a pledget. That would be very bad form. And it's also eliminated by the kidneys. So if you have a patient with renal disease and you really want to use TXA, you do need to dose adjust. And I put those dose adjustments here in the table. There are 3 hard contraindications for its use in the US: patients with subarachnoid hemorrhage, patients with prior TXA documented hypersensitivity reactions, and then patients with either a history of or current thrombosis. You also want to avoid use in patients who are on prothrombotic medications such as factor IX concentrates or hormonal contraceptives, which we'll talk about in a second. So most of the surgeons I talk to worry about TXA and thrombosis. They know about the drug, but they're hesitant to use it because, our surgeries aren't super high volume blood loss and really do the risks outweigh the benefits. There have been many studies to show that the increased risk in thrombosis is not an issue in patients if they've never had a thrombosis before. So there have been over 175,000 patients studied looking at things like DVT, PE, stroke, and MI. And in non-surgical patients, there was 0 increased risk for venous or arterial thrombosis when TXA was used. In surgical patients, the same finding was found: no increased risk in thrombotic events for any type of surgery. And most of these surgical patients studied were high blood loss cohorts, trauma patients and OBGYN patients. So key takeaway is if your patient has never had a thrombosis, does not have cirrhosis, there's really no evidence that says you need to avoid TXA. And then again, you have no reason to go over 1 gram, which increases your risk of these complications. When talking about oral contraceptives, if you were to take a non-pregnant woman not on OCPs, her risk of a blood clot is about 1 to 5 per 10,000 woman years. You give her OCPs, she's still not pregnant, her risk doubles. So OCPs in themselves are a prothrombotic medication, so you do want to think twice about giving TXA in patients who are on OCPs. There's a theoretical risk that they're already in a prothrombotic state, so do you really want to increase their risk by giving them this medication? These patients are higher risk if they're over 60, obese, have a malignancy, they're immobile, or they have thrombophilia. And there's ongoing studies about this, mostly in the OBGYN literature for women who have very heavy periods. But if you have a patient who's on an OCP and you can get away with not giving it until those studies are done, that's what I would advise. And then lastly, patients with hematuria. I can't even remember the last time I had a patient with hematuria, but there's one case report out there where TXA was given in a patient with hematuria, polycystic kidney disease, and they ended up with a clot in their ureter. So there's ongoing research in that regard, but those are the 3 situations where I would caution you with its use. So in summary, TXA is a great medication to have in your toolbox. It decreases bleeding and the complications associated with bleeding, specifically hematoma and pain associated with excessive bruising. TXA does not increase the risk of blood clots as long as your patient hasn't had one before. If you have a patient on OCPs, definitely talk to them about the risks before you use it, and then just avoid it with patients who have hematuria. Right, thank you. They didn't really talk about that in all the articles I reviewed. They were new seizures in all the studies that I read, and they were all in patients with major cardiac history. So I don't know the answer to that. No, I have the anesthesiologist give it right before the start of the case. They just put it in the line.
Appreciate your chat.
Yeah, I have in the past. I mean, obviously I have them do the regular things first, make sure the blood pressure is under control, make sure they've been reversed if they can be reversed. But if they can't, then I've certainly given it 1 gram IV, and then I have them put it in the nose topically also, and it does help quite a bit. Mm-hmm.
One more question.
Sure.
So it looked like for rhinoplasties and some of the other surgeries you do injection TXA. Is that in conjunction with the IV push at the beginning, or do you not like to mix and match?
No, I don't feel like it's necessary for rhinoplasty to do an IV dose, so I just use it locally. The places where I use it systemically are post-operative tonsil bleeds. I use it before sinus surgery before, but local is my main go-to for my facial plastics procedures, intumescence and whatnot.
I've also got the ER doctors, just use a nebulizer for constantly.
Mhm.
Use it that way, it works well that way.
Yeah, it's a great medication. I really encourage you to use it in a patient and just see if you notice a difference, because it's one of my first go-tos for things like that. Yeah. Anecdotally, in my practice, yes. For all my adult tonsils, as long as they don't have any of the risk factors that I discuss, I give 1 gram before my tonsillectomies, just because I always worry about adult tonsils. And I haven't had a post-op adult tonsil bleed since I've been in practice. Thank you.
Thanks so much for that, Janae. And that's not something that I've incorporated into my practice extensively, but I think you've convinced me, so I'm going to give it a shot. So I'd like to talk this morning about a topic that's a special interest of mine, which is the treatment of facial paralysis. Facial paralysis is a topic within facial plastics that's received a lot of attention, seen a lot of growth in the past 10 years in terms of new studies and advancements. Here in Southern Arizona, I think it's also an area of special need, just because there are relatively limited resources for patients to receive care for this condition. And so that's something that I'm working to build and hopefully develop here at the university in the years to come. As an interesting aside, the issue of facial paralysis in the form of Bell's palsy has kind of come up as a little bit of a controversy in the wake of the pandemic and the rollout of all the new mRNA vaccines. So there were a few published studies that suggested a possible association between the new mRNA vaccines and an increase incidence in Bell's palsy in vaccinated patients. And so these are kind of two more prominent examples published in the Lancet, looking at some population data that seem to suggest up to a 5 times increased incidence in Bell's palsy for those who had received an mRNA vaccine. But then on the other side, there were also some studies that conversely showed no increased incidence of Bell's palsy and also a possible protective effect of the vaccine against Bell's palsy as a consequence of an actual COVID infection. So the jury's kind of still out on this issue. I think it's something interesting that we'll have to follow and hopefully receive more definitive answers in the years to come. But on the topic of Bell's palsy, I'd like to start with that as one of the most common etiologies of facial paralysis. Counts for 70% of all cases. There's about a 10% recurrence rate. Interestingly, it's more likely that if you have it once, you'll get it on the other side of the face if you do recur. There's no predilection for sex, race, or affected side of paralysis. And as we know, Bell's palsy is idiopathic facial paralysis, so it's by definition a diagnosis of exclusion. And it's excluded primarily on history and physical. And so to be considered idiopathic, the paralysis has to be unilateral, it has to be complete, affecting all divisions of the face, and it has to be sudden, meaning you have to reach complete paralysis within 72 hours. So if only part of the face is affected, or if it's a gradual onset, then it's probably something else. So I can recall one patient who came in for evaluation of Bell's palsy, and he seemed to be convinced that that was his diagnosis, but the onset of his paralysis had been for several months, and it started off as incomplete. And so he had a pretty extensive and unfortunately aggressive skull-based tumor that was undiagnosed. So the initial treatment for Bell's palsy is, as we know, high-dose steroids and a course of antivirals. And then per our academy guidelines, if after 3 months there's no improvement, then there's an indication for further workup. So that includes lab workup for things like Lyme disease, as well as a skull base MRI. And this is what I'll commonly do for patients that are referred to me for Bell's palsy as well. So most of these patients recover to some degree. So if we do have patients that just, we don't see any changes after 3 months, then I will order imaging for them. And then, of course, all the other etiologies for facial paralysis, herpes zoster, which is the second most common after Bell's palsy, trauma, and then neoplastic etiologies, so parotid, skull-based tumors. And in my practice, most of the patients that I see that I treat for facial paralysis actually come from this category. So no matter what the etiology is for facial paralysis, when I first see a patient in clinic and meet them for the first time, the first thing that I kind of zone in on and focus on is their eye function. So this is kind of the most time-sensitive, pressing issue that needs to be addressed first. As we know, orbicularis paralysis results in incomplete eye closure, as well as poor apposition of the eyelids to the globe. And so over time, this causes not only direct exposure of the cornea, but also aberrations in the distribution of the tear film, which can cause exposure keratopathy and corneal damage. So this leads to things like acute corneal ulcer or chronic scarring of the cornea, which is the both causes of irreversible vision loss. So this is a dreaded complication of facial paralysis that needs to be addressed early. So this is a gentleman with an isolated upper division paralysis. Get the pointer here. So you can see he has the typical findings with the lag ophthalmos. He has some scleral show and a little bit of corneal show as well. So even though he has that good Bell's reflex, still not enough to completely cover his cornea when he tries to blink. And you'll notice he also has a pretty noticeable paralytic ectropion as well, caused by atrophy of the orbicularis oculi, so that lid will just pull away over time from the eyeball. And this is something that usually isn't apparent at first when someone experiences acute paralysis, but kind of progresses as that muscle continues to atrophy. And so fortunately, the treatment for this is relatively straightforward in the scheme of facial reanimation. So typically consists of an upper eyelid implant to load the eyelid to facilitate closure, and then some form of lower lid tightening procedure. And so my preferred kind of go-to for these patients is a lateral tarsal strip. So for this gentleman, we were able to achieve a complete eye closure again. He has good resting symmetry and good lower lid position after a very short procedure. In terms of eyelid implants, there's sort of a few different options that are available. So these implants come in gold and platinum. My preference is to use the platinum implants for a few reasons. So platinum is denser, meaning you can achieve the same amount of loading for a thinner profile weight. And theoretically, this decreases the chances of implant exposure. So if it's not sticking out of the skin, it's less visible and also less likely to break through. There's also less documented reaction to platinum compared to gold. So there are actually cases in the literature of patients with gold allergy, even though it's supposed to be inert. But there's no such cases for platinum. One of the lesser known complications of putting in these implants is, they kind of work almost like a hard contact lens, if you're familiar with those. So they can reshape the contour of the cornea over time just by virtue of sitting over it like a weight. So these can actually cause an iatrogenic astigmatism in patients. Patients can have vision changes over time. And so one way to circumvent this is to use this jointed weight, which kind of contours to the natural shape of the eye, which can differ between people. The one downside of this is that if you ever want to get it out, the tissue ingrowth and scarring in these little holes and joints makes them incredibly difficult to remove. So for a patient who has a reversible facial paralysis who you think you're going to recover, probably not the best option, but otherwise these are really nice. This is an example of a gentleman, similar issue, so incomplete eye closure with a very profound lower lid ectropion. And then he also has a problem of asymmetric, pretty severe brow ptosis from paralysis of his frontalis muscle. And so that's actually functionally causing a visual hooding on that side. So he's lost a decent part of his visual field on the right. And so in addition to the eyelid weight and the lower eyelid tarsal strip, we also performed direct brow lift for him. And that is my preferred intervention for patients with asymmetric facial paralysis, just because oftentimes the amount of elevation that you need is at least 1, sometimes even 1.5 and 2 centimeters, which is really tough to achieve with something like an endoscopic brow lift, which would be my preferred method for treating something like age-related brow ptosis. But the amount of elevation that you get and the direct control that you get with a direct brow lift is kind of unparalleled. So the way I do this is pretty straightforward. It's just a simple direct skin excision that I design preoperatively. And then I do deep tacking sutures to tack the brow to the forehead periosteum to keep it up. It's a little bit of a balancing act because if you raise the brow too much, you can worsen your lagophthalmos and kind of counteract the the eye closure that you get from putting in the weight. But ultimately, you can get pretty good symmetry, a resolution of that hooding, as well as complete eye closure. There's some patients also that you have to be careful of who have not only horizontal laxity, which is the typical case for facial paralysis, but also a vertical insufficiency of the eyelid. And this is a gentleman who has some vertical insufficiency, and he also has what's called a negative vector eye. So the orbital rim and his cheekbones are relatively recessed compared to the position of his cornea. So what happens is he actually had a facial paralysis and underwent a lateral tarsal strip procedure. And that kind of works like tightening a belt real tight underneath the beer belly. So the pants get tight, but the belly slips out. And so the tarsal strip procedure actually for him created an iatrogenic lid retraction that caused malposition of his lower eyelid and also further exposure of his eye. And so for these patients to address that vertical insufficiency, they'll often need a spacer graft. So this goes right below the lower eyelid tarsus, between the tarsus and the retractors and the septum. And you can use lots of things for this. So people will use hard palate mucosa. You can use auricular cartilage. My preference is to use thick alloderm, just because it avoids any donor site morbidity, saves time from needing to harvest any tissue. And the alloderm actually conforms really well to the eye. So sometimes if people have rigid ear cartilage, it can actually create a lot of irritation. And so we were able to get pretty good positioning, repositioning of his lower eyelid. So I redid his tarsal strip, but also put in that spacer graft. So for all of these patients, no matter what surgical procedure you do, it's super important that they have an ophthalmologist who sees them regularly and can perform routine corneal exams. Despite our best surgical efforts, so even if you get complete eye closure and the lids are in good position, some of these patients will progress to get worsening exposure keratopathy. And so you need to have someone who can recognize that and be able to follow it over time. So even if the eye closes completely after you load it with a weight, there's still a time lag whenever that patient blinks, where this eye on the affected side is just not going to close completely, or it's not going to stay closed or covered for as long as the other eye. And then some of these patients will also have sensation issues of their cornea, which can also affect their ability to protect their eye. So even if you kind of throw the kitchen sink at them in terms of surgical interventions, some of these patients will need aggressive eye care with artificial tears, the usual lubricating ointment at night, moisture chamber at night. And there are cases when even that's not enough. And so scleral contact lens is actually a great option for those patients who have very severe exposure keratopathy that's kind of recalcitrant or refractory to treatment. So this is a special lens that kind of sits on the sclera, and it creates kind of this space between the lens and the cornea to serve as a reservoir of tear film and fluid. And so this keeps the cornea hydrated at all times. So actually a really great option can give patients who have really bad kind of intractable eye irritation a lot of comfort. The downside is that these are super tricky to fit. So you need an optometrist who has special training and experience working with these lenses. So I'm really fortunate. I have a colleague here in the ophthalmology department who's a specialty trained optometrist who can offer these to our facial paralysis patients. Once the eye is taken care of, kind of the next question to tackle that's time sensitive is the timing for dynamic reanimation. And so we know that as a muscle is denervated, it'll continue to atrophy, and then eventually the motor end plates will completely fibrose over. So after a certain amount of time, and typically that ballpark time period is 1 year, even if you reinnervate the facial musculature, your muscle end organ is now defunct. It'll never work again. So that 1 year is kind of a ticking deadline when you're seeing these patients. So if you have a patient with an irreversible paralysis, let's say from like a nerve transection or a nerve resection from tumor, the decision for when to perform a dynamic reanimation is pretty simple. It's just as soon as you can, right? The earlier you do it, the more muscle you can recruit. Time is also muscle in this case, and the better your functional outcome is going to be. The tough question is for those patients who you expect to recover to some degree. So this could be a Bell's palsy patient who's already showing some signs of recovery, but still has really profound paralysis. They're still at a House Brackman 5 or 6, but they're starting to have some movement. And so could be a patient with a neuropraxia after a parotidectomy. So we know that the time it takes to see the most appreciable spontaneous nerve recovery also happens to be about a window of a year. And so sometime within that first year for these patients, you have to decide, okay, you're not recovering enough. You've recovered some, but I don't think it's going to be enough in time, and so we need to talk about doing surgery. And there's really no set guideline on when the right answer for when that time is in the first year, but we have a little bit of guidance from the vestibular schwannoma population. So we know that in these patients, that after 6 months, that truly meaningful recovery falls off quite a bit. So you don't really have to wait the whole 12 months to see what happens. We also know that if you perform dynamic reinnervation in these patients within the first 6 months, you get significantly improved functional outcomes. So typically in that range of 4 to 6 months for a patient who's recovering, who's at a House Brackman 4 or 5, I'll initiate that discussion of doing dynamic reanimation. And the alternative, of course, would be to just hold off on surgery, avoid surgery if possible, and hope that they can achieve a good spontaneous recovery, which we know that most Bell's patients do. Something that I can't emphasize enough, so whether it's a patient with Bell's palsy or any other facial paralysis that's spontaneously recovering, or someone who's already had a dynamic reanimation procedure, physical therapy is super, super important in optimizing the functional outcome. So, even if you plug a nerve back in or someone's recovering from Bell's, the rate at which they recover and the degree of function that they ultimately get, we know is significantly improved if they get specialized facial nerve physical therapy. And so there are physical therapists that specialize in this. And so they're actually kind of hard to find in Tucson, but fortunately we have some colleagues up in Phoenix that do virtual visits. So for my patients who are just starting to experience any sort of spontaneous or surgically provided recovery of function, I send them out with a handout of exercises to get them started, and then I connect them with some of our specialized physical therapy colleagues up in Phoenix. So what are the options for dynamic reanimation? One of the mainstays these days is the mesenteric to facial nerve transfer. And so this is kind of an older procedure. It's been around for a while, but is probably one of the most popular go-tos for a few reasons. So the way this works is we dissect out the nerve to the masseter muscle in the subzygomatic triangle, and then we divide it and transpose it out and coapt it to a dominant buccal branch that's, if it still stimulates, you want to identify as being the primary nerve responsible for lip elevation. And so we say facial reanimation and dynamic reanimation, but oftentimes, the one part of the face that we're focused on is reanimating the smile, being able to elevate the lips and the oral commissure to support the mouth for eating, for speaking, but also for facial expression. So some of the benefits of the mesenteric nerve, so this is a relatively robust nerve in terms of axonal throughput. So compared to some other donor nerve options, you get a decent amount of oral commissure excursion. So the amount of smile that you get is hard to beat. It's also anatomically right next to where you find this buccal branch that you typically want to coapt to. And so this avoids the need for an interposition graft. Every time so if you were to use like a jump graft or an interposition graft, let's say greater Rick or sural nerve, the estimate is that every coaptation like this, every neuroorrhaphy you do, you lose about 50% of the potential axon growth through that junction. And so if you can directly hook up your donor nerve to the recipient, you get a lot more axonal throughput. And then lastly, there's little to no donor site morbidity. So things like TMJ or masseter atrophy really aren't a thing. So people can kind of lose this nerve and go on functioning just fine without it. And so I should note that the movement that you get from this nerve is purely voluntary. So what happens is these patients have to bite down and voluntarily, do that whenever they want to smile and elevate their lips. And over time with training, you can actually kind of, learn to spontaneously do that every time you smile. But if someone tells you a funny joke or, someone tickles you, that spontaneous smile is not going to translate over until you voluntarily bite down and activate that masseteric nerve. Second popular option is the hypoglossal nerve as a potential donor. So over the years, there's been a bunch of different ways that this has been described. The first instance of it, they actually just transected the whole nerve, swung it up, and plugged it into the facial nerve. And as you can imagine, there was pretty terrible morbidity associated with that in the form of hemi-tongue atrophy and pretty severe dysarthria. So the way this is popularly done now is that there's an incision made on the side of the nerve after the branch point of the ansa. And this incision usually goes through about 30% of the caliber of the nerve is what you want to aim for. And at that point, you can use either a jump graft to coapt to the main trunk or a distal branch of the facial nerve, or you can actually transpose the entire infratemporal portion of the nerve down to meet the hypoglossal directly. So there was a meta-analysis that was done last year comparing hypoglossal and masseteric nerves as donor nerves. And in short, they both achieve about the same amount of oral excursion. The main differences are that you get better resting tone with the hypoglossal nerve, so there's better resting symmetry. But typically a longer time to initiation of movement. Probably because there's less distance traverse, you completely avoid this jump graft if you end up using the masseteric nerve. And of course, in general, the donor site morbidity, even though with this technique is lower, is still not zero. So there are patients who still get some level of tongue atrophy and dysarthria, which is important to consider. So what about for the patients who have been paralyzed for more than a year, let's say even 2 years out? So now their native facial musculature is just not usable. The gold standard treatment for that nowadays is a gracilis free muscle transfer. So this is a free flap of the gracilis muscle from the inner thigh, and we perform microvascular anastomosis to donor vessels in the neck. This muscle is typically fixated to the deep temporal fascia at the temple, and then the musculature of the oral commissures, the medialis, as well as the upper and lower orbicularis oris muscle. And so as shown here, it provides unidirectional movement to create that same lip elevation as some of the native facial musculature would do. So it's mimicking what your zygomaticus major and minor would do. And so the choice of donor nerve is variable for these free flaps. So what you plug into this obturator nerve that goes into the gracilis can really vary, and there's tons of stuff in the literature about this. So masseteric nerve, again, is one option. You can do a cross-face nerve graft, so an interposition graft, usually from a sural nerve. It's the only donor nerve that's going to be long enough. that's easily accessible. And that hooks up to a contralateral buccal branch on the functional side of the face. And so, and of course, hypoglossal is not shown here, but that's also a donor nerve option. All different studies kind of comparing the efficacy of different donor options. One of the benefits of the cross-face nerve graft is that you get spontaneous movement, right? Because it's hooked up to your other facial nerves, so every time you want to smile on the other side of the face, that signal comes across the gracilis. But because of the distance that you have to traverse, the multiple neuroorifices, as well as just the smaller caliber of the contralateral facial nerve, you don't get as much axonal throughput. And so the amount of excursion that you get is much less impressive. So your mouth doesn't move as much. With the mesenteric, it's kind of the opposite problem. You lack that spontaneity, but you get much better excursion. And so there's a more and more trend to kind of do these reanimation procedures with dual innervation. So using both mesenteric nerve and cross-face nerve grafts such that you can achieve some level of spontaneous movement as well as the tone and excursion from the mesenteric nerve. Also a lot of controversy in terms of whether to do the surgery in one or two stages. And so axons, through a nerve, even after you kind of hook it all up and sew it together, new axons grow through at about 1 millimeter a day, depending on the caliber of the nerve. And so it takes months for live axons to kind of regenerate through this nerve graft and actually reach this muscle. So one way to do the surgery is to actually place this nerve graft first, let it neurotize so that the tip of it is hot, so to speak, so that when you plug it into the gracilis, there's less time that it takes to actually innervate the muscle. That does take an extra surgery, and so a lot of times surgeons will do this all in a single stage, and we don't really know yet what the best way to do it is or what the right answer is, but hopefully we will in the years to come. So this is a patient of mine who underwent a single stage dual innervation gracilis free flap. So she suffered an iatrogenic injury to her entire facial nerve, affecting mostly the lower divisions. And so you can see at 5 months post-op is when she started to have some function and contraction of that muscle. So you can see that resting tone and symmetry is better on her face. And then she's starting to get some excursion when she bites down. So this is something that, again, requires physical therapy and training to kind of optimize the timing and the amount of excursion that you get. But you can see in the video here, when she bites down, you can see the timing is off relative to the other side, but she's starting to get that subtle contraction of her commissure. This is a pretty cool report that just came out of the Cleveland Clinic. So one of the drawbacks of all of these reanimation procedures that we do is that they're really focused on one part of the face, right? Just elevating the lips and creating smile. And so what that is lacking oftentimes is what happens with the natural smile, which is contraction of your orbicularis oculi. So what's called the Duchenne smile or a genuine smile. One of the ways that you can kind of pick out, unconsciously a fake smile is if someone smiles at you with their mouth, but not with their eyes. And so this is the first report of essentially a multi-vector gracilis muscle, which is harvested and dissected out along with its individual kind of innervation and vascularization to each subcomponent of this gracilis muscle. And so 2 of these vectors are hooked up to the orbicularis and the medialis to create that smile, and that's been described before. But that 3rd vector is actually used to create movement underneath the eye. And so it's I don't have the video here, so it's on the Cleveland Clinic website. If you have some free time, I definitely encourage you to check it out. the surgery is pretty wild, and the outcome is pretty amazing as well. I also want to emphasize kind of the importance of static reanimation procedures. And so, there are patients who get dynamic reanimation who need better resting symmetry. And that's actually better afforded by static reanimation procedures than with something like a nerve transfer or a gracilis free flap. And then there are, of course, patients who aren't candidates for a free flap or even local reanimation options using the temporalis muscle. And so this is a lady with a complete paralysis from a skull-based tumor on the left side. We did the typical reanimation procedures. This is pre-op, obviously, but we did the typical reanimation procedures for brow lift, placing an implant in her eyelid, doing a tarsal strip to address the ectropion. And then one of the mainstays of lower face static reanimation is fascia lata sling. So we take fascia lata from the lateral thigh. There's different ways that have been described to do this. My preference is to kind of use multiple pieces of fascia lata to focus on elevating different parts of the face. So I'll typically use 1 or 2 strips to support the oral commissure and the epididymis, and then a wider strip to support the melolabial fold and recreate that fold. And so she was unfortunately not a candidate for any dynamic reanimation, but you can see with just the static sling and the eye procedures, her resting symmetry is a lot better from those procedures. And so there are patients, most of the patients who have Bell's palsy will go on to recover completely, spontaneously. And so this is a lady who had very nice functional recovery from a Bell's palsy, which was a complete paralysis. And if you look at her like this, you probably can't tell which side was affected. But then every time she moves her lips, her eye closes. And so this is one of the common sequelae of any sort of spontaneous facial nerve recovery, which is facial synkinesis, whereby the axons that regenerate essentially, the wires get crossed. So when your brain says, purse your lips, your eye contracts. And as you can imagine, this is not only bothersome from a cosmetic standpoint, but if you're talking on the phone or talking to someone while you're driving and your eye closes, it can have a lot of functional consequences as well. So we've been talking a lot about the symptoms associated with a flaccid facial paralysis, all of these things that we've kind of touched upon. But there's this whole other side to facial reanimation and facial paralysis, which is what to do with patients who have recovered but have had aberrant recovery of the nerve. So this is a non-flaccid hyperfunction that's the result of facial paralysis. And so this causes synkinesis and causes things like involuntary eye closure, a constricted, immobile oral commissure. So what happens is you have all these different muscles that hook up to the corner of your mouth that let you frown, smile, pull your mouth sideways. And when you get aberrant recovery and synkinesis, all of those muscles are activated at once when you try to smile. So you kind of have this tightening, this pursing of the corner of your mouth without any real movement. You can also get involuntary facial twitching, and some of this can be painful too, especially over the cheeks and over the platysma on the neck. People can get really bad pain. So our armamentarium to treat these issues is actually a little bit more limited. And so the mainstay of treatment for synkinesis now is botulinum toxin, Botox injections in conjunction with facial nerve physical therapy, which I'll get into a little bit more in just a second. And as we know, Botox is temporary, right? So it can be a blessing. If you really hate the results, it's only going to last 3 months. But if you get a really excellent result, unfortunately, it's going to only last about 3 months. So to create some more lasting results, there are some other surgical interventions that have become kind of newly or recently popularized that I'll talk about briefly. So in terms of Botox injections, this is kind of an example of an injection map for a patient with facial paralysis. Typically, these patients will require much more extensive injections than anyone getting cosmetic Botox. So this involves asymmetrically dosed injections of the forehead, the brow, around the eye, possibly with injections medially over the eyelid on the affected side to counteract that periocular spasm that we see. For the lower face, a lot of these injections are targeted at kind of alleviating that tug-of-war phenomenon that happens between all of the different facial muscles. So we'll target the buccinator and the depressor anguli oris muscle right here, and also the platysma, which are the main components that are kind of driving the lip down when you try to smile so that you can actually get real lip elevation. Mentalis injections to address spasm here. And then the other thing you'll commonly see with these patients is that when they smile, not only does this lip go up higher, but the amount of teeth that you show on this side, on the unaffected side, is much greater as a result of more lip depression on the unaffected side. So you'll see a lot more teeth on this side than this side. So one of the things we'll do is we'll also inject the depressor labii inferioris on the unaffected side to kind of create more symmetry in that amount of dental show. And so some of the surgical procedures that are available to mimic some of the effects of the Botox, but in a lasting fashion. So this is a DAO, depressor anguli oris myectomy. And so the way this is done is essentially it's intraoral. You dissect out the DAO muscle, you kind of clamp it off, and you resect a certain length of it, ideally 1 to 2 centimeters, so that it doesn't grow back together. Pretty quick outpatient procedure, and the amount of difference it makes in oral commissure excursion with smile is pretty notable. And then something that you've all probably heard of is a modified selective neurectomy, which has really just become more popular in the past probably 5 to 10 years. So this is a procedure that uses a traditional facelift approach, initial subcutaneous dissection, and then transitioning to a subsmass dissection with incision through the platysma. And what's done here is you basically trace out all of the distal branches of the facial nerve and the parotid mesenteric fascia. You stimulate them to see which part of the face they move, and you selectively resect the nerve branches that are contributing to involuntary depression of the lip. And so typically those would be the cervical branch to the platysma. You actually keep the marginal mandibular branch, so you maintain lower lip function. You keep 1 or 2 buccal branches so that you still have, you maintain your oral competence. But the main target of this surgery is those buccal branches. So sort of any extraneous or redundant buccal branch, you end up resecting. And it's almost a little counterintuitive. You're cutting away more functional nerves. But the improved function that people get, again, from alleviating that tug-of-war phenomenon is very impressive. And so that's all I have. It's I think facial reanimation is a really, it's something that's exciting, especially in this day and age when we're constantly finding new and better ways to care for these patients. And it's also something that's incredibly rewarding. So even beyond kind of addressing the functional issues, a lot of these patients will come in for their initial visit, just devastated and tearful, and to be able to kind of restore not only function but kind of their sense of identity when they're looking in the mirror can be really gratifying and really awesome. So thanks so much for your attention, and I'll take any questions.
When you respect the labial depressor, do they bite their lip afterwards when they're eating?
So I haven't found that, and probably just because there's still redundant function from the buccinator and the other facial muscles. So it's something that I see very frequently with people who have a flaccid paralysis where nothing is working, but just taking out the DAO, I haven't had that issue. All right. Yeah, go ahead.
For a new patient to your clinic, are there any labs that you would check to rule out other causes? Or do you just traditionally rely on like an MRI to rule out intracranial processes?
So I typically just do the MRI and then Lyme screening labs. All right, thanks so much. Thank you. So next up, we have a talk by Dr. Fred Mennick. There he is. So Dr. Mennick is, of course, well known for his contributions to the field of nasal reconstruction. So we're just going to pull up his talk here.
My pleasure to talk to you. I'm not going to emphasize technique. I think the most interesting thing about things we do is why. Make some sense of it. That's always been my problem. So that's going to pop up. Should pop up in just a second.
Let's see. Oh, yeah, absolutely. Yeah. Let's see. I think it's, you know, it may be a little slow because we're loading from the USB. So let me copy it over and then I'll delete it afterwards. I'm sure you have photos in there.
What the hell do you do when someone comes in who doesn't have a nose? You know, kind of a cosmic question. You can't rebuild it, so what can we do? Getting it healed, filling the hole, getting something transferred, a named flap, baloney, usually looks terrible. That's because it's impossible to rebuild the normal face. The donor materials aren't like donor tissues. Gilly said like for like. There's nothing very like for anything. Only thing about a forehead flap is it's got a good skin quality. The defects vary in site, size, dimension, position, complexity. We've all been trained and we have some experience, but you can't know everything. And things always go wrong. There's always imperfections in planning, design, execution, wound healing. Complications always occurred. What a mess. And then we look at some patients that come in and you scratch your head. Why here and why not there? These two patients came to my office. Both had a similar defect initially. The man on your left had had a forehead flap with a big skin graft on his forehead to cover a defect of his bridge, tip, part of the ala, part of the cheek, and had a recurrence. The man on the left, on your right, had a exactly similar defect. Both had a forehead flap. Why did one turn out well and the other not so hot? Well, you have to ask yourself, well, what's normal anyway? Now, is it proportion in mathematics? Probably not, doesn't help much. I can tell you how long a nose is, not going to help you that much to build one. Is it artistic vision? This young surgeon certainly could paint a beautiful woman at 15, but something happened when he grew up, because it went to hell. It turns out that's where the facial units come in. Their characteristics area of skin quality, outline, and contour that allow you to create a mental picture in your sense, what looks normal. Now, we spend most of our time, especially as residents, well, how wide is it? How deep is it? My God, let's get out that measuring ruler. Doesn't help you much. Because you have to ask yourself, what's really missing? What needs to be replaced? But unfortunately, the wound doesn't reflect what's really missing. This lady had a spindle cell carcinoma removed, total excision of her nose, upper lip onto her cheek. That wound is now swollen and enlarged by edema, gravity, tension, and local anesthesia. That wound doesn't tell you what's really missing. She had an immediate repair, which is now distorted by old flaps, grafts, and scarring. Crazy idea to do an immediate repair in a patient like this. One-stage forehead flap, all that's crazy. But if you look at her post-op, what the heck was the defect? Who the heck knows anymore? It all falls apart. Now it's contracted by scar. That doesn't reflect at all what it looked like on the operating table, let alone what the true defect is. I'm out of order here because I'm looking at the wrong thing. And then she comes in again and sees another surgeon who does a free radial flap, which is a good idea for the lip, and a latissimus dorsi that's skin grafted. Now it's distorted again, and she shows up in my office with this looking halfway dead skin graft. What do you do now? What is the defect? So you have to ask yourself, what can I do to better understand the defect? And we'll go through that a little bit more. But that's exactly why I do everything under general anesthesia. I don't want to inject local anesthesia and balloon things up. And I don't want to inject epinephrine in my local anesthesia or a lot of local anesthesia because I don't want to balloon everything up and turn everything white so it all looks dead. Shan Baker's a terrific surgeon, but I would look at his book and everything had so much local anesthesia. And I couldn't sleep at night because it all looked like it was dead at the end of surgery. It was all white and mottled. It all lives. He's great. But I can't live that way. So what should be replaced? This lady had a superficial skin loss over her right tip and part of her ala. The solution by her surgeon, supposedly she went to sleep, I'm going to give you a forehead flap, but something crazy happened instead. He excised the underlying alar cartilage and the lining as a wedge, and then closed the defect primarily and put a partial skin graft externally. Crazy idea. You have to put back what's missing or you distort adjacent tissues. I made a paper template of the residual right ala and a template of the residual left normal contralateral nose, and then subtracted the right residual ala from the left hemi nose, and that told me exactly how much tissue needs to be replaced. So then I design it, recreate the defect, open the wound, place a forehead flap with the correct nostril margin border and width, and place the flap. So we have to replace tissues exactly, return the adjacent normal landmarks to their normal position, and put them back in exact dimension and border outline. How do we determine the size, outline, and position of grafts and flaps? Well, that's where the templates come from. I remember taking a piece of glove paper and slamming it down on a wound, and that's how big it is. Baloney. What you can do is make an exact template of the contralateral normal or use an ideal template. This lady has a full thickness defect of her left ala. I don't know, now that it's contracted, I don't know how much skin she needs to be put back there. But I do know that her right ala flipped over is the exact amount of skin with the exact amount of border contour as the normal left. So I can place steri strips, I can do markings. I can place 1/4-inch steri strips. I cover them with collodion. Your hospital may not let you. Some people use mastisol. I prefer collodion. And then I pull that tape off, and you'll find that the ink of her marking pattern sticks to the inside of the collodion. I can trim off the excess, cut a foil pattern, and that is the exact size, but very importantly, the exact border outline as her contralateral normal ala. You kind of get that, yeah. Or this lady, she's got a tip defect. I'm going to excise that as a subunit, and we'll touch on that, but it's marked out with ink. I can help myself a little bit. I'm going to put a tip graft there to restore her lost tip cartilage. I can make a little folded piece of surgical foil again, add a faux tip graft, and then place steri-strips over my markings. In this instance, there's the size of an outline of the subunit of the tip and a little bit of dorsum. I trim that off. Now, if it's a convex tip unit, you have to cut that along the border to make a 3D cupola into a flat pattern. But I can use that as a pattern to restore her lip, to restore her tip. Or this lady, she's in the operating room after multiple rhinoplasties and filler injection in the nasal tip with necrosis. I've seen a lot of that in my practice. I can take a piece of bone wax. I know what a normal nose looks like, more or less, what a cosmetic rhinoplasty would look like. I place my markings. I take some bone wax and sculpt a little bit of the tip I want. I'm hoping for it. Then I make my paper template, which now has been trimmed and laying over it. I make it flap. I restore the nasal tip cartilages and place a dorsal graft and use a forehead flap based on that design with a little bit of checking, because I have to have made my cartilage grafts comparable for that nose to improve the result. Or this lady, filler injection in the right nasolabial fold caused necrosis of her nose. What needs to be replaced? Well, I can make a pattern of the left hemitip, which is relatively normal, and a pattern of her left ala, which is relatively normal. I can flip this over twice to make my tip unit and then make my alar unit. That's the amount of skin that needs to be replaced after I recreate the defect. And then there's a universal pattern. You've made a nice nose. You don't have a contralateral normal. You've replaced lining if necessary, cartilage grafts if necessary, but you need to restore the skin surface. The normal pattern for a forehead flap should be a design like this. They don't come around like so. If you make an 8 centimeter pattern like so, crimp it and shape it and trim it to fit your nose, what you corrected on the table, you've got yourself the forehead flap that you need to ideally trim and fit it and flatten it on the forehead. What should be replaced? Very small defect, in this area, repaired with a nasolabial flap after several revisions. It looks like a patch. Why does it look like a patch? Because this little flap, which always pincushions like crazy, looks like a blob in the middle of a normal ala. Well, it looks that way because skin grafts may not have a great blood supply or unpredictable texture, but they don't really shrink much in the face, and they do not pincushion. Where flaps do pincushion, even though they're highly vascular and have good color, which makes a big difference and affects how we should repair defects. And that's where the subunit principle comes from. For convex defects, only the tip and ala. You should consider altering the wound in size, outline, and depth, throw away something if necessary, or narrow it if necessary to respond to a subunit. Discard adjacent normal tissue within the subunit, make it bigger, and resurface the entire unit rather than patch the defect if it's a flap, because that harnesses pincushion. The roundness of the pincushion flap looks like an ala rather than a meatball within an ala, and it hides the scars in the periphery between units where in the shadows they're much more difficult to see. They're almost invisible. Patient from a long time ago was at the VA hospital here. I did an excision of a basal cell from his right sidewall and a partial excision also of his left ala. I didn't really trust the pathologist. I thought I'm going to wait for permanent section, so I just put some ointment on it and a Band-Aid and have him come back in a few days once the past is negative. And then I decided skin grafts don't shrink much. They can be a little imperfect in color and texture and shiny, but that's exactly what the sidewall basically is. But flaps to resurface his ala do pincushion. So I used a preauricular skin graft for his sidewall, non-subunit, just patched it, and then I threw away extra normal skin within the ala to resurface the entire left ala with a 2-stage nasolabial flap, which I probably wouldn't do anymore because I don't use nasolabial flaps much. But the skin graft is healed smooth and flat like it's supposed to in the sidewall, and the ala has pin-cushioned up and blobbed up just enough with the help of a cartilage graft to make it look more like a normal ala and not like a patched blob. Or I have a tip unit, a tip defect, partial defect of the tip. The best thing to do is do a subunit excision. I excised all the skin within the tip subunit after the markings, and then resurface that with a forehead flap in 2 stages. Scars are mostly invisible, and the roundness of the flap has only contributed to a fairly normal looking tip. Another patient of mine, I thought I was quite smart that day. I made my marking so beautifully. I did a subunit excision, but I didn't really follow the marking on this side. That's not symmetrical, and that doesn't really lie within the border of her normal tip unit. So I've done an imperfect subunit excision, and that border scar is much more visible. It would not have been if it just lied as the opposite side, but this is a scar within the tip. My mistake. Adjacent cheek and lip loss. Well, the nose doesn't float in the air. It sits on the lip and cheek. And frequently defects are composite in the sense that they overlap 2 or more facial units. You've got the nose with some lip, with some cheek. And that delicate angle needs to be restored during a nasal reconstruction. You don't want to put a single flap in a large hole of the cheek and lip, because the nose sits in a cheek and lip platform in a specific position and projection. All these patients have poor nasal platforms for nose reconstruction. You can't build a nose on this cheek platform. This is a free flap, but again, poor cheek platform, no cheek platform after a forehead flap. What you don't want to do is build a nice nose on a cheek or lip that's not stable. Tension, gravity, edema drag your new nose usually down and out. So you have to build on a stable platform. Now, if it's a superficial defect, this is just a skin defect, really no substance lost. You can do it all at one time. In this case, made an incision in the nasolabial fold and advanced the lip up with a dog ear excision here, so that closed the hairless triangle and restored the nasolabial fold. I can advance the cheek, and I did a subunit excision of the ala with a 2-stage nasolabial flap and a primary cartilage graft. Now, you can do that in most circumstances. It's superficial, it's not deep, it's not that large, there's not that much tension. But when a defect like this comes in, which extends down the bone and a little bit of muscle, but a lot of subcutaneous fat is all missing, you should rebuild the platform first, in this case with a small advancement of a cheek flap with a nasolabial excess extension taken from here. Then I can come back at another day, my pattern of my upper lip, patterns, templates again and again and again, make a pattern of this side, flip it over. That's where the inset should be, pattern for the tip, pattern of the lining, and we now have a nice nose and a nice platform. What materials? Well, for small superficial defects, we're usually thinking local flaps matching local skin, but I see a lot of bilobe flaps with the ala pulled up or the nostril pulled over. I don't use them anymore. I see a lot of additional scars on noses. Lots of times, I wrote a book with Gary Burgett years and years ago, and we promoted bilobe flaps. You see some terrible scars at times. And they pin cushion. Skin grafts, no additional skin scars, no pin cushioning, and no distortion of adjacent normal landmarks, although they can have an imperfect skin quality. So what I do for superficial defects is a full thickness forehead skin graft. This is a different technique than preauricular, postauricular cervical skin, quite different. It has the quality of forehead skin and nasal skin. It has the fibrous bands within it, and they can take very, very, very well with almost no donor deformity. Really the secret in my mind is Mohs defect, I don't do anything. Go home, ointment, come back in 10 days, we're going to place a skin graft once it's granulated. So all those, what that Bovie-burn barbecued hamburger that comes from the Mohs surgeon after he's tried to stop the bleeding, let it all heal, let all that scar tissue spit out, charred tissue spit out. Let it revascularize and scrape that off and put a full thickness forehead skin graft. From here, close it primarily. This is she months later. Little pale, but there's not a woman in the audience here who wouldn't take a nicely shaped nose with no nostril deformity and a lot of scars on your nose if she could only put a little makeup on it. This lady, little pale, put a little makeup on it, days are over. This woman, not always this good. This is sheet about 6 months. This is sheet a year. Really a terrific technique. Short, sweet, simple, no complications, no contractions. Works like a charm. Now, large defects. Usually we're going to do a regional flap from the nasolabial fold of the forehead flap. Done a lot of two-stage nasolabial flaps. I don't do them anymore because I don't see any advantage to them. These are both patients of mine, both had a defect of the ala. This lady was repaired with a nasolabial flap. This lady was repaired with a two-stage forehead flap. So they both had two-stage operations. They both have good results. The forehead flap patient is so much better. The scar, virtually invisible. The donor side, even on old people, this is halfway normal, but it doesn't match the other side. And you can do all the excisions that you want on the other side. It never matches. And every girlfriend of hers, when she comes for bridge, sees something going on here, even though the nose looks good, and starts staring and staring and staring, and tracks her way back like an ant to the nose reconstruction I did, which is never perfect. So it just draws attention to itself. I don't see any reason to use them, and I used to love nasolabial flaps. Now, what surgical stages? The traditional is a two-stage forehead flap for small, and I would use it for small superficial defects, single unit and the underlying soft tissue, no cartilage. So we kind of saw this patient before, subunit, excision, here's my subunit excision, here's my forehead flap. I always skin graft the donor with usually groin skin, primary closure. And then I can come back and divide the pedicle. And these are very hardy, and it was a little too bulgy here and here. So I lifted it also up on the sides, lifted it thinly, sculpted out the soft tissue, tacked it back down, trimmed any off any extra, and here's her result. But you can't get from here to here with a two-stage forehead flap. With or without free flaps and all those other things, you just can't get the real perfection of looking normal in a complicated, deep wound missing cartilage and lining that's large in 2 stages. So I'm going to transfer a full thickness forehead flap in 3 stages in large, deep defects that encompass multiple subunits, cartilage and lining missing. And it's a 3-stage flap with an intermediate operation. All these cases, any real nose reconstruction needs a late revision. But it's a full thickness flap taken right off the periosteum, frontalis not excised under most circumstances. Because I can create an ideally thin skin flap and sculpt a perfect 3-dimensional contour. Patient with a defect over her tip and bridge, she has an old composite skin graft and other skin grafts over here. So I elected to fix her entire nose and restore lining on the left. So I did a subunit excision of the inferior nose, hinged over her old composite skin, placed primary alar battens, full thickness flap, brought it down, no thinning, and here's her flap. 1 month later, of course, this is all done in general anesthesia. 1 month later, the forehead is beginning to heal. I can lift that forehead skin up much more safely. This is actually a delayed flap now because it's been hanging down here. Lift it up thinly, leaving most of the fat. Here's the bulk of frontalis and fat. Sculpt that off and put the forehead flap back down. And then I can divide the pedicle, and in 3 stages without a revision, although I would probably in many cases do a revision to improve the alar creases. The forehead heals secondarily without a problem, and we've created a much better contour than I think you could get in 2 stages. And what does that intermediate operation do for you? It most importantly, equally importantly, allows you to correct imperfections, because nothing is perfect in this world. There's nothing that much like a forehead flap than its skin cover, unlike. You design it wrong. There's gravity, there's tension, there's malposition, the scar contracts, the flap recoils. So what do you do now? Well, here's a patient we addressed before. Radiated lip and total nose. She had a radial-free forearm flap for lining, and then came back and excised the external surface of that and placed additional cartilage grafts and a full-thickness forehead flap. I'm a pretty happy camper. But after her forehead flap transfer, the nose is bulky, the tip shape is poor, she has a low dorsum, so my imperfections, healing imperfections, not as much as I'd like. But it's not a problem, because I've already told her we're going to do an intermediate operation to sculpt this. I take the flap off thinly, I sculpt off the excess, I add a condylar cartilage graft. I hadn't saved enough rib, but it's sutured down flat, and I add a pec tip graft, rather a sheen type tip graft, after subcutaneous sculpting to get to here. That intermediate operation adds a tremendous opportunity. My father was a general surgeon. I actually hated, he would say as a kid, distasteful to me. Chance to cut is a chance to cure. Sounds like a typical general surgeon telling all the internists you stink. That's the old days of medicine, you younger folks. Chance to cut in this kind of surgery is a chance to cure, get a better result. Now, how to restore contour? Well, we're mostly talking, if I ask the resident, how are you going to restore contour? Cartilage grafts, ear, septum, etc. And obviously true, you need to support the nose and shape it, embrace it if you're going to make a contour and control gravity and tension, etc. And that's where subunit grafts come in. That's one of the big changes in the last 30, 40 years. You place little pieces of cartilage that have the shape of each unit under a forehead flap, so that when it's seen through the contoured overlying skin, it looks like a normal tip, even though it's not a normal alar tip or sidewall or alar. As in this lady with a multiply operated AV malformation, excision, lateral spreader grafts, columnar strut, alar battens, with a forehead flap, that's what gives it a shape. But what I think we've missed over the years is that what makes things look normal is shape, not scars. We forget the soft tissue shape. This lady came into my office saying she'd had an excision and wanted an improvement in her reconstruction. And I looked at her for a second, and I certainly thought to myself, gee, throw out some skin, do a forehead flap. I tend to come in my office, that's what you get. At the same time, I looked at myself and I said, she has enough skin, what she has is poor contour. Why can't I just improve her soft tissue shape and maybe put a small cartilage graft right here, which had never been placed, which was allowed a notch? She has a scar basically here. I opened up the old scar, disregarding her, disregarding the scar, just opened it up, lifted up the skin thinly, and then sculpted out the fat of the cheek, so a flat side wall and a more slightly full but softer cheek. And I placed a small secondary cartilage graft here and advanced the skin forward with some deep and superficial nasofacial sutures. And then I came back about 6 weeks later, made a direct incision to refine the alar crease and trim the rim a little bit. I really didn't do much to that lady but shape the underlying soft tissue so it looked like a nose. Or this lady came into my office with a small Mohs defect, really small. Could almost let it heal secondarily. I would be thinking full thickness forehead skin graft. But then what really caught my attention once I looked at the hole was, what's this? And I said, what happened here? She really didn't know, but it became apparent that she'd had a previous basal cell. This was probably a recurrence. And they had advanced her cheek onto her upper lip. So this is not her nasolabial fold. This is advanced cheek onto her lip. And what a horrible scar. Well, if you're thinking a little differently, why not recreate the alar crease to bulk the lip and put a small skin graft on the defect? So I took a pattern from the opposite side, flipped it over. That's where her alar crease, nasolabial fold should be. Here's the old scar and hatch marks. Made a direct incision, made a new scar on her face, lifted the skin up thinly and excised that excessive bulk. Tacked it down with 48 hours of percutaneous quilting sutures, excised a little bit of skin here and placed a full thickness skin graft. I think she looks good. But the interesting question is, what happened to this scar? I didn't do anything to that. I didn't touch it. I just excised the soft tissue that was piled up here, and by restoring a fairly normal nasolabial fold, restored the subunit appearance of her lip. And in many reconstructions, another subtotal defect, another radiopharynx flap, another forehead flap. Here's his result after pedicle division. Good, but it looks bulky. Disregard old scars. Scars are not what makes things look bad. Disregard old scars and do a direct subcutaneous excision. You can't lift these flaps up and kind of sculpt them from the inside. It never works. To make a distinct nasolabial fold exact, I made an incision in the flap itself, added a scar, and in this case, elevated part of the forehead flap from the sides and sculpted each side flat with a deepened alar crease and a few subcuticular stitches to tack that down. That is a different nose. This is a good result. That's an elegant looking nose because the bulk is right, the shape is right, and he has an alar crease. So we have to ask ourselves, what is deformity? Is it scars? Is it bulk? It's certainly not scars. She has normal subunit appearance. She has normal dimension, volume, position, projection, and symmetry by putting together a whole bunch of unlike tissues like forehead flaps and radiopharynx flaps and cheek flaps and lining flaps, etc., to rebuild. It's the skin quality, border outline, and 3D contours that make things look good. And I thank you very much. This information, if you're interested, is in a book published a few years ago, available online, etc. Are there any questions? Yes, sir. Excuse me? I do. I usually do it under light MAC, and I'll make the wound hasn't contracted at 10 days, so I can make a little template. Of the amount of skin that needs to be required and scrape that off. I can harvest my forehead skin graft from right under the hairline, and you can always close it primarily, usually about 1.5 centimeters. Place the skin graft on with peripheral sutures. I use 6/0 plane, and I will put some sutures through the skin graft into the bed and back out again as quilting sutures of 6/0 plane as well. And then I cover it with a piece of adactive, a little sponge from the sink, you know, the yellow sponges, and take usually a 5/0 Proline, and just run it back and forth. I don't do the million little silks around the side. Just grab it on one side, over, and I leave it on for a week. I used to worry terribly about stitch marks. I don't see it. Haven't had a problem with that at all. They usually take beautifully. One curious thing, which I haven't seen in a long time, but in the beginning I have seen, sometimes they won't take perfectly. Very unusual. They usually take very well. But they're different than a regular skin graft. They don't get soupy and pussy and wet, a forehead skin graft. It usually takes well enough. It may get a little dry and maybe even a little dark and kind of an eschar on it. Leave it alone. Don't yank it off. Usually when it falls off, it looks great. Any other questions? Yeah, yes, sir. Yeah. Obviously, you're not going to take a 3 centimeter full thickness skin graft from the forehead, so it's a matter of balancing how much the injury to the donor site versus the injury to the improvement in the recipient site. It turns out most of these defects are about, most of the defects I'm operating on, 1.5, 1.8 centimeters. If they're a lot bigger than that, I'm probably thinking, if it was a large sidewall defect, I might take a skin graft from another donor site, but I would importantly delay it again as well and let it granulate. I think that really makes a big, big difference. Again, I use full thickness, I let things to heal secondarily at times. I use full thickness forehead skin grafts for smaller defects. I don't use nasolabial flaps except to maybe restore the lip. And I use forehead flaps for cover and lining and for most nasal defects with a subunit excision. People don't care what you do or how long it takes if they get a good result. And we don't appreciate sometimes how people don't like looking funny, and they may not complain about it, but they really don't like it. Yes, sir. I probably had, over time developed maybe a, unique practice, but, the number of, if you're at a university or VA hospital, I'm sure there's people that are still smoking and drinking like crazy. I must admit, I don't see too much of that anymore. But obviously, you're going to tell them not to smoke, you're going to tell them not to drink and fall down on their nose. Within reason, what I try to do is get everything as right as I can the first time, which includes careful observation, make a good diagnosis of what the problem is, plan it out really carefully, and literally, I will, long before the night before, go through the surgery in your mind, just like Gillies did. I just read a new book out on him. He would sit in his office thinking through what he's going to do for the surgery and then go in and do it. I'm doing it under general anesthesia without local, so things aren't distorted. I'm using exact templates, and I'm taking my time to fix and suture those grafts in, if they're cartilage grafts, etc. I choose techniques that give me a way out, like the 3-stage forehead flap. In other words, I know there's going to be an imperfection. Why would I want to divide the pedicle 3 weeks later, when I know there's always something you can touch up, and it's more safe in vascular terms, and I can understand the defect better if I do it in 3 stages, and I can make up for broken or misplaced or free cartilage graft or too much excess skin here, not enough there, etc. I do a late revision. Almost all of these cases need a late revision to trim the nostril or one rim's a little bit higher. And I choose techniques that give me a way out, like that radio-free forearm flap. If you do it the way I do it, you've got a lot of extra skin. So when it comes time to do the forehead flap, you can hinge something down. In my experience, if you get a good result, and then I do a late revision because I'm going to make the alar crease, unless you have a bad complication, you can use surgical staging to solve all your problems and get a good result. It's not as though it's all going to fall apart or it's all going to go to look like hell a year later. It sticks if you have good skin, adequate lining, cartilage grafts of the right size and shape with some rigidity, and you've done all the steps. It's, I think I'm pretty good at it, but you could be just as good as I am. I mean, anybody could. You just have to work at it and think about it. There's no, no really God-given grace other than you're willing to take the time and think about it. I thank you very much.
Thanks so much to all of our speakers. I think that's it for the morning session for facial plastics. I believe we have time for a little break afterwards, so feel free to grab some refreshments. Thanks so much for your attention.
Sorry, can you hold it right and deep breath. Now, are you exhaling? Wait. So can you? Okay, can you
Breathe through my mouth or what?
Yeah. Either way. Can you inhale? Exhale. Inhale. Hello, hello. That's good, okay. Good morning. My name is Helena Yip. I'm the director of the Voice and Swallowing Center here in University of Arizona. Welcome to Tucson for those of you that are coming from out of town. I think we put together a nice session for you on laryngology today. It will be myself and Dr. Kwang Sung from Stanford, as well as our two speech and language pathologists, Dory Smith and Natalie Monahan. So I've handed out some surveys on chronic cough to each of you. It's just kind of a study in maybe knowledge gaps in what's actually being practiced and what the best practices may be. If you could kindly fill that out, we'll collect that at the end of the laryngology session. So I'll start out. The program order is a little bit different. So I'll start out, and then Dr. Kwang Sung will be talking for the next hour and a half. Okay, so my talk today is on evaluation and management of subglottic and tracheal stenosis. I have no relevant disclosures. So a large part of my practice now is actually made up of subglottic and tracheal stenosis. Maybe 10 years ago, we're still patting ourselves on the back and saying what a rare incidence it is to see subglottic stenosis, since the ICU doctors are now so good in vent management. But COVID came, and Arizona was hard hit. And in the last 3 years, this has become a big part of my practice by necessity. And I've learned a lot in the process, and I want to pass it on to you. So with regards to especially subglottic stenosis, it can be divided into idiopathic and post-intubation. And idiopathic stenosis, the stenosis generally is membranous and short segmented. It is a very peculiar entity that's solely found in women, and it can be misdiagnosed as asthma for many years. It can be delayed in diagnosis for decades even. So we as otolaryngologists are central in the diagnosis of this condition, and it's based on a strong suspicion. These patients will often have a diagnosis of asthma, and yet they're completely refractory to asthma treatments. Now, for post-intubation subglottic stenosis, hopefully there won't be as long of a delay in diagnosis just because the preceding event is there. Now, the patient with a post-intubation stenosis will come with maybe a long laundry list of procedures already attempted, already done. They could come with a trach, without trach, or having been trach and having been decannulated, having been dilated multiple times, having been reconstructed in terms of a tracheal resection or criciotracheal resection. And they can have multiple levels of airway stenosis, including glottic, subglottic, and tracheal stenosis. And these stenosis often can be fibrotic, they can be long segmented, or they could have framework deformity. The leading symptom in these patients is dyspnea. It can present with noisy breathing, exercise tolerance, intolerance, and then this mucus sensation that is actually real. So in this case, you can see all this mucus getting caught on the shelf of stenosis. In a patient with a higher grade stenosis, this amount of mucus is sufficient to completely occlude the airway, and these patients need to cough to keep their airway clear. In these patients, I would certainly not want to suppress their cough because that's the only thing that's maintaining the patency of their airway. These patients will come talking in short, fragmented sentences simply because they get out of breath. In a patient with dyspnea, one should always elicit a history of prior intubations or maybe asthma refractory to inhalers. A question that I always ask with bated breath is, how do you sleep? Do you sleep in a chair or do you sleep in a bed? If they say they can sleep in the bed, I breathe a sigh of relief because now I know they can go to the CT scanner or they can undergo a DL. We can even attempt an intubation. prior to the clinic encounter, along with the intake form, it's helpful for a patient with dyspnea to be handed the dyspnea index, which is just a short questionnaire of 10 questions grading their symptoms from a grade from 0 to 4. This is a good way to quantify perhaps their improvement from intervention to intervention. Now, if you have access to a pulmonary lab nearby, or if you're in close collaboration with a pulmonologist, it's also helpful to administer spirometry, which will give you a set of data points, including peak expiratory flow, vital capacity, forced expiratory volume. It's still an aspirational goal for me to try to set this up in my own clinic. A cheaper and more portable option is just a peak flow meter, which measures peak expiratory flow. It's something that a patient can buy even on Amazon for $129. I looked it up. And they can record the even daily peak expiratory flow. For some patients, having that kind of a number, a log, is helpful in monitoring their symptoms. But an in-office evaluation is essential, obviously, in the evaluation of a patient with dyspnea. Now, most of us, when we look at the larynx, most of the time, you may not be able to see down straight the barrel of the trachea. In this case, I was lucky enough, I caught the entire subglottic stenosis by just looking from above. But usually, the shelf of cricoid will obstruct the view of the trachea. So that means you have to go to an in-office tracheoscopy. In-office tracheoscopy just needs a little bit additional work in the topical anesthesia. It's easy to perform. You can do a bilateral superior laryngeal nerve injections with lidocaine, and then you can administer topical 4% lidocaine with either a therapeutic laryngoscope or an Abraham cannula, as seen here. Now, if the patient cannot tolerate a tracheoscopy, then obviously you don't force it. And if the patient's pretty dyspneic, I would just take them to the OR for an examination under anesthesia. Or if the patient's known to you, and it's been a while since their last procedure and they're pretty dyspneic, then you could just skip this in-office tracheoscopy. Okay, well, how do you grade a stenosis? There's a Cotton-Meyer grading scale, which grades it from 1 to 4, but you need an ET tube to size the stenosis. But we could borrow the same concept of this grading scale. So grade 1 goes from 0 to 50, and then grade 2 goes from 51 to 70%, and grade 3 goes from 71% to 99%. But there's a lot of inter-rater unreliability in this grading system. So I pulled some pictures off of Dr. Robert Bashan's website on laryngeal pictures, and he rated this one at 35%, and I would argue that this matches up better with one that's 50%. And then he graded this other one as 50%, but I would argue that the 50% one looks more like a 75%. So you can see how visual assessment may be different from rater to rater, but you get the idea. When you look down the airway, if it looks narrow and the patient is not breathing well, then the next step would be OR. All right, well, there are some other crude ways to measure the stenosis. If you're using a distal chip tip scope in the office, these are the tip diameters. So a regular adult scope, which is VH, measures 3.9 millimeters, and then a pediatric scope, which is V3, measures 2.9 millimeters, and a therapeutic channel scope is at 4.9 millimeters. If you could traverse the stenosis, then obviously the diameter of the stenosis is larger than the tip diameter. Okay, so now that the patient is completely numbed up, why not also administer intralesional injection of steroids? If the patient is stable, if the patient is not in distress, if the stenosis is not very stenotic, if it's low grade or even intermediate grade, I think this is a good option. So for subglottic stenosis, you can go into the cricothyroid membrane. And then for tracheal stenosis, you palpate either next to the prior trach scar site, or you simply just press on the anterior tracheal wall until you see an indentation, and then that's where the needle would go in. So here I started out at the start of the stenosis, and then I injected some with Kenalog, and I withdrew the needle, re-injected to a lower site to catch the maximal area of stenosis. I'll just let this play a little longer. So at this point, if the patient can tolerate a scope in the trachea, they should be able to tolerate a needle in the trachea as well. So we recently reviewed our experience with in-office injections, and this was presented at the Triological Society a week ago. I had a series of 14 patients from the last 5 years. So for the low-grade stenosis, I want to get the laser pointer. For the low-grade stenosis, they were successfully managed with just primary in-office injections. For the intermediate grade stenosis, they were managed with a combination of endoscopic dilations and in-office injections. For the high-grade stenosis, in the idiopathic group, they were successfully managed with just endoscopic dilations and in-office injections. For the high-grade post-intubated stenosis group, despite multiple rounds of dilations and in-office injections, they eventually had to undergo a tracheal resection. All right, well, another note of caution in post-intubated patients is that they can often have multiple levels of stenosis. So if you see posterior glottic stenosis, perhaps it's not a good time to manipulate their airway. So I would not try to traverse someone with a very marginal glottic airway to do a tracheoscopy. Now, wait, let me stop this video first. And then if they already have a trach in place, then it's a different story. You could obviously safely traverse the glottis to look down. And here the patient has a posterior glottic stenosis, and then she's trach, and the subglottic stenosis isn't so bad.
This is actually not bad.
All right, well, some people like to get a CT neck and chest in the evaluation of airway stenosis. There's nothing wrong with that. But for me, I would prefer an in-office tracheoscopy simply because it avoids the radiation, it's quick, and the direct in-office view can give you a whole lot of information regarding the makeup of the stenosis, whether it's made of granulation tissue, or is it fibrotic, is it membranous short segment, or is it a corkscrew-like long segment. And it's also helpful in deciding whether or not to go to the OR that day versus next week. All right, well, dyspnea has a subjective component, just like nasal breathing. And I would say probably in patients with low-grade stenosis, anyone with less than a 50% obstruction, generally they're asymptomatic. The same thing goes for high-grade stenosis. Some people can have a pretty high-grade stenosis and yet not be very symptomatic. And the same is true for low-grade stenosis. Some people, when I take them to the OR, I wonder, why are we even here? They can still be extremely symptomatic. When it comes to tracheal stenosis, this is where we intersect with our pulmonary colleagues, and it's nice to establish a collaboration with our pulmonologists, as we often take turns taking care of the same patient. At the end of the day, it is still the patient that drives intervention for me. If the stenosis is low grade and the patient is stable, and the primary symptom is just simply activity restriction, I would say that affords you a lot more time. You can just use in-office injection maybe to try as a primary treatment. If the patient's in distress, it's a whole different story. Then I would usually admit them at least for a Heliox administration, plan to take them to the OR, consent them for an awake trach, but try not to do one if possible. Now you're in the OR. How do you safely manage the airway? As we are the airway specialists, in residency, I was taught to intubate and then suspend and then withdraw the ET tube and then do whatever you need to do under apnea conditions. Now, what size tube should we use? I would say probably a 5 ET tube. That should probably allow you to traverse most fibrotic stenosis. Now, what happens if it's not a fibrotic stenosis? You're dealing with a bunch of granulation tissue which can completely occlude the lumen and prevent advancement of the tube. So that's happened to me before. Okay. So I would advocate for the use of an LMA with a flexible bronch. This is my primary setup in the OR. This is a PGY2 holding the scope. So once you have this system in place, it affords you a continuous airway, and you can do all kinds of interventions through the flexible bronch. So the conventional LMA that an anesthesiologist hands you has these aperture bars. It's not showing up very well in this picture. In order for the flexible bronch to pass, they'll cut off these aperture bars for you, but it's not a clean cut. You're left with little corners of these remnant bars. And what could happen when you pass the flexible bronch is the bronch can then push these pieces into the airway. So I can still remember vividly a year ago spending an extra hour in the OR waiting for the pulmonologist to look for a clear piece of silicone in the patient's airway after this had happened. So we couldn't find the silicone piece. Nothing happened to the patient. But let me tell you, I'm never using that again. So the LMA of choice is something called the iGel, which does not have any aperture bars, is stiffer. Generally, a female will call for a 3, and a male uses a 4. And the LMA also has the advantage of allowing the patient to spontaneously breathe. The packaging looks something like this, but the orange is simply the casing. So you take it out, it looks like this, and then you should also ask for this connector, which has 2 stems, 2 little branches, one branch to be hooked up to the circuit, and the other branch has a valve that will allow for the insertion of your flexible bronch. So it works very well. Okay, so the pulmonologists in our institution are actually using rigid bronchs. And I would say for us, rigid bronchs have become a lost art since we're not doing nearly as many pan-endos as we used to. It can be done through the mouth or the tracheostoma. The advantage is that you can also have a continuous airway. Through the suction port, you can administer jet ventilation. With this, you can pass, with the main port, you can pass instruments. You can also use just as body or the stem of the rigid bronch to tampen out bleeding. Okay, so with the LMA, because of the spontaneous breathing, it's important to apply topical lidocaine before the start of any procedure to avoid laryngospasm. Okay, so in terms of sizing the stenosis, a very crude way again is to use the tip of your bronchoscope. So a diagnostic bronchoscope, the tip ranges from 4.9 to 5.5 millimeters, and a therapeutic bronchoscope is larger, is around 6 millimeters. And again, using the flexible bronch, you can also size, you can characterize the stenosis. It's nice on a first-time examination to document the length of the stenosis as well as how far it is below the glottis. So the flexible bronch, the channel bronch allows you to insert a laser fiber, insert balloons, insert needles. So you don't even need to turn the patient away from anesthesia. Here's the operator, here's the assistant inflating the balloon. Okay, so in terms of lasering, we've all seen nice pictures like this where you make stellate incisions and then you pass a balloon to dilate. I would argue that we don't make this cut on the posterior membranous wall because that is a party wall, and you could cause a tear, which then can translate into pneumomediastinum and sometimes even a pneumothorax. And again, I'm speaking from experience. So now we're just making cuts on the lateral aspects and the anterior aspects. So here's just a quick video on lasering. So the laser fibers pass through the channel scope, and then we're making cuts here. Okay, well, in preparing for the talk, I ran into this article that says you can make wedge excisions of these fibrotic scars. In my hands, the laser is a very slow working cutting tool. It's hard for me to imagine you can make these huge excisions. If it's a fairly fresh stenosis, maybe. If it's just purely granulation tissue, maybe. But I find this picture to be a little bit fantastical. Okay, so should we biopsy? The teaching is that if it's idiopathic, it's a diagnosis of exclusion, which should really rule out Wegener's. But in truth, it's very difficult to perform a biopsy on fibrotic tissue. And then once you get into bleeding, what do? It's going to take you a long time to control the bleeding. And the pathology result often will be inconclusive, just like biopsies obtained from septal perforations to rule out Wegener's. So I don't do them. And it doesn't really change the management. So cryotherapy has been performed by pulmonologists at our institution. It works quite well, I think, in the refractory cases. If the idea is to have minimal trauma to scarring, I think this is a very good modality. And then here is just a look at how all the smoke comes out from the line that administers the cryotherapy. In terms of dilation, there are different ways to do the same thing. Obviously, you could use a cuff from the ET tube. You could even use the Jackson dilators. You can use the bevel tip of the rigid bronch. But my preferred way is to use the CRE pulmonary balloons, which come with 3 predefined diameters. They come at different lengths as well. They work very well. Okay, so how do you dilate? Usually, I would say if the patient is not an extremis, you can laser first and then dilate. Now, if you think the airway is tenuous, I would just go ahead and dilate first and then laser, because that will afford you more time. If the patient has a trachea already, how do you dilate? You could theoretically just dilate along the ET tube that's placed through the tracheostoma, but to get the best result, I usually just withdraw the ET tube completely and then dilate. And sometimes if the trachea has this A-frame deformity, the dilation is mostly, oh, it got covered up, okay. So the dilation gets taken out by the posterior membranous wall. So you can have the balloon dilated to 15 millimeters, and yet it's not going to change the actual diameter of this deformed trachea. There's something called watermelon seeding, which is a term borrowed from cardiac stenting. It mainly just means that if the balloon is very snug, it has a tendency to slip. So you have to hold on to the balloon very tightly in those instances. As you get closer to the maximal diameter of stenosis, you know that this is going to be the workhorse of your dilation. So just make sure it doesn't slip and render your dilation not helpful. All right, well, how long should you occlude the airway for? The manufacturer says you can occlude up to 2 minutes. The anesthesiologist tells me that a patient can be apneic for 6 minutes, but I don't feel comfortable with that, especially in the post-COVID population. They tend to desat very fast. So I just do 30 seconds at a time. I don't have any basis for it. But the other worry I have is for post-obstructive pulmonary edema, where if a patient is actively breathing against, say, a closed glottis, once you release the obstruction, the lungs can suck up a lot of interstitial fluid. And how big should you dilate to? These are the range for female and male tracheas. I think usually what I'm dealing with at the starting diameter is about 5 to 6 millimeters. So if I could enlarge it to 10 to 11 millimeters, I'm pretty happy with it. And it usually makes a world of difference for the patient. There's no prize or no reward for the maximal dilation. In fact, I think if you dilate very forcefully, it can stimulate restenosis. So a picture like this is not what I'm going for. At the end of dilation, there will still be very obvious cuts, maybe clumps of stenotic tissue. So at the end of your procedure, you can inject steroids either through the neck or through your bronch or directly through the tracheostoma. So what about mitomycin C? That was all the rage 10 years ago, and I'm sure people still use it, and recent papers have come out still attesting to the efficacy of it. But since I'm doing in-office injections as well, mitomycin C is just hard to get in the outpatient setting. Peristomal subglottic stenosis obviously is of great interest to me, as all these patients would come to me begging for decannulation. If I see just a shelf of granulation tissue drape over the trach, that's actually a very positive, encouraging sight. I think as soon as you remove the trach, this granulation tissue will fall away and will become more flush with the trachea. So the intraop view you see here may be a little bit more exaggerated in terms of the stenosis than the actual stenosis. And then now we come to tracheal malacia, where the tracheal cartilage has sustained significant damage and is no longer providing the support. In a patient like this, these are not the cords, these are subglottic. This patient, no amount of lasering or dilation will help. They most likely will need either trach or tracheal resection. And then there's another entity called excessive dynamic airway collapse, where the posterior membranous wall comes up anteriorly, and that can also cause significant occlusion of the airway. Now, this phenomenon can be reversed if the patient addresses the comorbidities, including obesity and OSA. Now, what if the length of stenosis precludes resection? What if it's too long or it's too distal? Then at this point, you would have to tell the patient you need a trach, and then we'll use an XLT to stent. Now, why don't we use tracheal stents for benign lesions? Because it can propagate the stenosis, it can also migrate, and it can be very hard to remove. So this is a happy day where the patient has a wide open subglottis, and he or she's ready for decannulation.
This looks wide open,
In conclusion, benign airway stenosis has become increasingly common post-COVID. It is a challenge to manage. The major considerations would be to improve the patient's quality of life, and including improving their exercise tolerance. The goal is to avoid a trach if possible and to minimize trips to the OR. It does require a multimodal approach as well as a multidisciplinary approach. Okay. All right, well, next we'll transition to Dr. Kwang Sung, who will give us talks on professional voice as well as in-office approaches, in-office procedures. Dr. Sung comes to us decorated as a laryngologist and academician, and he's a professional singer and as well as an actor. He has performed in off-Broadway productions and regional theaters, national and international tours. He is a man of many talents. He's truly a Renaissance man, so we're very honored to have him here today.
All right, good morning, everybody. Thank you so much for having me, Helena and Steve. Really am honored to be here. Today, we'll have 3 consecutive talks, so it's in celebration of Groundhog's Day. You're going to be seeing me again and again and again for the next hour and a half. And just in case you didn't realize, Punxsutawney Phil did see his shadow today, this morning, so 6 more weeks of winter to come. All right, so I do want to make this somewhat casual and interactive if we want to. So if you guys have questions or comments and you want to, shout them out to me during the talk, you're more than welcome to. I'm sorry, you can't see this. I have some messages coming up on my screen here that, I didn't know that I could dictate as well. So let me turn off the closed captioning. All right, my PowerPoint just updated, so I got all these new features, I think. So anyways, I thought about what would, this audience as comprehensive ENTs want to learn about laryngology to be able to do things in the office for your patients. So if you're like me, when you went to residency, you probably didn't get a chance to see much office procedures at all. Mostly we're in the ORs the whole time. If I went to laryngology clinic, it was maybe half day a week during a specific rotation. So all this office-based stuff was really a mystery to me until I went to fellowship. I should tell you, I have no disclosures for today. So, it's funny, laryngology started off in the early 19th century as an office-based subspecialty, right? We didn't have general anesthesia. We didn't have ways to enter the larynx except for to look through the mouth in the office. And then gradually, in the early 20th century, we developed general anesthesia and endoscopes that were able to access the larynx and moved a lot of our procedures, or most of our procedures, into the operating room. And then probably, in the last 20, 30 years, as we've developed improved instrumentation with flexible laryngoscopes and distal chip scopes now, we've really reversed that trend and started to do a lot more procedures in the office. And I'll explain, kind of why we're doing that towards the end, but it can be very beneficial for you and your patients to be able to do this. So just a quick overview of what I'll talk about today. We'll touch briefly on some laryngoscopy and stroboscopy, anesthesia, some typical procedures that I do in the clinic fairly frequently that I think that you guys might be able to do as well. Okay, so I'm assuming that you guys all do flexible laryngoscopy, and that's part of your practice for the most part, for most ENTs. And that's really the backbone of our office-based laryngology, being able to visualize the larynx with an awake patient and then do something with it. I wanted to touch on stroboscopy because I think a lot of practitioners don't get to see stroboscopy and you don't do a whole lot of it. And it's actually quite useful as an additional tool to help diagnose a voice disorder. It gives us details, more details of the vibratory qualities of the vocal folds, and it helps me to form a more accurate assessment of vocal fold closure as well as particular pathology, differentiating between maybe a cyst and a polyp. Sometimes I can tell, I have a better idea of when a leukoplakic lesion is invasive and it's going to be a cancer rather than just superficial, okay? So these are kind of the reasons that I think stroboscopy is very helpful. And of course, reimbursement is different. You get more RVUs for a stroboscopy, which is 31579. You get 5.75 RVUs in the non-facility setting as opposed to 2.99. And it's I haven't looked at the Medicare numbers recently, but I think it's about an $80 difference in what the payout is. All right, so in order to understand what we get out of stroboscopy, I do have to talk about a little bit of anatomy and physiology. So I'll try to keep the voicey voice stuff to a minimum today, though, so I don't have you glaze over, your eyes glaze over with physiology. But when laryngologists think about the vocal folds, we think about it histologically in this model of the cover and body. It's a two-mass model. Basically, the cover of the vocal fold is the epithelium and the superficial lamina propria. So that's that gelatinous cushioning layer that's just underneath the epithelium. And then the body is, well, I kind of mislabeled this. The intermediate layer of the lamina propria and the deep layer of the lamina propria fuse to form the vocal ligament. And that encapsulates the muscle, the thyroarytenoid muscle. And so the vocal folds, when they vibrate, these two entities vibrate separately. The body, the muscle, and the ligament will vibrate at a kind of at one frequency, or they're at the same frequency, but the cover will vibrate separately, kind of like if you see Jell-O shaking in a mold, right? The lamina propria, the superficial lamina propria, should kind of shake like Jell-O because it's soft and gelatinous like that as the vocal folds vibrate. So when we talk about looking at the strobe, we're looking at the mucosal wave. The mucosal wave is just that epithelial and SLP layer kind of flowing on top of the vocal folds as they vibrate. So in this two-mass model, the cover and the body vibrate as separate masses. The body's stiffer, the muscle and the ligament are stiffer, and then the cover is supple and will ripple over the vocal folds. So as the vocal folds vibrate like this, we should see in a stroboscopy that propagation of this small little ripples on the top of, on the medial surface and the superior surface of the vocal folds. So stroboscopy really is just adding a source of flashing light to your laryngoscopy exam. And it can be either done with a flexible scope or rigid. Now, most of us, I'm sure most of you out there probably don't have, the resources to buy separate strobe tower and rigid endoscope. So there's actually some lower cost strobe units that are available, I think, besides like the typical Olympus and Pentax models that we're lucky enough to have in our university practices. So the strobe light basically creates this pseudo slow motion view of periodic vocal fold vibrations, because the vocal folds are vibrating too fast for us to see with our naked eyes under white light. There, for males, the speaking frequency is somewhere between 100 and 150 hertz, right? So that's 100 to 150 cycles a minute that they're hitting against each other, and that's far too quick for our eyes to catch. And for women, it's 200 to 250 hertz. So basically, the strobe unit captures there's a microphone that senses the frequency of the sound, and then adjusts the light flashing to just a little bit off that frequency of the voice. So we capture the cycle in different little spots, and then we fuse that together, kind of like a movie, a stop action movie, to see slow motion movement of the vocal folds. So this is a flexible stroboscopy. So typically, I have a separate light source that I use for stroboscopy. I do my regular white light laryngoscopy, and then I'll switch over to do the stroboscopy. The cheaper ones, I think, are integrated, and you can just flip a switch with your foot to turn on the strobe light. So that's that. Oh, that's in there twice. So what do I look at when I'm looking at a strobe? So part of the laryngologic assessment, you're looking at like the basic anatomic variations or lesions. Always looking for symmetry, right? When you're looking down into the larynx. You want the left side and the right side to look the same ideally, and if I see any asymmetry, then my mind says, okay, why is it asymmetric? What, is it a lesion? Is it paralysis, paralysis, something like that? So we look for gross laryngeal movement. We look at the false vocal folds to see how much there's supraglottic hyperfunctioning there may or may not be, if that's even on both sides. We kind of take note of the frequency of the voice. Is it a high-pitched voice that they're using, low-pitched voice? We look at the edges of the vocal folds to see if they're smooth. And then for the strobe, I'm looking at these things in the yellow, the mucosal wave properties. And I'll go into these in a little bit more detail about this. I'm not really going to talk about this. A vocal fold movement, again, we're looking for symmetry, medial to and lateral excursions. You can sort of see sometimes if the vocal fold levels are off, one side is higher than the other. False vocal fold activity, as I mentioned, sometimes, in a paralysis or a paralysis, one false vocal fold will be squeezing much more than the other, and you won't be able to see the true vocal fold almost because of that squeeze. All right, so symmetry, as I mentioned, is kind of one of the key things. So phase symmetry is one of the things we look for. So when you're looking at the strobe, they should be, if you look at my hands, they should be mirror images of each other as they vibrate. If there's a tension mismatch or a mass mismatch, you'll get them dancing kind of like a snake dance sideways where they're not in phase, okay? So that tells me that there's a little bit of difference between the two sides. Amplitude symmetry, so how much the vocal folds move out when they're vibrating, they should be equal, but if one side is scarred, it won't move out as much if one side is more tense than the other. So these are a couple of... So this is a rigid stroboscopy. A little bit better images with the rigid usually. So, all right. Periodicity, we're looking for the vocal folds, the strobe unit can only capture and give you this slow motion view if the voice is pretty regular. So if the voice is really hoarse or if there's irregularities to the voice, it won't really capture it, and it'll kind of just have a fluttering look on the strobe. In some strobes, there's a lock mode where it'll actually sync up to the exact frequency of the voice, and so basically it'll freeze the motion in at one spot. So this is an example of, you can see that actually the two sides aren't equal. The excursion on the left vocal fold, which is on the right side, of course, is much higher farther than the right side. And then so it wasn't really capturing that well, but now we're in lock mode. Now all we see is it frozen in the same spot, okay? So that gives us an idea about the periodicity of the vibrations of the vocal folds. I talked a little bit about amplitude already. It's that horizontal excursion of the mucosal wave, how far out the vocal folds move, as well as how robust the surface vibrations are. We want to judge this kind of in the middle of the voice, what we call modal frequency, where most people do their talking. If you do this when they're speaking or singing too high, it tenses the vocal fold and it changes how much the vocal folds move, the amplitude of vibrations. And then, so the last thing that I'll mention about strobe is, it gives us a really better view of how well the vocal folds close, glottic closure. This is actually one of the key things for stroboscopy is whether or not we get complete closure. So when you look with a regular white light scope, we can't really actually judge whether the vocal folds are closing because they're vibrating so fast you can't really tell. But with strobe you can really tell. So some of the closure patterns you'll see will be complete where they obviously completely close. You might see hourglass shaped where that might happen with nodules. You might have like a posterior gap where they don't come together completely, anterior gap, spindle shaped if there's like presbylarynx or loss of bulk of the vocal folds. All right, so that's stroboscopy in a nutshell. That can be a whole course unto itself, so I'll leave that at that. The next thing I'll talk to you about is topical airway anesthesia, and Helena already mentioned this in her talk. If you take nothing else away from this laryngology session, this is probably the best thing. Learning how to topicalize the airway so you can do some of the more advanced diagnostic things that we do. So The key to a good AFRS procedure is almost always good anesthesia so that the patient can tolerate the scope and tolerate manipulation of the vocal folds. I usually use 4% lidocaine. I think that's what most people use. And there's different ways that you could get it down into the airway. So my go-to is probably transtracheal injection. I use a 5 cc syringe. I put a 22 gauge 1.5-inch needle on there, and I draw up 4 cc's of 4% lidocaine. And I'll show you kind of where I do it. That is the quickest, simplest way to do it. It is a little bit traumatic because you're putting a needle into the airway. You can nebulize them, so if you can get a nebulizer, attach it to an oxygen source, put in 6 milliliters of lidocaine and have them breathe it in. But it does take 10 to 15 minutes to get them numb, and I don't find that it's quite as effective as a transtracheal. Working channel laryngoscopes, we'll talk about in a little bit, but you can drip lidocaine through the channel, do what we call a laryngeal gargle. Basically, you get the scope in place just above the vocal folds, and I have them phonate, and when they sing E, you have them hold it out as long as they can, and you start dripping it on, and they ideally gargle it. Most of the time they'll sputter a little bit, and then they'll, as they get numb, it'll be better. And then Helena showed the Abraham cannula. So that goes through the mouth. It's that long curved tip that you can place into the larynx and then drip it that way and do laryngeal gargle that way. All right, so transtracheal injection, as I mentioned, 5 milliliter syringe, 1.5-inch 22 gauge needle. So I typically, you can go through the cricothyroid membrane. I typically try not to because on occasion you will hit the vocal fold and inject into the vocal fold by accident. So I typically try not to use that unless I can't, the larynx is too low and I can't access the trachea. But I palpate the cricoid cartilage and I go down somewhere around between the second and third rings, and I will grab the patient's neck like this with my middle finger and my thumb surrounding the trachea so I know where midline is, and I'll go through there. There'll be a little give. You'll hit some resistance, especially if you hit the cartilage. If you're hitting resistance, I'll move it up or down until I get the inner space. And then you'll feel a give as it goes in. And then I pinch the needle at the skin so that if the patient coughs or moves around, you move the needle with them. So, it doesn't poke into the posterior wall, doesn't come out. So I just secure it there, hold it there against their neck, aspirate. It's key to have a little room in the syringe so you can see bubbles come out. And so that way I know that I'm not injecting subcutaneously or into the esophagus or something. And then I have them take a deep breath in and start coughing. And as they cough, I start plunging, and I'll do little aliquots as they cough because I want them to cough it up rather than have it all go down. So patients with a vocal fold paralysis is actually sometimes very hard for them to cough, especially cough very long. They'll go and they'll run out of air. So I really have to pulse and time it so that they don't aspirate most of it, and most of it goes up. That's it. That's the most important technique today. All right, so this is the lidocaine gargle that I was mentioning. This is a working channel scope. A lot of times we'll prep them by spraying some lidocaine directly into the mouth, and then I have a kind of a curved tip plastic applicator with my spray tip, and I'll angle it down and I'll have them say ah, and as they say ah, I'll spray a little bit first in the back of the throat. I'll hit the uveolar soft palate base, and then I'll try to get the base of tongue and into the larynx a little bit just to prep them. And then I'll do this. This is dripping down. Okay, take a deep breath in and say E. And that's what you get the first time. It's terrible. It's no fun. I give them about 15 seconds to get a little numb, and then I'll repeat it. So each time it gets a little bit better. If I'm going into the trachea, I'll have them actually breathe in because I do actually want some to go into the trachea. And then the last time here, what we really want to see is you see this bubbling of it while they're phonating, and it's kind of just bubbling on top of the vocal folds like that. So once you've done that, then you're able to do a lot of procedures. So we saw an earlier example of this, but so this is that same patient that I just topicalized. So now I can go down. This is a guy that had a tracheostomy, and then came into me short of breath, and we see he's basically got a blind pouch here, and the trachea deviates way off to the right. I can pass all the way through this with the same flexible working channel scope. So I just give them about 20, 30 seconds with a scope in the nose until they're adequately numb, and then I can, I'll actually, with this one, I'll pass I will pass into the main stems of the bronchi with this. So you can get all the way down and do a good diagnosis with this. So what's great about this is that we hardly ever go to the OR to do a subglottic stenosis or tracheal stenosis without knowing what we're getting into, because that can really make those procedures rather hair-raising. If you get in there, you're surprised by how long that stenosis is and how narrow it is, and it really can affect. It really helps me with my surgical planning. All right, so we'll skip that. Okay, so the next thing, the most common thing that I do is vocal fold. Well, this is probably the most common thing that I do: vocal fold injections, injection laryngoplasties. And we do these, usually for vocal fold paralysis or paresis. And the reasons to do them are to improve voice, swallowing, and cough. So, they'll come in breathy, you'll give them a voice, you'll help them to not aspirate as much, and you'll strengthen their cough. Injection laryngoplasty can be done both awake in the office as well as, surgically in the OR under anesthesia. Number of materials that we use, I do fat injections occasionally. I don't do them in the clinic. I only do them in the OR. Most of my injections I do Prolarin gel, carboxymethylcellulose. It's a couple reasons for that. One is that it's off the shelf. You can just pick it up and we keep a stock of them, and we just grab it when the patient comes in and we need it. I can do the injection, and the physical injection takes maybe about 30 seconds to a minute. That is a temporary injection that lasts about 2 to 3 months usually, depending on how big the gap is and how good of an injection I get. Calcium hydroxylapatite or Prolarin Plus or Renew Voice, those are longer lasting, maybe about a year to a year and a half, 3 years maybe, again depending on the patient. A lot of practitioners now use Restylane or Juvederm, so hyaluronic acid versions. We've just used the Prolarin products for the most part. I have used Renew. They're very similar. You can use those as well. Silk is a new product that's just coming on the market. It's a little bit different injection. It actually goes through the working channel port. So you'd have to have a working channel laryngoscope to do that. There's various approaches to doing the injection. You can go transorally, basically with a long needle like the Abrams cannula. You can do percutaneous from above. You can go percutaneous through the thyroid cartilage, and you can go from below through the cricothyroid membrane. And there's pluses and minuses for both. Why do we do these injections? As I mentioned, improved voice is obvious, but for patients that, if you guys are staffing consults in the hospital where you get an acute paralysis from like a cabbage procedure, we did this series a couple years ago where we saw 30 patients that had iatrogenic injury. 22 patients were NPO pre-injection, and we were able to get about 80% of them eating after the injection. So it's helpful for swallowing as well. Okay, so real quickly, this is a transoral injection. So the Prolarin products come with a long injection needle that's malleable, and you bend it. I basically take the 4% lidocaine bottle, and I use that to bend my needle over it when I have to do it. I don't typically like to do this that much, but I occasionally would do it, especially post thyroidectomy, because the neck is sometimes very tender and edematous, and it's hard to do it cutaneously. So you bend it, you've anesthetized it, you're trying to aim for 1/3 of the way anterior from the vocal process to the anterior commissure. So that's the vocal process right there, 1/3 of the way, and you want to be lateral to the vocal ligament. You're injecting into the muscle and paraglottic space, and basically we're looking for bulging. Usually I'd like to see it bulge underneath the vocal fold more than on top, okay? So that's a transoral injection. My go-to injection is really the transthyrohyoid. I like to come from above. You can go through the cartilage. Younger patients, it's easier. Older patients, it gets the thyroid cartilage gets really calcified. It's hard to push the needle through there, and the needle can also get clogged with cartilage. So I've never done that. I occasionally will go transcricothyroid from below. I personally don't like it because I can't see the needle. I don't know exactly where the needle tip is. So I'll show you why I do this. So the transthyroid approach was first described by Getz for injecting cidofovir for papilloma in the larynx, and I do that occasionally. Millen Amin adapted this approach for vocal fold augmentation also. I think it's pretty simple to use. It does take, there's a learning curve to it, but it allows us, it's a great technique because it allows us to access almost the entire larynx. So I can do therapeutic injections of steroids, I can do augmentation injections, and I get direct visualization of the needle tip as it enters the injection site, and I can move it around if I don't like the contour of the vocal fold to augment different parts. So the injection technique involves topical anesthetic. If I'm doing it myself, I'll put using a marking pen to mark a spot about 2 to 3 millimeters away, just above the thyroid notch. And I'll actually infiltrate a little bit of 1% lidocaine right there just to help them a little bit. And then we do our transtracheal injection. And then what I do is I bend the needle twice. This is a 25 gauge, 1.5 inch needle for most patients. If it's an obese patient, I'll use 2-inch needle, or if they're really tall, if they're over about 6'2" or 6'3", I'll use a 2-inch needle. I bend it at 45 degrees at the hub, basically, and then 45 degrees, about 1 centimeter away from the tip. And that helps me to get a little bit better angle onto the vocal fold once I get into the larynx. And I'll show you why that is. Then it's a little bit more vertical approaching into the larynx. And then we come from just above the thyroid notch, and the angle is actually down at 45 degrees, basically, going into the larynx. So let me show you a video of this. So this is with an assistant holding laryngoscope. So my needles come through just below the petiole of the epiglottis, and then I can guide it into the vocal fold exactly where I want it, usually. And you see, once they're anesthetized, they'll tolerate, having a needle stuck into their larynx. And then again, I'm looking to see the vocal fold. As I inject, they'll sometimes feel some discomfort. I'm looking for the vocal fold to medialize right there, and sometimes down below. Okay, so that's and a good injection, you should hear voice is really strained like that. It's what I call a stiff sounding voice, or a strained voice, because they've been working really hard to close that gap by themselves, and when you medialize it, they right away will have that really strained voice. You want to over-inject with these materials. You want to over-inject by 20 to 30%. So you get them to straight, and then you want it to bulge out more, because the water will get in the injectable will get reabsorbed over the course of the first couple days. So if you just get it straight, it'll shrink down, and the voice won't be good after a week or two. So what do you do when you don't have an assistant to do this? So when I first started at Stanford, I didn't have anybody to help me. So I figured out a way to do these injections myself. So one of the things about being in private practice is you might not have anybody to help you. And you can train an MA to hold a scope. Usually I would pass the scope myself into the right place, and then hand off the scope to the assistant, and they just kind of try to keep it in place. But you can actually drive a scope with one hand if you keep the scope straight and use good technique. And so I have marked, I've topicalized him, I've marked his larynx. He's got a polyp that I'm trying to inject some steroid into. So I palpate where that is. When I palpate, you'll see the epiglottis move. So that tells me that I'm in the right place. I have my needle on a Mayo stand, and then you'll see me put it in, insert just above the thyroid notch. You'll see it come out into the larynx. I usually try to get it far enough out so that the bend comes out, and then from there you can see I have free mobility to move it to the left and the right. I can move it forward and back, and then I actually kind of like doing it myself. It's fun, it's a challenge, but I also get a better view usually of the vocal fold because I know what I'm looking at. It's like doing sinus surgery, you know, holding the scope yourself versus having an assistant hold your scope. They don't know where you're looking and what you're trying to do. So here I'm injecting Decadron into the superficial lamina propria for this polyp. All right, so that's that. Working channel scopes are a friend. I'm already past my 30 minutes for this, so luckily I'm only interrupting myself. So I'm going to keep going, obviously. Working channel scopes, you know, if you can invest in one of these can be really helpful to do some of these procedures. This is a biopsy forceps that's going through the working channel. I do a fair number of biopsies. Typically, I do biopsies for like oropharyngeal or hypopharyngeal cancers, something on the supraglottis. I don't typically like to biopsy on the true vocal folds. It's not quite so precise in it. I'm going to take them to the OR anyways, and most of the time I will do the resection and the biopsy at the same time in the OR, so I try not to do the vocal folds. So this is just a disposable biopsy forceps. You know, you have to have a partner to do this. They will open and close the jaws. I basically drive the biopsy forceps into the tumor or into whatever we're trying to biopsy, and then I have them close it, and then we pull back, and there we got a pretty good specimen. So that's enough to send to the pathologist and get a diagnosis of squamous cell carcinoma. So a lot of times you can save the patient 2 or 3 weeks of time getting them to the OR and getting into treatment if you do a biopsy in the clinic. All right, laser procedures. I'll touch briefly on this. I don't know that most of you guys will be trying to do laser procedures in the office, but they are available for rent. There are companies that will bring a laser to you. And one of my former fellows, she's in private practice in San Antonio, and she'll schedule a whole bunch of laser procedures for one day, both in the OR as well as in the office. So they'll bring the laser. She'll do like an OR case, and then she'll bring the laser to the office and do some office cases. So you can pass the flexible fiber through that working channel, and this is I think a blue light laser. So the KTP laser is kind of the laser that has been most used for office-based procedures for laryngologists, though they stopped supporting it and they stopped selling it. So you might be able to rent one. You won't be able to buy one. CO2 laser, there's the OmniGuide, which has a waveguide that you can use in the channel. I don't like to use it because I find the KTP is very forgiving. If you miss and hit something farther down, it's no big deal. The CO2 laser, if you miss, it'll burn more. Okay. There's also, I think, the Duo laser, which is a fiber-based. The OmniGuide fibers are really expensive. They're like $600 a piece, so that's another reason not to do it, because you won't cover your costs for the rental of the laser and the fiber if you try to do an office procedure like that. The True Blue laser just came on the market in the last year or so. It's a similar laser to the KTP. 445 nanometers is the wavelength blue light. It's angiolytic laser also. And so here we're going to treat a little remnant of a polyp, an ectasia that's here with this laser. It'll take maybe just a few pulses to kind of coagulate this ectasia. It does pop at one point here, there, but giving it maybe 20, 30 pulses, and then I will put my fiber tip into the lesion to try to lift off the tissue so I can get to the deeper tissue. That's all it takes for this to treat this ectasia. She coughs afterwards, and you can see that thing is mostly gone after that. All right, so that's laser. All right, so in summary, why do office-based laryngology? Well, I think there's a really good variety of useful diagnostic and therapeutic procedures. I think it's a great patient satisfier. If you're not anywhere near an academic center and you can't send your patients to somebody like me, then, you know, there's immediate gratification in that biopsy, you get it done that same day. I get a lot of patients with acute vocal fold paralysis. I see them, I will inject them the same day because they're coming, a lot of times they're coming from 2 or 3 hours away, and I just feel bad. I don't want them to come back. When I first started practice, I would make them come back on a procedure day, but it's quick enough that I will do it the same day. And you don't know how happy some people are when you inject their vocal fold. They come in with a voice that sounds like this, and you give them a voice. I mean, they cry afterwards sometimes. It's really a great satisfier. Lower costs, you know, they don't go to the OR, you avoid general anesthesia, the OR costs, so that patients like that. Clinician satisfaction, I mean, it's easy to schedule a whole bunch of procedures in a day, and I do them consecutively. It's a good revenue generator, and I think they're fun and challenging. So that's office procedures. Do you guys have any questions about that? All right. Not interactive session. All right, so let's go on to my next topic. If my computer behaves. The next topic is, I think, on. Yeah. No, they're different codes. So hospital code for an injection is 31571, and there's a new office injection code, 31574, for flexible laryngoscopy. It includes the cost for the materials. So it used to be the materials weren't included in the injection, and they came up with this new code about 3 or 4 years ago, which includes the product. Yeah, in the back. No, I mean, these biopsy forceps are about 1 to 2 millimeters. I've done it with people on, you know, anticoagulation. It's not a big deal. Like I said, I tend to do it more in the pharynx, base of tongue, you know, vallecula, hypopharynx, piriform sinus, where it's not really going to go in the airways much. I'll do some supraglottic stuff, like that one was on the arytenoid. That it is a good point though about bleeding. Like it's one of the reasons why I don't do it on the glottis too. Yeah. Yes.
Your one-handed flexible laryngoscopy is quite impressive. Is that a 2 millimeter or 4 millimeter?
That's like the 3.9 millimeter, the regular VH scope. Yeah, it has enough rigidity to it that if you keep it straight and you have it on the floor of the nose, it'll slide in and out. And you know, you can do one-handed scoping pretty easily as long as you maintain keep the scope straight. If there's a bend in the scope, then it won't react to what you do, okay? So good technique is keeping that flexible scope straight. I always tell my residents that. And also, if there's a bend in it and you rotate your hand, the distal part won't rotate as much. So it's much more responsive if you keep your scope straight. So that's goes for anything. So I taught myself to do that by, like, one day I said, okay, I'm gonna scope everybody left-handed. And I just went in and scoped everybody left-handed. It took me a day to figure it out. And then it wasn't that much harder to figure out how to do the injection single-handedly. Yeah, I would do it with an assistant first before you tried it by yourself, though. All right. Okay, so that is that. My next topic will be talking about singers. So let me get this to play. All right, so as Dr. Yip mentioned, I have a sordid past. I was a professional actor and singer in New York for about 7 years before I decided to give up the business and go to medical school, and then found my way into ENT and laryngology. So it's kind of funny, actually. I didn't know anything about laryngology and ENT until my 3rd year as a surgery clerk. During my clerkship, one of my interns was a ENT, and we started talking about it, and then it all dawned on, it all clicked, and it all made sense. I can go work with people with singing problems. So that's how I got into this business and how I got here. So I wanted to, you know, talk to you guys a little bit about how I look at professional voice users and how I take care of them, just because I think there's some special knowledge that I have that hopefully I can pass on to you when you see people who are singers and performers. All right, so one of the things that I like about it is I get to meet with cool patients.
Just moved it to 14G.
This is a singer
so
who happens
cozy,
to be our
calm,
former
and
fellow
peaceful.
Jennifer Bergeron, who is a trained opera singer at Pepperdine. And she let me record her singing like this. So it's always fun to look at singers while they with a scope in their throat.
Window seat with garden view, a perfect nook to read a book. I'm lost in my Jane Austen when I hear.
All right, that's enough fun with Jennifer. So that was quite impressive. When we talk about professional voice users, it's actually a fairly inclusive category. As laryngologists, we think about anybody who uses their voice in their jobs. So that can be, a lawyer, can be a salesperson, can be a telephone operator, teachers. Teachers are probably the most common people that come to us with voice problems that have to use their voice for work. And doctors too, and if you guys during COVID had to wear masks and had HEPA filters running, you probably got some hoarseness from straining your voice talking to patients, shouting at deaf patients all day. So any profession like that. A thorough history and careful physical exam are required for that. But for singers, it's helpful to know a few different things in terms of how they're using their voice, what settings they're using their voice, and what vocal style they use. So I will ask them more questions than I will the typical voice user. Okay, so a complete singing history. We're going to find out about their medical history, if they have any medical or surgical problems, social history, including, of course, tobacco use. And then kind of try to suss out what kind of problems they're having with their voice. So are they having a problem with their range? Are they getting fatigued? Is there pitch instability? Are they having problems with their voice transitions? And that means going from the low part of the range to the high part of the range, volume, pain, etc. The type of singing. So, the type of singing can be very different, right? From an opera singer to a jazz singer, musical theater. The types of singing and the stresses on the voice are quite different of those things. And a choral singer, if they're singing professionally or if they're amateur, do they have a performance coming up? If they have a performance coming up, that means they're in rehearsals. So they're under stress. They're probably singing a lot more than they're used to, and that can cause problems. Have they had any formal training? So, people that have had formal training are less likely to have problems, and the ones that haven't, are more likely to not know exactly what they're doing and get into problems. What are their daily vocal demands? So a lot of, as a former actor, I had a day job. My day job, luckily, I worked as a temp admin or secretary for most of my time. So I didn't have to work in restaurants and bars, but those are places where they have to talk a lot in a very noisy environment, and it's very stressful on the voice. Do they have allergies, breathing problems, reflux, etc., smoking, exposed to smoke? Okay, so when I have a professional voice user come in, or any voice user really, I'm listening to them from the time that they walk past me to go in the room. I say hi, I hear what their voice sounds like, and I'm already judging them. So I'm very judgy, and I listen to them as I'm taking the history. I like to do a complete head and neck exam, and especially a neuro exam, because sometimes these things can be neurologic problems that are fairly subtle. Laryngoscopy is stroboscopy. We do a neurologic challenge. We try to fatigue them when we're in there, and I usually will have them sing for me. So I'd like to prep the patients and say, hey, I'm going to ask you to sing when the camera's in there. Think about a song that you're singing that you're having problems with, or if they can't come up with anything, I'll just tell them to sing Happy Birthday. All right. But I want to see how they're functioning when they're singing. If they're doing some weird things like pressing the voice down like this and they're singing like this, that's no good. Stroboscopy. And then in my practice, I'm lucky enough to have a multi-D practice with a speech pathologist. So my SLP helps me to do the assessment. They'll do acoustic and aerodynamic measures after the session. So more physiology and some singing terms, okay? So as voice people, we think about the vocal system in three different subsystems, the power, the source, and the filter. So the power comes from airflow, of course, which comes from the lungs. And the source is the vibratory source, which is the true vocal folds. And the filter is everything above that, okay? So there can be problems with any of these aspects, these subsystems, and cause vocal problems. So the vocal tract, meaning everything, the supraglottis, the pharynx, the mouth, the lips, the teeth, etc. And those all go to modifying and the sound that we produce to change the color of the voice, as well as articulation for forming words and speech. So as I mentioned, power is below the glottis. You know, if they have any sort of respiratory problem, COPD, asthma, they have a diaphragm that's not working, you know, those can affect their ability to sing. You know, trauma like broken ribs or something like that. Source, the vocal folds we'll talk about later. This is simple anatomy: thyroid cartilage, cricoid cartilage, arytenoid cartilage, the skeleton of the larynx. I'm not going to dwell on this. The muscles of the vocal folds you should hopefully remember from way back when, but the main muscle of the vocal fold is the thyroarytenoid muscle, which is here. And then the medial portion, we sometimes refer to that as the vocalis muscle. And then the other muscles, the lateral cricoarytenoid muscle, the posterior cricoarytenoid muscle, interarytenoid muscles, are the ones that move the vocal folds around. You'll remember that the TA, the LCA, and the interarytenoids are involved in adduction, so bringing the vocal folds together, and PCA is involved in abduction. So abduction, adduction. All right. For singing, one of the most important things is the cricothyroid muscle, which is innervated by the external branch of the superior laryngeal nerve. And that's the muscle that we use and the mechanism that we use to really stretch the vocal folds out and thin them out, and that's how we change pitch. And so if you have a superior laryngeal nerve injury, for instance, after a thyroidectomy, so you know, most of us doing thyroidectomies really know we have to watch out for the recurrent laryngeal nerve. But if you're not careful with the superior laryngeal nerve, you can injure that, and it can cause, like a normal person who doesn't sing, they probably won't notice a whole lot. But if a singer, you injure that superior laryngeal nerve, it'll really affect their vocal range and their ability to have fine motor control of the tension of the vocal folds to be able to adjust pitch. So keep that in mind. Okay, so as we know, the cricothyroid muscle gets activated. It tilts the visor of the thyroid cartilage down and stretches the vocal fold and tenses it. I'm not going to talk about this. We don't have time. FOC. What the FOC? All right, so FOC is a German term. It's a German term that describes the classification of singers. So you may or may not have heard of this, and you may run into it. But we think about this because of the way that people use their voice. And this is mostly for classical singing and musical theater singing, because people get kind of shoved into their voice categories depending on what their anatomy can produce. All right, so soprano is the highest voice, mezzo is kind of middle, alto, contralto are the lower females, and then for males, tenors are the highs, baritones are the middle, and basses are the lowers. And you know, this is important to know because if a singer is really an alto or a mezzo-soprano and they get stuck into a soprano role, they're going to really struggle to sing that role, and they're more likely to injure themselves doing that, okay? And vice versa, sometimes when people sing too low, they can actually get in trouble, and they're more likely to cause a polyp to form or something like that if they're singing too low. So we want to ask what their vocal part is, and then if is what they're singing appropriate to their vocal part. There's different mechanisms of the voice. There's something, and it depends on how we're using the vocal folds, how we're tensing them, how they're vibrating. So mechanism 0 or M0 is called vocal fry or vocal creak. It's the very bottom of the voice. It's like that, okay? And mechanism. One is basically our typical speaking voice, or in women, it's the lower part of the range called the chest voice, and in men, it's the normal singing range like this. We get into mechanism 2, that's the higher part of the singing range. That's the head voice in women, or falsetto in men. And then for women, the very highest high sopranos will have this whistle tone register, the mechanism 3. And this kind of shows a little bit about how it differs. So modal frequency will be lower down, falsetto a little bit higher than that, so if in men, and then chest voice, middle mixed, and then whistle tones on there, and then vocal fry way down there. This is a piano keyboard in case I didn't explain that. So these vocal registers, as I mentioned, it's how you're using them that differs. So in vocal fry, the muscle activities, only really the thyroarytenoid muscle is actively being used or being activated. The whole vocal fold will vibrate, and we'll get this kind of low, kind of rough quality. Chest voice, mostly the TAs and some of the cricothyroid will be activated, and you'll get both the cover and the body vibrating. As we start to tense the vocal fold, the thyroarytenoid becomes less active, and we get more cricothyroid activity. And in the higher pitches, only the cover will vibrate, and the deeper the muscle won't vibrate. In whistle tone, it's very little vibrations at all, and it's really only the cricothyroid that's activated. All right, so just to kind of show you what the difference is between these, this is modal frequency. Can we turn up the, yeah, there we go. You can hear it a little bit. So this is an opera singer from SF Opera. It's right in the middle of this range, okay? So here, this is the pitch where we're judging glottic closure, okay? Next one is falsetto. So this is higher in his range. Vocal folds are tensed. A lot of times when they're in falsetto, the vocal folds won't actually even touch. They'll be slightly separated. So that's why we don't judge vocal closure at the high pitch. You want to judge it at the modal frequency if you're commenting on that. Low modal, so this is a little bit lower in his range. You can see that there's greater excursion of the vocal folds. And then vocal fry, this is that very bottom range. And the voice becomes a little bit more irregular at vocal fry. Another term that I want to explain is the passaggio. So the passaggio is the transition between different registers. And a lot of times singers will come in and say that I'm having a really hard time with my break. And so this is what they're talking about. It's that shifting from the chest voice to the head voice, or normal modal frequency to falsetto. And usually there is a little break in the voice, but sometimes it can be quite a big break, and they have a hard time singing in there. The break actually, some singers will utilize it, like yodelers. Is actually when you yodel, you're switching from that low register to a higher register. You hear that transition there? That's the passaggio. So professional singers, opera singers especially, train years and years to try to smooth out that transition so that you don't hear a break. And that's part of the singing. Whereas like popular music, there's less worry about that. Mostly you're singing in your chest voice. Musical theater, there's some, like sopranos are mostly singing in their head voice, and then belters or altos are singing in their chest voice. So that's that. Vibrato. So vibrato is this regular pulsations of the pitch and the loudness of the voice, and that's something that's found most frequently in opera singing, classical singing. Some musical theater singers use it. Most pop singers don't utilize it, but it's important to know that it exists because it's very similar actually to vocal tremor, but vibrato you can control and vocal tremor you can't control. So this is vibrato. So straight tone, vibrato, okay? All right, I'll skip that because we're running out of time. Maybe I'll play the video. So there's a couple ways to change loudness. Basically you have to increase pressure, subglottic pressure, by generating more air pressure, airflow. The singer has to be able to tense their vocal folds tight to resist that extra pressure. And so if there's a neurologic problem, a weakness of the vocal fold paresis, then they won't be able to increase the pressure or sing loudly or speak loudly. Okay, so I'll talk, I got 6 minutes, 6.5 minutes, I'll go over just a couple cases to kind of illustrate some of the things that I think about when I'm treating professional voice users. So this first patient, patient A, is a 28-year-old professional opera singer. She's a coloratura soprano, which means she sings at the very top of the range. So if you know the Marriage of Figaro, the Queen of the Night aria, where that's where they're singing way up in the high range. So she's been having trouble with her high register off and on for several years. I saw her 3 or 4 years ago. And then she was diagnosed with reflux, which is very common. They go see somebody and they don't see anything on the vocal folds because they've done just like a regular flexible laryngoscopy with the old flexible fibers, and you don't get a great look. And we say, well, I don't see anything. Maybe it's reflux. We put you on reflux medications. But sometimes it'll help, but not for her, not 100%. A couple of years before seeing me, she had a large lead role in Pennsylvania, and afterwards she'd wake up with hoarseness, and she had trouble with the soft high notes. She was diagnosed with nodules and put on voice rest for 3 weeks, and the voice improved, but still not all the way back to normal, about 60 to 70% of her normal. When she came to see me, she was in rehearsals as the lead of a new opera in a small professional company in San Francisco, and she has 2 shows coming up in 3 weeks that are 1 week apart. So again, this is one of the things I was talking to you about, knowing what their schedule is, right? So now she's under pressure because not only is she in rehearsals, so she's learning the music, she's getting 2 or 3 hours of rehearsal time a day probably, and the stress of learning this stuff and the stress of having the show open is there. And then, because it's a small company, she has no understudy. So really, she either goes on or the show gets canceled. So these are high stakes, and you have to understand what the stakes are when they come to see you. So let's see, trouble with highest part of her range, fatigue, no real pain, and she's been marking during singing. So this is another term that you should know. So marking means that you don't sing full out. So a lot of times if I'm having a singer that's having problems, I'll say, hey, just sing softly during rehearsals, mark it. And the key thing is that they need to tell their musical director and the director that they're doing that. Because the directors sometimes, sometimes, most of the time they should be understanding, especially the musical directors. But the directors sometimes get angry and they'll yell at them like, why aren't you singing? Sing out, And that just makes things worse, because if they have a problem that is from vocal trauma, you don't want to exacerbate that by making them sing through an aria 3 times during rehearsals, okay? No other past medical history. This other stuff is not contributory. So this is her exam. So vocal folds are maybe a little bit edematous, a little bit swollen. I judge that by looking from the vocal process to the anterior commissure. Does it bulge out a little bit? Yes, it bulges out a little bit. And she had a little lesion on the medial surface of the left true vocal fold, right there. So I do the pitch glides to make sure that they can access the upper part of the range. And her passaggio is seamless. You didn't even notice when she went into her head voice there. And then I do a full neurologic exam. So I try to do a lot of these E-sniffs. And it's kind of a running joke in our clinic. Like, we'll really torture them and do a whole bunch of E-sniffs. Because if they have a mild paresis, as you do this, they'll fatigue. And you'll actually see one side stop working as well as the other side. So that's her problem right there. So by having her sing the song that she's having problems, I can see where she's having the problem. Right? So the voice breaks right there. It was a little bit unfair because she didn't come in warmed up, and this is like 9 in the morning. So the opera singers tend to rise a little bit later and sing later in the day. But so that was her problem. After doing a little bit of warm-up, though, she was able to work through it. Okay, so that's important to know, too, is that she can actually hit that note, and it just, you know, maybe she's got to be prepped a little bit better before singing. So she got through that note right there. So, all right. So what is the diagnosis? Well, she doesn't have nodules by definition anymore. So nodules actually, we have a fairly strict definition for nodules now. They have to be bilateral, they have to be symmetric. And her lesion is more on this left side here. She's got a little bit of a bump on this left side. I'll tell you, I tend to avoid the term nodules or nodes when I'm talking to a professional voice user, because that in itself can be very triggering. There's actually some stigmas that go along with saying you have nodules or nodes. So a lot of times I'll say, oh, you have fibrovascular lesions. So it's a little bit of a euphemism, but it doesn't tend to stress them out as much. Okay, so she has a little fibrovascular lesion on this left vocal fold here, maybe a little bit more edema on this left side than the right side. So, all right, so the treatment plan. Well, for her, you know, she could sing through it, right? She's able to sing through it. I told her that, you know, try to rest your voice as much as you can, try to mark, get a lot of rest. I typically don't, sometimes we'll give steroids in acute inflammation. I don't tend to do it unless I have to. You know, like we're 1 or 2 days out from performance and they're really struggling. So, you know, just conservative voice use for her. Maybe, you know, if there's time, I might have her work with a speech pathologist to do some voice therapy, but, you know, probably for her, we don't really need to do that. Surgical decision making, this is really the key for taking care of professional singers. When do we actually want to do surgery? Because for me, as much as I can avoid it, I try not to operate on singers. So if they can get better on their own with voice therapy, rest, etc., that's probably better, because I tell them anytime I operate, no matter how good a surgeon I am, there's going to be a little scarring afterwards. And a scarred vocal fold, scar tissue just doesn't vibrate the same as the normal vocal fold. So there will be a difference after you heal up, okay? Some of the things that we think about are really timing. So for professional voice users, can they really take a couple of months off before they start singing again? Because you have to be able to rest the voice after surgery. Then I usually take 1 to 2 months post-op before I let them start to sing. And then to get up to a performance level, still another month of working those muscles back. And then we talk to them about expectations, as I mentioned there. So you really have to be at a point where they really can't perform anymore and they really have to do something. So I'll speed through this last one. It's a 30-year-old professional music theater performer. Lost her voice a year ago. She works as a dance instructor now, too, which is a very high voice intensity profession as well. And so she has this lesion on her right vocal fold there. So I'll let this play a little bit. She has a little bit of hourglass-shaped closure, maybe a little bit breathy voice, little roughness in her voice. Doesn't sound terrible here. She can actually sing with this. Oh. Good. And then sniff. All right, I'm going to skip a little bit here for time's sake.
Happy birthday to you.
This is why she is having problems in this part of her range. That polyp that's a sessile polyp or pseudocyst, very similar, but that's really interfering with that part of her range. And she's about to go on tour for like a year, but I have about 3 or 4 months before she's about to go on tour. So for her, she really couldn't function singing with that and singing the repertoire that she needed. So I went ahead and did surgery. I'm going to skip this. This is me taking off a different polyp. But this is her afterwards, you know. I got her looking like this after 2 months, and then she was able to go out on tour. and do her job. So these are the considerations that I have for taking care of singers. I think it's important to know, again, how they're living their lives, how they're using their voices, and then really understanding their problems. The singers have a reputation of being high demand, right? High anxiety, and I get that because, if you can't sing and that's your job, then you can't work and you have no livelihood. So, and a lot of times their self-worth and definition of self is really incorporated into their ability to sing, and that can be, cause depression and a lot of problems with that. So that's my second presentation. Hopefully everybody's still with us. So that's the end of that. Do you guys have any questions about this? Yeah.
Your first example, there was a lot of mucus sitting on top of his cords.
Yeah.
And so, how do you know when that mucus is pathologic and that situation looked like it was totally normal?
Yeah, so a little bit of mucus on the vocal folds is normal. It does keep the vocal folds moist, and a dry vocal fold doesn't vibrate as well as a moist vocal fold. So having a little bit is okay. When it starts to get thicker and interfere with the vibratory qualities of the voice, then that's when I think it's pathologic. And if it's very thin, it's usually fine. Okay, if it's like the consistency of saliva, thin saliva, that's usually fine. If it gets thicker and it's bothering them and they have to clear their throat every couple minutes to make the voice clear, then that's pathologic. And then I certainly will treat them for reflux. I'm not one of those practitioners that thinks everybody has reflux. So I'm definitely more judicious about giving out PPIs and treating for reflux. Yes. Yeah. Yeah. So the question was, do I use calcium hydroxylapatite for injections? And yes, I do. I don't do it nearly as frequently as I use gel. So I probably the only times I use it now are when a patient so I do it for patients that have metastatic cancer a lot of times. So if they have a lung cancer that's in the mediastinum, or breast cancer that's in the mediastinum and they're metastatic, and I'm not going to take them to surgery, I'll do it then. And I don't want to just keep doing gel, okay? So yes, CAHA can get, if you inject it too superficially, it can get into Röntgen space, cause the vocal fold to be really stiff and can make the voice really bad. And one of the reasons why I like the transthyrohyrid injection technique is I can see where the needle is. And I pretty much know if it's too superficial. If I'm coming from below, I can't see the tip of the needle. You might not know until it's too late that you're injecting superficially. So that's the thing that you worry about with that. There's some patients that don't want to get a thyroplasty, that want a longer lasting material that I'll do it for as well. I usually try to convince them to do a thyroplasty after 6 months or a year, usually a year, if I'm doing something long term. Yeah.
Hey, Dr. Sun, can you play the surgical video? I actually would like to see.
Oh, you want to see the surgical video?
Yeah.
All right. This is actually turned out to be a polyp. I wasn't sure at first if this was a cyst, so I actually made a microflap. So you'll see I'm just kind of palpating both vocal folds with a elevator, and then I'll bring in a second here. This is I do most of my benign lesions with cold steel. I don't use a laser for these. So I'm just making a little incision on the superior surface, or kind of superior edge of that lesion. And then once I make the incision, I'll dissect it out with that blunt dissector to elevate the epithelial flap. Okay, and here I'm just trying to make sure that it's not a cyst, and to expose it. So we open it up a little bit. Then I will grab it with these micro alligators to grab the flap and dissect away the polypoid tissue from the deeper lamina propria. And once I loosen it up, then I'll take another alligator and grab, this is the other alligator, and grab the polypoid tissue. So when you have a kind of a bulging out exophytic lesion like this, the epithelium's attenuated, it's stretched out. And so afterwards, you end up with this extra redundant epithelium. So I'll go in and just resect enough of it so that it's not floppy, and then the edges will come together nicely. So ideally, I try to do this in one cut, but you won't necessarily make it all the way in one. And then we'll do a second cut here. So this is a different patient than the one I showed the case, but similar type of pathology. I did pretty much the same thing on that patient. So that's it. Then it looks beautiful. The other side, you'll notice that the other side, the contralateral side, has a fibrovascular reactive lesion there. So I inject some steroids in there to try to reduce that afterwards. So that's it. That's that. All right, let's move on. I think some of you snuck out for bathroom breaks. That's okay. I'd like to invite our other panelists, our speech pathologists, up to the stage.
Oh, by the way, those were beautiful injections in the office. And that's a beautiful excision of the cyst.
We only show our best work, though. Nobody comes up here and shows their worst work. All right. So I've actually never met you guys.
Hello.
You can introduce yourselves, Natalie and Dory, right? Who's who?
I'm Natalie Monahan.
I'm Dory Smith.
Okay. I might have met you guys before. I don't know.
Wait.
All right.
Well, Dory Smith is also a professional soprano. She's still, is it not on? Okay. Oh, Dory Smith is an active soprano here in town. She has her own voice studio, and she got the lead role in the musical called Chess. It's playing when?
February and March. Yeah.
Okay. And then Natalie came to us from UCLA, where she also had another career as a musical theater actress, and she had a voiceover actress, and she was in this Charmin commercial that paid for
Put me
her
through
grad
graduate school. Yeah, it's a good story.
All right, a bunch of performers up here. Very good. All right, so I'm going to talk a little bit more about some stuff neurolaryngology-wise, because I think it's important, this topic that we're talking about, muscle tension dysphonia, you have to kind of know a little bit about neurolaryngology. So, physical exam, I typically do a complete cranial nerve exam because I want to look for things like tremor or myoclonus or writhing of the tongue, assess for dysdiadochokinesis, so padaka to see if they're able to articulate quickly. And then, I'll check like the soft palate to see that it's closed. I do the normal laryngeal exam, and as I mentioned before, I'm looking for symmetry, right? And we're really trying to see if the two sides are equal and if we're seeing any sort of spasms or tremors like that. So this is a flexible exam. I'm going to play this quickly.
Coca-Cola, baby bottle.
Checking for soft palate closure. So this is actually me scoping myself. I needed a video. And I didn't have a good exam video, so I scoped myself. So it's not the best because it's backwards, right? And I gag myself a little bit. But so I check the base of the tongue, I look at the vallecula, I look at the inferior poles on both sides to make sure there's no tumors. I try to be systematic when I'm doing my flexible laryngoscopies. And then I try to get an up-close view. Anytime I see any lesion on the vocal folds, like that one there, you gotta have them cough to make sure it's not just mucus. So this was just mucus. I back up and cough. So ideally, I'm trying to get a close-up look, and I want to be able to see individual blood vessels on the vocal folds when I do this. So I was probably less successful than typically when I'm doing somebody else in this. All right, so I'm going to skip a little. The reason why I wanted to show you this. So these are the E sniffs. After doing some E sniffs now you can see that there's some asymmetry. I actually have a paresis. I have a right vocal fold paresis, and that's one of the reasons why I got out of the business, because I had a lot of trouble singing after a while. So those are kind of the things I look out for the neuro exam. All right. In terms of neurologic disorders, you can have hypokinetic disorders where you're getting less muscle activity. You get hyperkinetic disorders where you're getting overabundance of activity, okay? And then you can have mixed disorders. And we want to think about it in those terms because there's different diagnoses that come with each. So some of the hypofunctional laryngeal disorders are vocal fold paralysis, paresis, neuromuscular junction disorders like myasthenia, Parkinson's, ALS, MS, stroke, and you can have some psychogenic things, right? Hyperfunctional dyskinesias, you can have tremors, dystonias, myoclonus, chorea, tics, Tourette's, and then muscle tension dysphonia is a hyperfunctional laryngeal disorder as well. So we'll kind of go through some definitions. So a paresis is a disruption or decrease in neural input which results in a motor weakness, right? Tremor is action-induced, and it's rhythmic contractions of these agonistic and antagonistic muscle groups, while myoclonus is sustained activity that happens involuntarily at rest still. Dystonia is an involuntary disorganized action that's task-specific and happens with sustained muscle contractions. And then muscle tension dysphonia is the term that we typically use now instead of a functional dysphonia or psychogenic dysphonia. It's a behavioral disorder of the larynx, laryngeal muscle functions when there's no organic cause or despite not having an organic cause. All right, so I'm going to just go on to a couple more definitions. So just in case you didn't know, spasmodic dysphonia is on the way out as the term that we use. We're starting to use laryngeal dystonia, so you might see this appear more. Same thing, okay? LD and SD are the same thing. Idiopathic focal dystonia of the larynx, adductor, adductor is 80 to 90% of the cases. We get pitch breaks, irregular speech, strangled, strained voice. Abductor is very much more rare. It's 10 to 20% of cases. You get a breathy voice quality with short duration of vocalization. And then you can sometimes have mixed both adductor and abductor. All right, so I'm going to show you a video of somebody with adductor spasmodic dysphonia. Again, E. Good, say So it's a very strangulated voice, right? It sounds like this. So, ow. Ow. Good. Sniff. And then say E, and then I'm going to skip a little bit. Can you count from 60 to 70 again?
60, 61, 62,
so
63,
we'll have certain senses that will give them
66,
patients to try to elicit more of the abductor or adductor SD.
70.
Good. Count from 80 to 90.
80, 81,
so
82,
80,
83,
81,
84,
82. It really
85,
exacerbates the adductor spasmodic dysphonia. The 60 to 70 exacerbates the abductor version. And hold it as long as you can. Okay. So here it's not quite so prominent, but when we ask these certain senses and counting things, it'll be more obvious. A little bit loud. Can you say right, so I'm going to skip now to the next one. This is abductor. Say ow. So she's hypophonic. She's breathy. The voice drops out. Just sing up high. Okay. How about down low? Okay. Good. I want you to sniff. And then I want you to say E, and then
alpha shape cystically cross 50 or 60 steps in front of Sister Cat's house.
Say E, and hold that as long as you can. Sometimes you'll actually see the vocal folds spasm out. They'll have abduct as they go. Okay, good. Right. So the reason I'm showing you spasmodic dysphonia is because it's sometimes very difficult to differentiate that from muscle tension dysphonia and some other things. Vocal tremor is another thing that's kind of in a similar vein. So this is somebody with a kind of a horizontal vocal tremor. You can see this supraglottis is spasming together. Sorry, the volume's not quite so loud on this. But you also see the whole pharynx and the basic tongue tremor. Right? A lot of times they'll have head neck tremor to go along with it. Okay? And the way I differentiate between tremor and spasmodic dysphonia is tremor is very periodic. It's very regular. So I think of it kind of like, and spasmodic dysphonia is irregularly irregular. So I think of SD kind of like atrial fibrillation, right? So you get spasms that go in and out, but it's irregular, whereas tremor is very regular pattern, like vibrato, when we were talking about that earlier. All right, so, all right. Vertical tremor, sometimes you'll have, the tremor is more coming in and out because it's the strap muscles and the basic tongue muscles that are tremoring, so there's vertical and horizontal. That's more important for me when I'm treating it because I can actually Botox horizontal tremor and I can Botox strap muscles for vertical tremor, but if it's pharyngeal tremor or basic tongue tremor, I really can't do a whole lot about that. All right, now we get you guys involved. I'm going to play some videos.
Can you start by saying E?
We're going to decide what sort of pathology this person has.
Is there a sound that's
Or
easier
just
for you to
sound?
say?
It doesn't have to say E.
Okay, that's all right. I got a little mucus in there. Can you clear your throat for me? It's hard, I know. It's hard to do anything. And try that again, just a little.
So this is a otherwise young and healthy, like 30-year-old woman.
All right. How about a
Sounding
yawn?
like this.
Tired. Okay. Whenever I try to do some of that reading.
What are you guys thinking about?
So she's close to being aphonic at this point?
Yeah, she's pretty much aphonic, yeah.
What was the antecedent event?
That's a really good question. So, I actually don't remember that she had a really antecedent event. Do you guys, in your practice, what kind of things tend to, what kind of history do you get when patients have, go aphonic like this?
Sometimes they can report having a period of having a cold and being vocally unset subsequent to like a cold or URI. Sometimes it's overuse, sometimes it's stress, emotional or physical. Sometimes they can't really identify anything as being an immediate cause, but if like the onset was sudden, it, to me, would move towards something muscle tension, primary perhaps.
Agreed.
Yeah.
Yeah, I completely agree. So the first line that we would probably try, I would assume we're in agreement, is that we would try to collect a full case history, and then we would try to elicit voice, whether that's through vegetative sounds, whether that's through laryngeal reposturing and laryngeal manipulation. Just try as best we can to get any kind of true phonation that we can then shape from there.
Yeah. So a lot of times in muscle tension dysphonia, there's actually, I divide it into two types. There's primary and secondary, right? So primary is meaning that they don't have any other laryngeal pathology. They don't have no organic pathology. They don't have a polyp. They don't have a vocal fold paralysis. Everything else looks normal, and the vocal folds are moving normally. Secondary muscle tension dysphonia is a compensatory muscle tension dysphonia. They might have a vocal fold lesion or a paresis that they're overcompensating for, and they're straining so hard to get the voice out that they get pain and fatigue and tension from doing that. So it's important to differentiate between those two, right? So for the primary ones where there's no organic cause that we can tell, a lot of times though it can be because it's been triggered by some event where maybe they had laryngitis, they lost their voice, and they secondarily compensated for that and got into a pattern where they were just working so hard and they can't get out of it, right? So we'll get that. So I tell patients like, hey, it's like if you injured your knee and you were limping and compensating and you're your knee got better, but you just kept that limp, and you just didn't get rid of it. So that's sometimes what we'll have. And we mentioned stressors. So sometimes we'll have psychological trauma that happens that will make patients aphonic. And you might get that assault trauma, sexual trauma, things like that. And most often these are women, right? These are most frequently younger women, I think, that it tends to happen in. So you need to sometimes elicit that type of history. Another thing that's with MTD that happens is they'll report that they'll have good voice periods, right? They'll say, oh, I was fine for 2 weeks, and then my voice got like this again, and it was bad for 3 days, and then she had normal voice, and then, you'll have this relapsing, remitting thing. And to me, that spasmodic dysphonia, laryngeal dystonia doesn't do that, right? It doesn't come and go. Okay, I'm getting head nods, so I'm glad I'm not saying things that are terribly untrue.
Not at all.
Did you have something to add?
Yeah, in this scenario, would you try to spray topical lidocaine on the larynx to see if you could maybe unveil a voice?
Yeah, so I forgot to go back to the case. This I think was a muscle tension dysphonia that's super severe. She would, during the middle of the exam, you might have noticed my speech pathologist said, okay, there's a little bit of mucus down there, can you clear your throat? And we tried to get her to cough, and that's a vegetative task. That's a trick of the SLPs. So sometimes we can get them to break muscle tension by doing coughing, and you'll get a voice. If they have they're not getting their vocal folds together, they're holding them apart. If they can cough and bring their vocal folds together, then you know that it's not a paresis paralysis problem, it's a functional problem, right? So, so a lot of times we'll get them to start phonating by going, or we'll do humming, right? Stuff like that. So I can let you guys talk about that in a little bit. So this is a different patient. So, that other patient was so severe that we couldn't get her out with voice therapy. I actually Botoxed her, and then she got out.
Did you do it that day, or did you have
No,
a course of
we
treatment?
did some, we tried for several sessions and didn't get anywhere. But the thing is, I Botoxed her, and the voice came back, and Botox should wear off after about 3-4 months, but she would go 6 to 8 months and be fine, and then come back to me like, hey, talking like this again. And then I would just have to Botox her. And I think there might have been some secondary gain involved because she requested disability forms for me, which, I don't mind signing disability forms, and patients, have problems, and certainly, MTD is a real problem, but sometimes it's hard to separate out, like when is it real and when is it malingering, right? So that's a challenge. She was a very challenging case. All right, let's play this one.
Good, let's hear ee-hee, ee-hee, ee-hee. Yeah, can you give it, yeah, there you go, good. Ee-hee, ee-hee, ee-hee. Hee-hee-hee-hee-hee. Woo!
So this is one of those it's kind of got breathy dystonia.
Yep, I know it's hard. We're
breathy
gonna have you say
phonation.
E.
She's
and then
not
try to
closing her
stick through
vocal
your
folds
nose
all the
like you're
way.
smelling a flower. E, E. Keep going.
But she's got full mobility. When you elicit that cough, and she'll be able to cough and generate a crisp cough. So what would you do for this patient?
I mean, I think to tease out the primary versus secondary MTD, if there is an overlay, and see what emerges, if you can get her to fully phonate. Yeah, I think that's important because, and there's also elements of distractibility too, right? You can vary the task to see how the disorder varies and what you can grab onto. With the acknowledgement, though, of course, that for every hallmark of, like, for example, like differentiating between early early SD or laryngeal dystonia and MTD, that there's a certain percentage that could be a little bit of a false flag. For example, if you're counting like phonatory breaks or really trying to elicit them or find a breakdown, you also have to acknowledge that phonatory breaks also exist in muscle tension dysphonia. So you're kind of looking for that pattern recognition and how they're also responding to various stimuli during a trial therapy.
Yeah, and a lot of times during the initial exam, so I have a multi-D clinic. I see all my new patients with a speech pathologist. I'm very lucky to have a great speech pathologist, Beth Dorenzo. And, you know, we'll try to start doing things in that initial visit. And a lot of times we'll figure out if they're stimulable, if we can get some normal voice out. And then if we can that first time, like a lot of times they'll walk out of the room late, I'll leave the room and then they'll come out 20, 30 minutes later and they can talk normally, which is amazing, right? But sometimes it takes several sessions. Yeah, what are the, do you guys do laryngeal manipulation? Yeah, massage, you want to talk about that a little bit?
Sure. That was kind of the first thing that popped into my mind. Like I'd want to be touching this woman's neck, be looking for signs of extrinsic laryngeal muscle tension, in particular feeling for signs of tenderness, palpating the hyoid, superior border of the thyroid cartilage, if the patient says, oh, that's tender, that's an indication to me that there may be some extrinsic laryngeal muscle tension. And if they can tolerate it, I may try some laryngeal reposturing. For example, there's a hyoid push, so I can gently push the hyoid back and see if asking the patient to produce voice, ooh, humming, and really making it impossible for them to produce voice with the muscle tension pattern that is sustaining the dysphonia. So if I can make it so difficult for them to continue that pattern, we may get some good voice. And if we can shape that over 10, 15, 20 minutes a session, that's when that patient can leave with a normal voice. And you talk about satisfaction. You feel like that's amazing.
Yeah.
So this is definitely someone I'd want to feel. One of the things that I think was difficult during COVID when we were doing so much telepractice is we couldn't do those manual techniques, so I'm really glad to be back in person.
Yeah.
It makes a big difference. I think it also helps with buy-in, if I may add, like making sure that the patient feels reassured, they feel validated during the motivational or trauma-informed interviewing, depending on the patient's needs, is that you're acknowledging that their symptoms. And then you're treating the physical manifestations of them. And if you are making headway, it's very validating to the patient, like, oh, this can work. You get that buy-in, you develop that rapport, and you've got a path forward.
Yeah. So in the interest of time, I'm going to move on to this one. So this is that same patient. I can't remember if it was the same day. Sorry.
One more time. Very good. Say
Same day or like after one session? Pretty much normal voice. Yeah, right? So the key is making the diagnosis and knowing to send them to the speech pathologist, really, because I can do a little bit. I'll do a little bit of laryngeal massage, and sometimes I'll get a little bit, but I don't have the time to do it, and I don't have the expertise as opposed to these guys. So I think I will leave it at that for this. I was going by that clock that's counting down that says I still have a minute and 40 seconds, but the clock says 12:05, so I'm into the lunch hour. I'm sorry, I didn't realize I was watching that. Do you guys have anything to add before we finish this session?
Well, in Arizona, we're pretty limited in who we can administer speech therapy to. So for the Medicaid population, we're pretty tied in our hands. So unfortunately, while this seems magical, a lot of them can't even get the benefit of that.
Oh,
I know.
that's really
so then
awful.
sometimes I'm Botoxing the false cords to disable them.
I mean, there are tough patients that have MTD that we really can't get to break, and that's when they send them back to me, and then I'll try Botox, and usually that will work. But sometimes you really can't. It's a very difficult distinction between SD and MTD sometimes. And so if I'm not sure, I'll usually send them to the speech pathologist to do a trial, a few sessions, and see if we get anywhere. If not, then we'll do the Botox. And it's turned out that after a while, it's like, oh, this was early SD, LD, and they just end up getting Botox for forever, in perpetuity. So. All right, that's it. I'm going to finish up now. If you have questions, I'll stick around for lunch. You can come up and ask me directly. I don't want to delay lunch anymore. Thank you, everybody, for your attention.
Thank you, Dr. Singh.
we're going to get started here in just a little bit. I wanted to start off our rhinology session, give you a little brief outline of what we'll be doing. So the first part, we'll actually be focusing on chronic sinus disease, on nasal polyps. We'll have a short break, and then after that, we'll have a surgical talk, talking about frontal sinus anatomy, challenges, and complications. The one intertwining theme is truly our guest of honor, Dr. Jim Palmer. So Jim Palmer comes to us from the University of Pennsylvania, and we are so happy and grateful that he decided to accept our invitation. A little about Jim. Jim grew up in the Midwest, went to school at the University of Chicago, and majored in chemistry. So the University of Chicago, if you don't know, probably the most rigorous scientific institution. And you could have been like me and done econ or geology, but did chemistry. I think probably found his passion for science and for research. Then went to the Ohio State University, which you'll be very proud to talk to you about. And spent a year actually as a research scholar. I think that's when you thought you might want to be a cardiologist? Yep. Yeah. Thankfully, he turned to the correct side and is a rhinologist. But I think really at that time probably learned how to ask questions, really do good fact-finding, good evidence-based research, which he's going to talk to us about today as well. And then was a resident at Northwestern. Actually interacted with Dr. Conley, who was our guest speaker for the non-CME event. And since that time has been at Philly in Penn. And for those, I don't think I need to let you know, but Pennsylvania is probably the premier rhinology institute in the country. And I think Jim has a lot to do with that. He's really led this division. Got to train with Dr. David Kennedy, who was one of our former speakers. But then since then has really evolved this into a practice that stresses cutting edge clinical care as well as research. So 3 things about Jim quickly. One is he's incredibly inquisitive. You'll know that he really likes to dig into the depths of things. The second is that he's very confident as a surgeon, which is great. I mean, you want your surgeons to be confident, and he'll really teach us some of the tips and tricks that he uses in surgery, which we love. And then the third is that he's incredibly affable. So he's always got a smile on his face. I've gotten a chance to listen to him at multiple national and international conferences, and he does a great job presenting. So without further ado, Dr. Palmer will lead us off in improving outcomes in FESS. Thank you so much.
Eugene, wow, now I've got to actually try to keep up with that. So, all right, so for those of you that know me, I'm also pretty informal. So hands shoot up or grab me later, let's talk. I should put in the slight, I got to do my disclosures and my other thing, which is a lot of what I'm saying, I'm seeing by patient and so on, so please feel free to challenge it. It's my evidence base sometimes is what I see in front of me with the patients. Disclosures, Optinose, Acclarent. My favorite disclosure, I'm an employee of the University of Pennsylvania. It's always funny how we don't actually talk about that part, right? We're paid to operate to some extent. We should think about that. And a part owner company is directed toward topical therapies, but nothing's available. So people I need to thank for this article, there's Richard Harvey showing how to irrigate. He's doing it wrong, by the way. If you want to get on the web and watch my thing on how to irrigate, they'll be a little bit better. This is an old picture. Look at Cohen. I mean, he's still got all that hair is not white yet. Brad Woodworth, myself hiding in the back, bunch of our crew, Adapa, my current partner now, John Basso, whose slides I flat out stole for some of the biologic work, and I will freely admit I have changed. But the ones that are his have his name on, the ones that are mine, I say it's mine. So you kind of get a little bit of an ENT phenomenon. I've learned over the years I should just tell you what I want you to go home with thinking first, and then hopefully I'll give you enough evidence that you buy it. I want to convince you that the role of ESS or FESS, I actually don't use FESS anymore, I say ESS because it's not really the functional that they used to talk about, at least not in my hands. Its job is to open the sinus cavities to allow irrigation and placement of topical therapies. And I believe that you should either do complete surgery, I'll define that as we go along, or don't do surgery at all, especially in the polyp patient. My favorite line for people that say, I do targeted surgery, I say, I do targeted surgery too. I target every last ethmoid air cell. I target every last part of the maxillary. I target the sphenoid. I target the frontal. They're all open when I'm done. I want to convince you that topical steroid therapy and cure of the CRS patient is lifelong for success. The idea that we're going to interact with this cavity, clear it out, and then send them back to the same allergens and whatever it is that they were breathing in and think they're not going to go bad again, baffles my mind. And then convince you that biologics are for 10 to 20% of patients that need them. That's not everyone. So my philosophy is that CRS is a disease of poor mucociliary clearance with two major groups. Loss of mucociliary clearance secondary to congenital traumatic cause. That's a mucocele, that's a sinus. That needs to be ventilated, and you probably are done at that place because something closed it off. Poor mucociliary clearance due to inflammation from either a systemic or local cause, that needs ventilated, but it needs to be continually washed to decrease inflammation. And I'll talk about how we get there. Slide I made yesterday just for fun because I thought I'm starting to think about it this way when we talk about the biologics. Do you believe that CRS is a local disease with systemic manifestations, or do you believe it's a systemic disease with local manifestations? And where does the Venn diagram cross over for those? For me, I think CRS is a local disease with systemic manifestations, and there are a few times that it's a systemic disease with local manifestations. Our allergy friends might look at this the other way. So this gets sort of this, my surgical philosophy in evolution is primarily, don't do any surgery until you've really completed your aggressive medical management. I will define that for you. And then once you're talking about revision surgery, you really need to clear everything so the topicals can get there. If you want my recipes and stuff, just send me an email. I'll send it on to my scribe. My scribe will send you everything. If you don't have a scribe in this life, get a scribe. It's the best move I ever made. I have multiple scribes now. Okay, so this patient shows up to see me. She has the one thing that's the worst part when they show up. It's my wife's friend. And she tells me about how she's had 4 to 6 months of symptoms, multiple 10-day antibiotic courses, short courses of oral steroids, no irrigation. Let's just get a scan on you, you're here. So if you look, she's got a lot of disease, and she's even got some bony thickening. That goes to surgery in most people's hands. But it's my wife's friend. The last thing I want to do is operate on her and have to listen to her complain to me for so on. 4 weeks levofloxacin, steroid irrigation, BID, a large prednisone dose pack, 300 milliliters, 60 for 3, 40 for 3, 20 for 3, 10 for 3, and then stop. And that's her CT at 3 months of treatment. Now, she's still got a wicked deviated septum. Turns out she was a field hockey player. But her sinus disease is cleared up. And I see this over and over. And so this is my plea and sort of what I learned, that you really got to give them a lot of medical treatment. And a lot of times, that inflammation will clear out, the cilia will return to normal, and life will be better. She's a super taster. That's a whole nother set of lectures which you will not hear today. I apologize. CRS pathophysiology. So if you think about it, OMC blockage or primary mucosal inflammation. So these are the patients that have CRS in general and polyposis in particular, and this is the group we're going to talk about more so. If you think about the history of sinus surgery, and the history is defined by me, I recognize it's not exactly going to match up to everybody. Pre-80s, we really talked about infection and obstruction. That was before the era of FESS. Then in the 80s, we're starting to talk about inflammation. That line starts to blur, but we're still really talking more about infection and obstruction. And now I would tell you that I think we're believing that inflammation is the majority of what we see. It may also be that the infection and obstruction group is being taken care of in the office with balloons, and I'm just not seeing them. And that would be fine too when you think about it in the big picture. So in the early days, surgery goal was relieve obstruction. The mucociliary clearance would magically return to normal. This is David Kennedy. This is a slide I got from him. This was at his second sinus surgery course. And it was all about the osteomeal complex back then. And so you've got obstruction in narrow channels of the osteomeal complex. Is it anatomic? Is it mucociliary abnormalities, particulate deposition, viral alveolar infection, persistent localized inflammation? And they blocked up the osteomeal complex. If you fixed that, everything was better. If you cleared up those sinuses, everything got way better. And so the problem with that concept is we see these patients all the time. That's an open OMC. There's disease in the OMC. Here's clear sinuses behind. So it clearly is not just a backed up one linchpin phenomenon. And this isn't just anecdotal. This is when Rick Chandra was still at one of David Conley's partners at Northwestern. They went through and looked at a bunch of their patients and saw that, yes, this is just not the case. So we see disease in all sorts of places. It's just not the osteomial complex itself. So if we go back to this sort of history of how we look at things, I like to suggest this part. If an effective systemic anti-inflammatory had tolerable side effects for long-term use, surgery might not be needed. And our allergy friends would say that's where the biologics fit. And I'll talk about, I think that they're right to some extent. Surgery goals remove the inflammatory burden and then allow topical medications to dampen or prevent the return of inflammation. Local treatment is better. And that's really where I want to come down to, and I want you to think about it across the board. If you believe that chronic sinusitis is a local disease with systemic manifestations, better to treat it locally and take care of it and let those systemic manifestations happen. That's me in the Dead Sea. Had to have that picture taken. It's always got to be in any talk that talks about irrigation with saline, because that's your base for irrigating. So post-surgery irrigation, P.J. Wormel brought this out a few years ago. I'm not sure how he managed to make it 3.95 millimeters as his measurement. Bottom line is, big holes allow surface tension to let your irrigation get in there. Small holes do not let your surface tension in. Relatively obvious. So this is the way I think about FESS today, and I got to give David credit. He had it on his slide. I think what we're dealing with is persistent localized inflammation. However you get that inflammation, whether it be allergy, whether it be pollutants, whether it be whatever it is that causes it, this is your issue. And if you can get that taken care of, everything else gets significantly better. So it's nice to see it on that slide all the way back then. So when I'm thinking about surgery in the big picture, you know, I've got polyps here and rhinosinusitis here and infection obstruction here. What I think is probably the majority of what we're dealing with is inflammation on a lot of these patients, certainly in the polyp crew. And so those are better done with a wide cavity, removal of inflammatory products, and topical access, while the minimal techniques work when it's infection obstruction. And so we've gone over this again, but what I want to do is think right here. Poor mucosary clearance due to inflammation from either systemic or local cause. I don't want to just ventilate. I want to continually give therapy to decrease return of inflammation, either local or systemic. I would prefer to do that locally if I can, because I think that's going to get us better off. So this is a happy patient with an ideal cavity. Everything's wide open and they look good. Here's the same patient, intermittently symptomatic, and then gone bad. And you'll notice this is actually the same one. He just stopped irrigating with his steroid irrigation. So let's talk about how we got there and the sort of thoughts of steroid irrigation. And these are the patients that sort of taught me this. 45-year-old male, 3 previous sinus surgeries, presents with nasal obstruction and polyps, no other pertinent history, negative allergy workup, no asthma, no AERD. Here he is in 2004. And you can see right there, so don't worry, it is 2004. A lot of polyps. I took him to surgery, cleaned him up, put him on mometasone nasal spray, because that's what I had in 04. Daily irrigation with saline. Over the next 4 years, multiple oral prednisone tapers, progressive return of nasal obstruction, and there he is in 08. Suddenly I'm thinking I'm a terrible surgeon, because he's regrown his polyps and things have gotten worse. Now this is 08, right around that time period, 06 to about 08 is when Alex Chu and I, you'll recognize that name, sort of switched over from dripping steroid into noses into putting into the irrigation bottle, and it started working great, and all of a sudden we wiped out a lot of our recurrent polyp patients. Don't worry, there's always been more for us to keep up with. So I took him to surgery then. Here's his video 13 years later. And all I really did was just clean up those polyps. And back then, I was still leaving turbinates and not doing quite as much surgery as I'm in some ways doing now. But what you're seeing is that mucosa is cleaned up. So he irrigates once or twice a day with a steroid wash, and everything settles down. And so what I'm doing is I'm daily treating that inflammation, just like Richard Harvey was irrigating at the beginning of the talk. I put everybody on lifelong steroid irrigation. It's a steroid that's not systemically absorbed. We've got good data showing there are no side effects with it, and that will fix and make sure a lot of things go well. If you compare it to steroid spray across all things, there's even randomized double-blind controlled trials showing that it's significantly better. So here's conventional spray not doing well in terms of the SNOT 20 going out of time. Here's budesonide irrigation. That spot right there, interestingly enough, is delivering steroid high into the cavity. So this exhalation delivery system that I work with, it's available to you, that actually works quite well too. It's known as the Optinose product. And so if you look at that, it's about 20 points better on a SNOT 22 running out long term. And so that's very exciting to me. We have a couple options on how to deliver steroid to the cavities to keep them in good shape. And as an advertisement for my frontal sinus talk, this is a computer flow dynamic looking at the ethmoid pre-op, and then this is after a draft 3, same patient. Look at how the steroid wash gets into that area. And so really, on many fronts, I'd like you to think about complete surgery, meaning open up every ethmoid air cell, opening up the frontal widely and making sure you've done things so the irrigation can get to those sinuses. You will do significantly better. 34 patients, lifelong history polyps, 3-year follow-up, just a 9% recurrence of polyps, not even going back to surgery. These are AERD patients that we know have this issue forever. So a good clean out plus topical placement of steroids, lifelong, really can get you significantly better. Okay, now let's get to the biologics part, because I promise that's what we're here for. So if you're looking at all the CRS phenotypes in the USA, that's the big numbers. Here we're talking about polyps, 400,000, AERD, 4,400,000. These are the only ones that you should really be thinking about with a systemic biologic for. And only 10 to 20% of them need a biologic. And so unfortunately, I think we're being taken crazy by big pharma. So let's look at prices. Dupilumab, mepolizumab, benralizumab, omalizumab, $50,000. What surgery plus aspirin desensitization plus budesonide lavage and aspirin? That's a massive difference. In terms of FDA-approved biologics, these are the studies that have demonstrated them. And so I'm going to sort of debate surgery versus steroid irrigation a little bit. This is a slide from a previous debate that I gave. If you're thinking about biologics or you're thinking about surgery, if you do complete endoscopic sinus surgery plus lifelong topical corticosteroids to the majority of sinus surfaces, which means you have to have done surgery to get it there, that's superior to dupilumab because it's faster, more effective polyp removal, and it's cheaper. And the caveat is 10 to 20% of those polyp patients will benefit from a biologic addition. And that's in our group at Penn, too. So I consistently find that when we go back to BASO, how many people are we actually putting of the polyp patients with AERD and all the other big issues, what percentage of those are going to biologics? 10 to 20%. So a slide from Klaus Balkert, looking at the general adult population, asthma, severe asthma, prevalence of nasal polyps. So if you have polyps and you have severe asthma, that's the group that we really should be thinking about for these biologics. And it's probably 10 to 20% of the whole group. So of the 4 million polyp players we've got in the States and the 400,000 AERD people, 10 to 20% of them are biologic people. So we put together an interdisciplinary expert panel talking about this whole thing, and I'll leave it for you to run through all these things. I just want to point out a couple things. One thing that scares me about it all is we say, okay, sinus surgery, and then once you've done sinus surgery, you can real quick run over to biologics. And what I see a lot is people doing partial surgeries and not doing lifelong topical steroids and then saying, oh, you failed, now let's go to a biologic. We don't know what the long-term outcomes of those biologics are going to be. They're still new for us. And we do know what the long-term outcomes of steroid irrigation are. And fortunately, they're small. So indication for biologic treatment in CRS with nasal polyps. This is taken directly from John Basso. And we're looking at type 2 inflammation, systemic corticosteroids, quality of life, loss of smell, diagnosis of comorbid asthma. And this is Palmer's sort of review of what we're thinking here. Evidence of type 2 inflammation. So high eosinophils, that's going to make me more likely to give them long-term steroids, to give them steroids post-op and then topical application. But we're really worried about the systemic symptoms. If we say presence of bilateral polyps in patients who had ESS, what was the quality of ESS? And it's interesting, this is coming from Witzke-Falkens in Europe. They're not irrigating with steroids. And if you've ever irrigated, had your patients irrigated with budesonide, or I'm actually using mometasone now, you will find a massive difference in these polyp patients and how they're doing. Need for systemic corticosteroids or contraindication of systemic corticosteroids. I know we want to avoid our steroids, as Dave Conley pointed out nicely in the lecture before, but my insurance company won't even allow me to go to surgery without one course of steroids. And now we're already saying, oh, we're another thing to take us to the biologic. Significantly impaired quality of life. Systemic symptoms do matter. So it's the systemic symptoms that are going to push me towards thinking about a biologic. Anosmic on a smell test. In the era of COVID, it's going to be really hard to know why you're anosmic realistically. And I think we've all seen that in our offices. And then diagnosis of comorbid asthma. Asthma needing regular inhaled corticosteroids. We'll have an allergist talk later. To me, that would make sense if it said uncontrolled on inhaled steroids, because I see inhaled steroids as being a very useful treatment for these patients. So if we look at the inflammatory endotypes, we do know that the polyp crew is mainly a Th2, which is when we think about steroids or we think about biologic mediators. So let's go over the approved biologics and sort of how we're handling them and how they're fitting in. So dupilumab, that's a monoclonal anti-IL-4, blocks IL-4 and 13 signaling. Omalizumab, anti-IgE, Mepo, anti-IL-5. All of them approved for chronic sinusitis with nasal polyps. So sort of my summary on how I think about them, for better or worse. I go to dupilumab if the polyps aren't controlled with good surgery, steroid irrigation. If those patients have bad asthma and they have a lot of local eosinophils on the tissue. If you haven't done this, you should talk to your pathologist. You can send me an email, I'll send it to you. Richard Harvey did a really nice breakdown of how he has his pathologist go over every case that he does. We do that at Penn. We made a couple small changes to it, and all of our pathology reports come back, and our pathologist doesn't just say chronic sinusitis with inflammation. They say how many eosinophils per high power field, leukoplastic versus eosinophilic type inflammation, and they break that all down for us, which can give us a key for where we're going. It's certainly far from perfect, but it's the beginning of giving us an idea where we are. So if I have somebody with a lot of local eosinophils on their pathology and they have bad asthma, this is one that I'm going to pass to John for dupilumab. Omalizumab. If they have an IgE problem such as AFS, I think this is a nice add-on. The funny thing is, to tell a story, way back when Palmer and Alex Chu are sitting in our offices at Penn, it's 2002. Xolair has just come out. Chu says to me, you know what we're going to do, Palmer? We're going to put a bunch of people on Xolair with polyps. We're going to prove that it takes care of all of it. We're going to write that article. We're going to be a New England journal. I said, all right, let's do it. Signed up a bunch of people, put them on Xolair. Guess what? Not much effect at all. Laughed it off, moved on back to our surgery life. Now, 20 years later, suddenly it has an FDA approval for polyps. So, yes, I think that there are cases when it's helpful and useful, but to try and use this FDA approval as what you're going to do blanketly, you know, Winston Churchill a long time ago said, lies, damn lies, and statistics, and sometimes I think that's the case. So just be careful when you start using these guys. Now, mepolizumab, if they have a systemic eosinophil problem as opposed to a local one, that does a better job with the eosinophils, and we'll go that direction. So those are sort of our three ways to look at it. So let's break down each of them. There's little cartoons that you need to see. Dupilumab blocking IL-4 and IL-13. So this is John Bosso's sort of way he thinks about these things. So if you take pictures of these slides, know that you can blame John, not me, for the thought process. So higher tissue eosinophils level correlate with positive response. Steroid-dependent asthma. That's your big key to start thinking about this thing. This is inhaled nitric oxide. John uses that a lot. Admittedly, I don't ever do that. His AERD crew, if he's not having success with aspirin, this is when he reaches that spot. Rapid regrowth of eosinophil polyps after surgery. Just make sure when you mark that one that it's because the patient was or was not irrigating with steroid, and how much steroids did you use immediately after surgery. Admittedly, for me, I'm 20 milligrams a day for at least 2 weeks, usually a month, and I'm doing it based on endoscopic view. I want to get that cavity to normal. If you don't get the cavity to normal, I don't know that you can really count this as now we're starting them to irrigate. So at least in my hands, surgery is opening up all the sinuses, clearing everything out, perioperative steroids, and we'll go over this in the next lecture, to make sure you've got everything clean. When you look with the scope and you see it good, now they transition to steroid washes or sprays. Those people will stay good. The only spray you can use, though, unfortunately, is the exhalation delivery system. If you have trouble getting a hold of Pulmicort or mometasone, again, send me an email. There's a mail order pharmacy out by King of Prussia Mall that I know the owner quite well, and he'll mail it to you for $100 for a 3-month supply, which is less than most of their co-pays for a lot of other drugs that they're using. And we've actually started to do this internationally too, because it really does make a difference. Sorry, I got out of the dupilumab lane there. I'm gonna get back on that. So those are the things we think about for dupilumab. Now, why does John say, oh, I'm not gonna use dupilumab? If they have peripheral eosinophilia, so that's if it's more of a systemic response, then you might move away from dupilumab. And the rest of these are smaller things to think about. Eosinophilic pneumonia, that goes back to the peripheral eosinophilia. And so in the setting with that, if you think it's more of a systemic issue, that's when you would move away from dupilumab. And then this other one, he's starting to find a lot of females with autoimmune disorders tendencies. He's running into trouble. We recently published an article of some of the side effects we're getting from our dupilumab crew, and that's starting to climb. Of course, with any use of any new medication, you're going to find that. Okay, omalizumab. Let's talk about that. Here's the standard cartoon, basically blocks IgE. When does John think about using that one? Strong allergy tests, of course, it's an anti-IgE blocker. High total IgE, of course, again, IgE blocker. Allergic asthma, allergic fungal rhinosinusitis. Now I have to talk about that for just a second because people say, oh, they've got AFS, we got to put them on Xolair. If you live north of the Mason-Dixon line, having practiced on both of those sides, so I was in Savannah for a year, it seemed like everybody had allergic fungal sinusitis with Fred Kuhn, and now in Philly, I'm sort of the local expert, so people come my way. What I find is if I clean them out really well, get everything wide open so the irrigation can get there, then every spring and every fall for the first 2 to 3 years of their time with me, they are at risk for going bad. And so I make them come see me right in the spring when it gets wet in Philly, because Philly's hot and humid just like Savannah all summer long, unfortunately. And so what I got to do is support them through that period of time, whether I clean them out endoscopically, give them a burst of steroid, make sure that I keep them good. Then we get to the winter. I see them in the fall right before we go into the winter, maybe another hit of steroid, maybe just a little bit of a clean up, make sure they're irrigating well, and then they do very well over the whole course of the winter because they call it Spanish moss, but it's really fungus hanging from the trees down in Savannah. Philly, it gets nice and cold, all the fungus dies. And if you pay attention to your patients, you'll also find that these patients are the ones that go bad when they went into their basement and were messing around with a bunch of books and there was fungus in the air. And you just say, hire some kid to clean that out for you so you don't go bad. So there's a little bit of understanding environment here for this part. But if they're not being controlled, it's time to roll out the Xolair. And then, you know, probably a better pregnancy choice if you have to, if they're planning pregnancy, to things to think about. So when does John not choose omalizumab? If they have late onset eosinophilic, again, if it's more an eosinophilic systemic, you need to move other ways. Low IgE levels, that makes perfect sense. It's really an IgE blocker. And then he has this postoperative rapidly growing eosinophil polyps because he's going to go dupilumab with that idea. And then IL-5 biologic modifiers. MEPO, we're just going to use that as opposed to going all of them together. What makes John choose MEPO? High peripheral eosinophilia. So again, I go back to saying it in my sort of simple mind. If they have a systemic issue that's eosinophilic derived, yes, this is so much better than giving these patients steroids. We've all seen them with the eosinophilic pancreatitis and the eosinophilic pneumonias and esophagitis and so on. This is such a great drug for these people. And so that's the way I think about those. When do we not choose it, or when does John not choose it? High total IgE, why? He would be using Xolair for that. And then predominant early onset of IgE respiratory disease. So all the things you'd think about, the reason why we choose the other ones. Now I do want to throw this out there because this is actually brought to us by our friends with dupilumab. And here's this baseline scan. And then week 24, after 24 weeks of dupilumab, they have that picture, and somehow that's supposed to be evidence of success. And no. If you brought that to me, I'm going to take week 24 to surgery and make them actually feel better. I'm going to take some polyps out if they have them, and I'm going to open up those sinuses. So just careful with how we're going to use these things. This is my chance to just sort of say, when they say, oh, failed surgery, well, it's really failed a complete surgery plus topical steroids and managed well. If they failed that, then yes, biologics make a lot of sense. And then, we got enough time. I'll real quick show this. So this is a draft 3 after dupilumab. Then these numbers are going up for me. So here's somebody that's on systemic dupilumab. You can see his frontal sinus is in bad shape. Look at his sinuses. He's actually irrigating with steroid also. And you'll notice the lower sinuses look okay where he's getting his irrigation, but everything else just looks terrible. Now I'm going to move us up a little bit here because this is not a frontal sinus talk. And we're going to start drilling, and look at all the pus and trapped mucosa. So you can give patients that have mucoceles, blocked off sinuses, biologics till the cows come home. If they don't have an ability to drain or to wash out those areas, they're just not going to do well. And so you're treating the inflammatory meteors that are trapped in the sinuses. And so in my mind, this type of patient is far better off getting a draft 3 up front and then irrigating with a steroid wash. And of course, I have to finish it off by saying in his situation, he no longer is on dupilumab. He's just washing every day with steroids, and he used topical steroids for his asthma, and he's doing beautifully. And so this is sort of the thought process I'd like you to think about, which is, are we treating the sinuses to their complete setting before we move to the biologics and take advantage of how good they are? And it's 10 to 20% of our patients. They're going to fit into that category who have nasal polyps. And so now we've kind of got him most of the way open. And then I'm going to go ahead. I'm just rotating flaps. We'll talk about that later. And then there's my elastic stents I like to put in. And then that's at 1 month. So that's when I'm going to start decreasing oral steroids and then follow him out with irrigations. And so to sort of get back to my summary for where biologics fit in, polyps not controlled with bad asthma, local eosinophilic tissue, those are the ones I think about dupilumab. Omalizumab, if they've got an IgE problem, such as AFS, that's when I start thinking that direction. Mepolizumab, systemic eosinophilic problem, that's when I start going that direction. And then I got to end with a cartoon. I worry about what our future is with biologics. What's the biggest side effect of the drug? Bankruptcy. So how does this all fit together? I know that there will be people who will say, well, if biologics, if they were free, you'd use them on everybody. And I worry about that too. You know, prednisones, while you can come up with the side effects that are there, I think we're also going to run into other issues with some of our other medications. So just careful with it as we use it forward. And that's all I have. Thank you. Okay. I'll give it, I always end up giving a long answer, so I apologize. So back with Fred Kuhn, we were actually taking bottles of mometasone, sticking a needle in it, sucking it out, putting it in an eyedropper, having him flip upside down into Meigen's position and dripping it in. And then get to Penn, started doing that, some success in some situations. And then Alex Chu's like, dude, we can get budesonide in these vials for a lot cheaper. Let's use budesonide. So we would just lie and say everybody had asthma and we were dripping budesonide in that way, and we would have them do that. If you have them drip it in like that and you don't make them irrigate every few days, they get these big old dry crusts of steroid goo that fungus grows in, so that's bad, so you got to have it irrigate. So at some point we just said, let's throw the steroid in the wash and see what happens. And lo and behold, it was fantastic. So that's 06 to about 15, 16. The guy who runs Advanced RX, not to be advertising for him particularly, calls me on the phone and says, hey, I can get you mometasone for the same price as budesonide. What do you say? Let's switch over to mometasone. So that's why mometasone. Mometasone is less systemically bioavailable. You're actually counting on budesonide. You're counting on some liver first pass effects to keep it from giving systemic bioavailability. So it's got less systemic bioavailability. And that, to my mind, same price, works a little bit, and it's a little more potent steroid locally. Works better, less side effects, done, same price. Yes? Okay, ask it again a little bit louder. How important is desensitizing a Samter's triad patient with aspirin? I will answer you with a story. I show up at Penn in 2001. I got these Samter's patients. I send them to my allergist. They don't really want to do much with them. I start looking around the Philly area. Nobody wants to do desensitization really well. I find out there's this guy named John Basso up in Nyack, New York, who did his fellowship at Scripps, who's doing desensitization. So I start sending people on the train jokingly to John. John starts desensitizing them. They're doing significantly better. We're talking on the phone. He's like, Palmer, I think what's doing so well is complete surgery and steroid irrigation. I say, John, I think what's doing so well is you're really aggressive with your aspirin. I mean, he's got him on 1325 a day, 4 aspirins a day to get to the right spot. And he's very aggressive. So about 2010, I had the brilliant idea, we got to hire him. So I started working on him from about 2010, finally got him to join us in 2015. We have one of the few AERD centers. He would tell you it's the only one that surgeons and allergists are side by side in practice. And Nitha Dadappa, my partner, who's the surgical director of the AERD Center, loves to tout a couple of papers. So he went through all of Palmer's old surgeries, passing back and forth the Basso at a distance, and he participated in that. And they had good outcomes. But man, with John across the hall doing the exact same patients, same disease burden, but the two of us together, significantly better. So my answer to you is if you're going to operate on an AERD patient, please find someone that's going to desensitize them. And if you don't, you're going to get to do a bunch more surgeries on them and you'll feel sad about yourself. Well, we'll get the numbers that we're talking about. And yes, thank you for saying, Eugene, that I am confident. Yes, it's really worth it. Yeah, so it's funny, like remember there was from about 2008 to about 2014, my email box was constantly getting filled with all these complaints of joint tears and joint problems and everything else with levofloxacin. And so I've done this in many meetings, so I'll happily do it again. How many people have actually had a patient have a tendon tear on them on Levaquin? Now, a lot of people put their hands up, and then I challenge them, because it's definitely possible. How many of them was it they heard it from somebody else, or was it that they actually saw it with their own eyes? And then that's the thing. So it's definitely there. And then I smile and say, okay, how many people have had C. diff from using Augmentin? Because that's one of the first things we change. And almost everybody, my hand goes up multiple times. So I think we got to think about all the different things we're doing to these patients with both antibiotics and steroids, and be careful. What does careful mean? If I put you on Levaquin, I do sit down and say, no heavy lifting, no working out for at least 6 weeks. And if they say no, they're not willing to do that, then I move them to a different antibiotic, and then I've got to caution them about things like C. diff. So I think there's no question those issues are there. I think they're rare, but they're there.
Because I've already been very intimidated. I saw your talk before and I thought, man, how am I going to follow this person? It's like there we go. Fantastic. Well, thank you again, Jim, for a very informative and really practical talk, which I really appreciated. There we go. Does that work? No, we'll just do this. If I just do slideshow, it should be fine. Hold on, let's see here. I can do this and swap displays. There we go. So I really appreciate how Jim was able to kind of talk to us about chronic sinus disease with nasal polyps from a surgeon's perspective. And I do agree that biologics have a role in sinus disease, and certainly not in everybody with sinus disease. And so I want to try and provide a little bit of evidence in some of our work that we've been doing on biologics as well as surgery in these challenging patients. So I do have some grant support. So I run a molecular airway lab to help understand why patients develop sinus disease. Noam Cohen is one of my heroes. This was really exciting to me because for us, or for me personally, I had always been wondering what's the next step for patients with inflammatory local or systemic disease. And I think a lot of our thinking has been, yes, absolutely treat local disease, but we really didn't have any therapies that treated primary molecular mechanisms. And so this is one advantage, and it's certainly just one option of many. So our first goal when we wanted to look at this, and I talked a little bit about this last year, was really what is out there. There are tons of papers on surgery. There are many papers on biologics, but which papers really look at outcomes in patients with sinus disease with nasal polyps? And so as a group, this is not me, we had a group of enterprising students, postdocs, residents, medical students. We screened over 12,000 records. So let me repeat that for you again. We screened 12,000 records. So we looked at abstracts, we looked at titles, we worked with a librarian, and that is a lot of records. And so thanks to Naru, who really helped with this. But after looking at this, we really only found 65 articles that looked at outcomes not longitudinally, but over the long term. And so what did we find with this? Well, interestingly, they were about half and half. So 32 papers that looked at this from a surgical standpoint, how did they look at outcomes? And then 33 papers that were in the biologic literature. Obviously, the biologic literature has exploded over the past couple of years. So one way to look at this is through quality assessment. So this is a heat map. So red is not great quality, green is very good quality, and yellow is kind of in between. And so when we look at the surgical studies, we see a lot of red in terms of random sequence, allocation, outcome assessments, data, and selective reporting. And why is that? And this is an inherent bias that I do as well. All of us love to write about that case report or that patient that we helped, that patient that we made happy. And we often have selective memories because, I'm sure all of us had those patients that we didn't help or that we didn't treat very well or that might have needed further therapy. And so when we looked at the surgical literature, we did see a lot of retrospective studies. And I think retrospective studies are very, very important. But they were often, my experience or, this is what happened or there was sporadic data. And so I do think that this literature was a little bit harder to interpret. On the biologic literature, we see a lot of green on this slide. And is this because the authors are that much better? No. It's because they needed to get FDA approval, right? And so in order to get FDA approval, you need randomized longitudinal studies, high-powered studies, so that the FDA will grant you approval for a new medication, for a new indication. And so, obviously these studies were of higher quality. But what this really got us to thinking was, in these 12,000 records, we were unable to really find what we need to do, right? The surgery versus biologic study. We had talked about a debate. And I would say it should be probably more than just a debate. It should be more evidence-based. And so how can we do this? And so we thought if this was going to happen, we wanted to do a study design that reduced bias. We wanted to really show people who did complete surgery. And by complete surgery, I think, opening up all of the sinuses, big ostia, and that's all our practices here as well, too. Looking at either a single surgeon or a single institution, and then looking at a single biologic therapy as well. More importantly, we want to look at standardized outcomes testing. So NPS is a nasal polyp score. Many of us may start doing this in the future, but I know that when I was a resident, I didn't grade polyps on size. We just said, yeah, they're polyps, and let's go take them out. But there is a graded scale, and certainly if you want to come to me with a question, we can certainly talk to you and take you through that grading scale. There's obviously the Lund-Mackay CT grading scale as well. That assesses how much a pacification is within the CT. There's the UPSIT. So this is a University of Pennsylvania smell identification test. These are 40 questions that are a scratch and sniff test. My nurses and MAs hate it when we do this. And why is that? Because when you open up the room, even after 10 minutes later, it smells like dead fish. So I don't know why you guys decided to pick dead fish as one of the smells, but I'd please ask you to change it to like cherry cola or something, because something that would be a little bit more tolerable. And then the SNOT 22, so symptom questionnaires. This is hard to do. This takes a lot of time. But hopefully what I've convinced you in this review is that we probably need to do this. We really need to look at our outcomes. Not all of us need to do, but certain centers need to do. And then we want to look at this over 12 months at least. And why is that? Well, I have patients of mine that I've done complete surgery on that have recurrent polyp disease, and they typically don't happen a week, 6 weeks, 3 months afterwards, but it can be a year, it can be 2 years, it can be 4 years afterwards. And again, just because you see polyps doesn't necessarily mean that they need to be symptomatic. And if you can treat them topically or with other therapies, I think it can be helpful as well. So this is our ideal goal. So we decided, you know what, nobody else is going to do it. Let's try and do it. And so this is a longitudinal study that we've started on our own. And this is a lot of work, but I want to at least show you what we're thinking about doing and what we've started, and show you at least the first year's data, because I do think it can be very enlightening. So our inclusion criteria here were you had to have bilateral nasal polyp disease, and they had to be of a total size greater than 4. So for those not familiar with the nasal polyp score, these are polyps that are hitting below or at or below the level of the middle turbinate. And these patients are going to have decreased sense of smell because all your olfactory epithelia are right at that recess where the polyps are. So they're going to have hyposmia, and they're also going to have significant disease on CT scan. Just as Jim had said, these polyps will block those drainage pathways, and then you'll get this mucosal disease and this inflammation. We excluded those with immunodeficiency, we excluded those with CF, and we obviously excluded those that we thought were tumors or cancers like inverting papilloma. And so we looked at these patients and we brought them in every 3 months. And just so that you don't have to, we ran all the tests. We did nasal polyp scores, UPSIT scores, SNOT 22, and nasal congestion scores. So how can I convince you that these were not just patients that had mild disease? Well, these are our demographics here, and thankfully, as Jim had mentioned, these are the worst of the worst. They have a high percentage of them have AERD. Very high percentage of them have asthma. This is really enlightening to me. Many of them had at least a single, if not multiple, sinus surgeries in the past. And because biologics are new, and I think this is a little unfair because I do see biologic failures, none had biologic therapy at that point. And so these, again, are patients that we're seeing at tertiary care centers that are the worst of the worst. So what were their symptoms like? Where they had really big nasal polyps. They had significant disease on CT scan. I think, Jim had mentioned that over 40 in terms of the SNOT 22 were criteria, and these were patients in the 50s and 60s, and they were certified anosmic. So less than, I think it's less than 17, I think, is anosmic, and then 17 to 20 is hyposmic. So they really could not smell. So I think everyone would agree here that these would meet the criteria of either complete revision surgery or biologic therapy. And so we let our patients decide, and I think in our panel following Dr. Carr's talk, we'll talk to you a little bit about how we counsel patients. But as a surgeon, this was really hard for me to do, right? I love operating, I love seeing patients, I love helping people immediately. But what I kind of put in the back of my head is I need to give patients all of the options. So I talked to them about surgery. I talked to them about biologic therapy. I gave them the advantages and the disadvantages of both. And I sat down and I said, what would you like to do? Amazingly, and I promise this is not fudged, half chose surgery and half chose biologic therapy, which is kind of cool. And so it kind of gives you the milieu of what's out there in our patient population, what are they thinking about when they get this, you know, I would say unbiased information. So the first thing is what happens to polyp size. This is what we're interested in, right? This is what we can see on our endoscope. And so for biologic therapy, what we found were that polyps began to decrease by 3 months. And so again, I apologize, in red are the biologics, and this is on a scale. The y-axis is the total nasal polyp score, and on the x-axis is time. So these are the times that we brought them in. So polyps began to shrink significantly at 3 months, but it really didn't go to its maximal effect until about 9 months. So this is a duration of time, just as Jim had said with that CT scan at 24 weeks. This is not something that's going to be instantaneous. And truly, I think that is the advantage of surgery, right? What you can do, and potentially even steroid-sparing surgery. You know, what you can do with maybe a whomping dose of steroids, we can do in a matter of 20 or 30 minutes by removing these polyps at their base. So with surgery, as expected, it removed all the polyps immediately by 3 months. And this is hard for me to swallow because I was a surgeon in this. Dr. Lay also contributed patients. None of his patients actually had recurrent disease, so that's why he's giving the surgical talk. But yeah, in 2 of my patients, I started seeing some polyp recurrence at 1 year. And if I never told them, they would never have known. You know, they weren't coming back, and none of my patients were saying, hey, I want repeat surgery, or I want to change my therapy. But from an objective standpoint, I had to say, look, you were a grade 1. You know, there were polypoid mucosa along your skull base on both sides. And so I would grade that as a recurrence. It's also hard to tell if they were using topical steroid irrigations. All of our patients go on topical steroid irrigations. We use budesonide, but I think I'm going to switch to mometasone now based on your talk. But it's hard to know how many people are actually doing that, right? But this is something that we stress. What about symptoms? So the nasal congestion score as well as the SNOT-22 are measures of how patients are doing day to day, week to week, month to month. And they really talk about, nasal congestion score I think is a little bit more specific for nasal polyps. SNOT-22 talks more about sleep, energy, fatigue, and smell. But both groups, thankfully, had improvement in their symptoms. And this is why I practice clinically, is that I love making patients feel better. And these are the patients that say, man, like I couldn't smell, I couldn't taste, and I actually never knew it until you either operated or I was on a biologic or something else, right? But you can truly make a big impact, and this is really showing that. However, at 1 year, the surgical group did show some higher symptom scores in biologic therapy. And perhaps that's a polyp recurrence. They didn't complain to me directly about that, but on the questionnaires, that's what it shows. What about smell? So I think smell is the most underappreciated sense, and we don't really realize that until it's gone. My previous chair was a huge wine fanatic, and he lost his sense of smell. He had probably hundreds and hundreds of thousands of dollars worth of wine, and he couldn't taste wine anymore. And this was a huge, I mean, it was just a huge issue for him. It's a huge issue for chefs that we see. It's a huge issue for people that love to cook. And the reason being is that taste is probably about 60 to 70% related to smell. And so both of these groups started at anosmic levels, and the recovery of smell was similar in both groups over time, although the surgical group did have a slight decrease at 1 year. Hopefully in next year's conference, I might be able to tell you a little bit more about how they do over 2 years, because I do think that we're gonna want to continue to follow this group in the future. So this is the elephant in the room that Jim had talked to us about, and I don't think we can ignore this. Again, my interest as a scientist is what is the data? How can we look at this? But you can't think about biologic therapy without costs. And so this is a recent paper, a multi-institutional paper actually, that had economists, sinus surgeons, epidemiologists, and they looked at the cost of dupilumab versus endoscopic sinus surgery in a wide group of patients, and they put a 36-year time horizon. And what they found were that the overall cost in terms of quality of life was 10 times higher in those on biologics versus those with surgery. Now, I will put a caveat. I don't want to put us into bankruptcy, but I will put a caveat that to our patients at least, I haven't found much difference. Nobody said they have a higher copay. And that's because insurance companies, as long as they meet these critical criteria, are covering biologic therapies as they are covering complete surgery. But I think perhaps if that changes, that could be a huge issue. But historically, I'll tell you, biologic therapies are not the most expensive medication that we have. I'm very, very used to expensive medications. And my previous work was in CF, and one of the most expensive medications are these immunomodulators. But historically, what I will say is, as we have increased competition, prices tend to decrease. I think scales of economy are really important as well too. So the 5 most expensive prescription drugs out there in the country right now are for orphan diseases. And what I mean by orphan diseases are, these are incredibly rare diseases in which they are life-threatening. This patient doesn't get on this medication, they are gonna die. And so those medication costs range in $1.5 to $2 million per year. Or another one is blindness, gene therapy, retinal therapy. I mean, that's another huge example. But if you can increase the scales of economy, if you potentially can increase this population group, I also imagine that likely some of these costs will decrease. Right now, a lot of the biologic therapies are every 2 to 3 weeks. These are injections, but perhaps if you change the dosage and the duration of this might also change. And we all know about drug patent levels as well. So typically a drug patent is about 20 years, but in reality it's about 10, because 10 of those years is actually part of kind of doing the testing and developing it and going through. And so, I think in our generation, there certainly will be generic options available. I will plug this. We are one of the centers that is looking into this as well. So we are running a clinical trial on a biologic therapy that you can actually inject every 6 months. This is going to be a double-blinded, randomized study. But that's kind of exciting because, it's not every 2 weeks. If it works, I don't know if it will, but if it works for every 6 months, then that could be really exciting as well. So I think that we are on the cusp of a revolution in terms of how we treat patients, and I think we are divided a little bit in terms of those, but I think we will come to an agreement. Hopefully some of the data that I showed was informative. It might help with how you counsel patients in the future. We'll give you some strategies as well in our panel. And I wanted to thank our wonderful group that was part of our process. Dr. Lay is amazing, so I really appreciate, Chris, you letting us go into your clinic, recruit some of these patients. He's a phenomenal partner, and he's going to talk to you in the next group about surgical therapies. Naru is one of my postdocs who's actually getting a PhD in clinical epidemiology, and he really looked at this systematic review. Shireen is our fellow. She's out there in the back. She's amazing as well, too. And she really helps sift through the major bulk of these articles, giving it a clinical sense. And then we've got fantastic people both in the lab as well as students that are sifting through this information so that you don't have to read 12,000 articles. Thank you so much. I appreciate it. Do you all have any questions that I can help answer? Oh, it was crystal clear. So now I'd love to introduce Dr. Tara Carr. Dr. Carr is a chief of allergy and immunology at the University of Arizona. She trained in both a residency and fellowship at Northwestern University, so we see a lot of Northwestern in Chicago here, where she developed her interest in allergic rhinitis and sinusitis. I will give a plug here. I think Northwestern has done a phenomenal job. Dr. Conley, you're certainly part of that group. I don't know how you do it. You must have 36 hours in a day where they're looking at clinical patients, surgical patients, really understanding the science of this. And she brought this to the University of Arizona. She's been phenomenal in this, and we're so lucky to have her as a partner. We also have a multidisciplinary clinic, just like Dr. Basso, just like Dr. Conley over there, where we're able to kind of go back and forth, send our patients, kind of converse through these ideas. And she's going to talk to us a little bit about the role of immunotherapy in nasal polyposis with the focus on our most challenging patients, those with AERD and AFS.
Thanks, Eugene. Thank you so much. I'm really happy to be here. I'm kind of jealous that I didn't get to talk about biologics, because biologics are something I think about all the time and I recommend all the time. Immunotherapy, as an allergist, I should love this, and it should be the major tool in my toolbox. More and more I'm finding that it's not. But that's okay. I think there is still a role for it, and I think we still find many patients who do benefit from immunotherapy. So Eugene asked me to speak today about the use of immunotherapy for patients with nasal polyps, particularly with these subset diseases, and so that's what we'll focus on. Not needing to preach to the choir, right? We know that CRS is very common. We know that a big chunk of CRS is the nasal polypoid form. And more with these chronic diseases, particularly the diseases that we're recognizing are more complicated or more difficult to treat. The disease nasal polyps might really be more of an umbrella term that describes different types of inflammation that's happening, right? Different molecular and chemical and cellular pathways. And so that's getting to this idea that there are endotypes of disease that are really driving the disease for that patient and may inform our therapeutic decisions at some point in the future. And AERD, aspirin-exacerbated respiratory disease, and allergic fungal rhinosinusitis are distinct phenotypes of nasal polyposis that kind of fit that criteria. They have a certain set of cells and chemicals and pathways that drive the disease as best we know. Really, potential for specific therapeutic interventions in these groups. In general, immunotherapy does have limited application for the treatment specifically of nasal polyps, but we'll talk about the exclusions to that rule. As Jim mentioned earlier, we have a couple of recent kind of consensus statements, almost guidelines to some extent, that we can look to that have been recently published just within the past couple of years. I've found these to be, great and informative, not limited to US, which sometimes makes it a little bit harder to extend some of the recommendations to our patients with FDA and some of the insurance limitations, but certainly really great summaries of where we are in sinusitis and our understanding of sinusitis, and also where we need to go. So I will pull some tables and recommendations out of these guidelines and other papers that I'll cite through and through. Klaus Bockert published this review a few years ago in Nature Review, and I think this is a really interesting thought that there's this healthy, kind of resilient, normal nasal epithelium, right? So there's all kinds of trauma to the nasal epithelium that our noses are experiencing every day, chemicals, pathogens, traumatic injury. And when that epithelium is damaged, the normal process of healing involves this epithelial mesenchymal transition, where the cells sort of separate out, they proliferate in space, they kind of make a nice covering of the epithelium, and then they redifferentiate and they reform those normal tight junctions. So the cells sort of wound heal properly, right? And then the next time there's an injury, this process can happen again, and in a normal process, you get normal reformation of that properly functioning intact barrier with hopefully nice ciliary function. Well, in chronic rhinosinusitis, this is not happening. Upon injury due to those same trauma, chemical, pathogen insults, this epithelial mesenchymal transition tries to work, but it just doesn't. And instead of the cells sort of proliferating and redifferentiating and everything being fine, there's this acanthosis, acantholysis pattern that develops in the epithelium, and then this secondary repair process that causes the formation of an epithelial barrier that's just not functional. It doesn't have the good tight junctions. It's not making the appropriate bacterial antibacterial components, and maybe doesn't have normal ciliary function, right? Which is so important. And there are a variety of different factors that might contribute to this happening that have been proposed in the literature, like some of the inflammatory cytokines that we know to be present in sinusitis, some genetic disorders, and some other characteristics that are consistent with a chronic sinusitis picture. So once you have this abnormal epithelial response and all this inflammation driving that, what does that actually mean? Well, what we find is that not everybody is the same, as I suggested before, and there are three major types of inflammation that occur in patients with chronic rhinosinusitis. There's this type 1 inflammation, which really corresponds with this type 1 Th1 inflammation, right? So you have type 1 helper T cells, you have cytotoxic T cells, innate lymphoid cells that secrete interferon gamma. Their effector cells are natural killer cells, regular macrophages, and this is sort of normal antiviral inflammation. In comparison, the T2 group of inflammation have type 2 inflammation. So you'll see helper T cells type 2 and innate lymphoid cells pumping out IL-5, IL-13, IL-4, and so inducing that eosinophilic inflammation, but also the IgE-mediated inflammation and getting those mast cells involved and the allergy involved. These are patients that may also have more asthma. They may also be more responsive to corticosteroids. And then type 3 inflammation is something that's a little bit newer and that I find really fascinating, this IL-17 pathway of Th17 cells that pump out IL-17, both in response to and affect down IL-6 and IL-1 and other pro-inflammatory molecules that drive neutrophilic inflammation locally. So here we have this piece of the slide that says these people are sort of responsive to steroids, type 2 biologics. We have the presence of IgE on mast cells and basophils. So there definitely is that allergy component that can be present in these patients. This slide digs a little bit more down into the inflammatory pathways, and not to spend too much time belaboring this because I know I'm not talking to immunologists necessarily, the allergic inflammation that happens in the nasal tissue can have a systemic component, right? So you have cytokines that are circulating all throughout the body and that are getting eosinophils recruited from the bone marrow. You have alarmins that are being released from the nasal epithelium that are driving a lot of this process. But you have formation of lots of different allergic pathways. You have allergy, you have eosinophils, you have basophils, and you also have these alternatively activated macrophages that kind of contribute to this process of fibrinogen cross-linking and the formation of the polyps. So then the question becomes, since there's T2 inflammation and IgE in nasal polyps, does allergen-specific immunotherapy improve the disease? And you go, well, maybe. I mean, there's allergy there. We should give allergy shots, and these patients may get better. So what is allergen-specific immunotherapy? Many of you probably offer this in your practices. If you don't directly supervise it yourself, somebody in your practice may. This is a process by which long-term exposure to an antigen to which somebody is allergic by type 1 hypersensitivity or mediated by IgE alters their immune response. And the most common ways that these are administered are either sublingually through tablets or drops or by shots, so which we call subcutaneous immunotherapy. There are 3 conditions required for successful aeroallergen immunotherapy. We can give immunotherapy for a variety of different things. The most common things are the things that we're breathing in the environment, which is aeroallergen immunotherapy. We also give this for venoms, for people who have had anaphylaxis to bee stings and the like. So for a patient to benefit from aeroallergen immunotherapy, they should have symptoms that happen when they have exposure to an allergen, right? So if they're not having respiratory symptoms when you're breathing in dog dander, is dog immunotherapy really going to help you? I'm not entirely convinced that it will. You also should have evidence of allergy against that antigen, and so we'll do skin testing and blood testing to try to confirm whether there's allergy there. And then the patient needs to receive a series of injections or sublingual exposure at an appropriate dose, potency, and for an appropriate period of time to affect those changes to the immune system. There's definitely a placebo effect of the injections, which is great if your patient benefits from that placebo effect. But the reality is that if you ask a patient to come in every week or a couple times a week for a shot, to sit for a half an hour after their shot monitoring for anaphylaxis, it's an awful lot to ask of a patient. I'm not sure I would be able to do that. I think some of our ENT colleagues who see me, it's great because we're like right next door, and so we're able to get it in sort of at lunchtime or in between patients. There are a bunch of different things that happen to the immune system when you're on allergy shots. Some of those changes happen right away, which I find to be really fascinating. When you're doing allergy shots, as you know, we start with little teeny tiny doses and then gradually ramp up over time. But even with those small doses, you start to get some stabilization of those allergic cells, of the mast cells and basophils. So they are less likely to react to allergen. And the more often and the more regularly you dose patients, you sort of maintain this stabilization of those mast cells, and that's this red line here. Also, within the first few days, you start to induce regulatory T cells, which are the T cells that start to shut down that immune response and that start to sort of promote a more tolerant or less allergic immune response. And then over time, you see that your skin test reactivity comes down, and that's preceded by your IgE levels starting to come down, but also by the anti-IgEs, like the IgG4 levels going up. So you lose your allergy, you gain tolerance, your mast cells become stabilized, and patients feel better. So there are no randomized trials for allergen-specific immunotherapy for chronic sinusitis with or without polyps that I could find. And there's really no great data to support the use, and this is stated in those guidelines. However, a lot of our patients who have chronic sinusitis also have allergic rhinitis, right? They definitely will have their polyps, but then they'll get worsening nasal congestion and drainage and sneezing and itching during the pollen seasons or because they got a new dog. And so treating that is absolutely valid, and as long as you don't promise your patients it's going to fix their sinusitis, I think you're good to go. There are two special circumstances where immunotherapy may be helpful, the CCAD and AFRS. So central compartment atopic disease is kind of a newer term. It's something that I wasn't very familiar with, but we had sort of been referring to it for a while. And it's the idea that you're having polypoid change of the middle turbinates or polypoid edema of the middle turbinates without a whole lot of effect of the lateral structure. So you're not really getting sinusitis filling up the ethmoids or filling up all of the cavities like you would with a recurrence of nasal polyps like you saw from Jim and Eugene's talks. But these patients are very likely to be atopic. And so what may be happening in these patients, and it absolutely requires further study, is that this type 2 inflammation that's happening when they're breathing in these pollens is just causing this polypoid change. These patients probably will benefit significantly from immunotherapy or Xolair, but allergy shots are cheaper, so you can start there first. And I think this is something that's a potential real great option for these patients specifically. Of course, needs further study. When we start to think about the allergic fungal rhinosinusitis, I think it's helpful to consider that there's the way that our bodies respond to mold really will ultimately determine what happens to us when we have that exposure. So it's our immune system. It's the way our immune system is functioning. If you're on the right side of this spectrum and you're immunosuppressed, if you're neutropenic because of chemotherapy, if you have bad uncontrolled diabetes, and you're exposed to the right kind of mold, it's going to cause a life-threatening disease, right? These are the invasive fungal sinusitis patients or the chronic invasive fungal sinusitis patients, very high morbidity and mortality, right? They just can't fight that fungal exposure. In our immunocompetent patients, if they have a fungus that sort of finds a place to live in their sinus cavity, it may just cause a fungal ball locally. And these patients, you know, it'll be like one sinus, like a sphenoid sinus, and it's all full, and you take out the fungus, and these patients are better. On the left-hand side is hypersensitive immunity, which is really a very, very, very pronounced allergic response to mold, and this is what causes the allergic fungal rhinosinusitis. So these patients have not only that kind of IgE-mediated mast cell degranulation, but they have tons of eosinophils flooding into their tissue. They have tons of lymphocytes and other pro-inflammatory cells that don't get shut down properly, and so really perpetuate this very, very significant immune response. So fortunately, this doesn't affect all of our patients, but it does happen, and it's certainly very common in southeastern U.S., right? It may be more common in patients of African American descent in North America, maybe lower socioeconomic demographic to some extent. These happen in younger people, females, and they're atopic. Often they have allergic asthma as well, and so you're kind of treating somebody who has this whole airways disease. And like I mentioned, they have eosinophilic mucin. You can often see hyphae in the sinuses, in the tissue. And when you do allergy testing for these patients, they'll be whoppingly allergic, hopefully to the mold that you found on their sinuses, but sometimes it's hard to get that confirmation. So these are the thick peanut butter discharge patients. These are the patients with this sort of inspissated, very high attenuation mucin. Their disease can be unilateral, but they tend to get polyps, and those polyps come back and come back and come back. So I think surgery is really important for these patients to debride the antigen, because the problem is not just the allergic inflammation, but that the inflammation is happening because that fungus is trapped in their sinuses. So if you get everything out, if you get out all that abnormal mucus, if you get out all of that fungus, if you flush it constantly and kind of keep it all clean, then these patients might feel well for a long time. And of course, if you're giving good topical drug delivery to that area, and if they're flaring and you can kind of give them that local treatment or short bursts of systemic treatment, I think that's great. We know that this is an allergic reaction to molds, and so the topical steroids are very helpful, particularly with flushes, systemic steroids. But these are patients actually who might benefit from immunotherapy because they're having an allergic reaction to the mold. So if you can get that allergic reaction to go away over time, you might actually give them significant long-term quality of life benefit, reduction of exacerbations, reduction for need for surgical debridement and steroids. And this was actually a level 2B recommendation from that EPOS 2020 guideline, which says that immunotherapy to both fungal and non-fungal, so all the other stuff people are allergic to, antigens in AFRS is likely to help them. Omalizumab may be an option for these patients. It's not an FDA-approved indication, so if they have comorbid nasal polyps, if they have comorbid asthma, you can get them started on it. I often use omalizumab for the lung counterpart of this disease, which is allergic bronchopulmonary aspergillosis, and I find it to be magic. So I look forward to giving it to patients with AFRS as well. And then finally, sometimes antifungals are necessary to help reduce the burden of antigen, although if you're doing really good surgery, hopefully not. So we'll move on to aspirin sensitivity in the last few minutes. I know we're okay. So aspirin sensitivity or non-steroidal anti-inflammatory medication sensitivity is reasonably common. This affects, fortunately, very few patients who have coronary disease, probably because coronary disease is very common. It affects a subset of people with chronic rhinitis, about a third of patients who have chronic hives, and about 34% of patients who have chronic rhinosinusitis with nasal polyps and asthma. And this is going to be our Samter's Triad AERD group. So this is about 10% of patients with nasal polyps in total. They tend to start early. They tend to be atopic, eosinophilic, and have alcohol-induced symptoms. So your patients may tell you that whenever they drink red wine or beer, they have worsening nasal congestion or they start to feel short of breath. This is a well-known complication or side effect of having AERD, and sometimes is the reason people are willing to get treatment, so they don't suffer. As I mentioned, these patients start out with sort of rhinitis. They can be allergic. You give them all the medicines, you give them all the shots, and they continue to get worse and worse. And their primary care doctor may never look in their nose, but once you see them, you do, and then they have nasal polyps, and then you elicit a history that the aspirin or the ibuprofen or the naproxen is causing them to have worsening symptoms. They may not bring that up to you. I think it's very helpful to ask of your patient because they might not put that together with the fact that this is a specific disease process that needs treatment. So what happens with aspirin or NSAID ingestion? There's a variety of things, and it can be different for each patient. We expect that the respiratory system is going to be the major place where people feel it, but it can happen just in the eyes. You can have red, irritated eyes and, runny, itchy eyes. You can have nasal obstruction, postnasal drip. Some of our patients get very severe asthma symptoms, like bronchospasm, sending them to the emergency room. Some patients get itching, flushing, belly pain, and cramping. So it can be really kind of a systemic reaction. Interestingly, the reaction to aspirin or NSAIDs happens like a couple hours later. It doesn't happen as quickly as you would expect if a peanut allergy or some other kind of allergic reaction. So the patient might not immediately put those two things together. Here's just a beautiful image of what a patient who has AERD looks like after they've had surgery and their polyps have recurred. So these recent guidelines recommend that you can actually make a diagnosis of aspirin exacerbated respiratory disease, which the Europeans call NERD, but we, in the US use that as a derogatory term, so we're not supposed to. But it counts for the whole spectrum of NSAIDs. If a patient reports that they've had respiratory symptoms, like more than a couple of times or with a couple of different types of NSAIDs, especially if they have nasal polyps and asthma, you can pretty much make the diagnosis clinically. If you're questioning that diagnosis, there's actually protocols for doing aspirin challenge, but there's not a good blood test and there's not a good other biomarker for presence of this triad. Why does this happen? Arachidonic acid physiology, which nobody ever wants to think about. Allow me to just wave my hands at you and say that people who have AERD at baseline have too much inflammation from arachidonic acid metabolism. They have too many bad prostaglandin and thromboxane. They have too much bad leukotriene. When you knock out the left side of this, which is the COX-1 pathway, by taking an NSAID, you're probably kind of shunting to the leukotrienes and losing some of your protective prostaglandins. And so you're bad even when you're not on aspirin, but then you take aspirin and things can get worse. And this is evidenced by literature that goes back years that shows that there is increased leukotriene producing enzymes in tissue of patients with AERD compared with patients who have other kinds of sinusitis. So how do we treat AERD? Well, we treat locally to start with, right? So patients who have asthma should get appropriate asthma therapy, inhalers. Patients who have nasal polyps should get appropriate polyp therapy, surgery, topical therapies. Leukotriene modifiers, even though leukotrienes are really important in this pathway, we think don't help. So, people often will get Singular when they have AERD. I don't find it to be that helpful. Please, if you're prescribing Singular or Montelukast, warn your patients about the risk of neuropsychiatric adverse reactions. I've seen patients become suicidal with this medication. I've seen patients with profound anxiety or depression develop on this medication, and if they're not aware of it, they won't know to stop it. Patients who have AERD should avoid aspirin until, of course, you decide that they need an aspirin desensitization. And we know that dupilumab and other biologics may play a role for patients with AERD. Quickly about aspirin therapy after desensitization. I think the reason that a lot of allergists don't do this is because it's kind of awful. I mean, I'm not going to lie. I know Basso, he's great. And we do this in our office too, but I don't like to do aspirin desensitization, and I'll tell you why. The purpose of this is to give people enough aspirin, not only to induce a state of tolerance to the aspirin, but also so these chemical changes start to take effect, and hopefully you'll sort of downregulate some of that inflammation that's happening. Tanya Laidlaw is doing a lot of that work, right, about why this works and what the immunology underlying it is, and it's all very fascinating. But the practicality of this is you take a patient who has bad asthma, bad nasal polyps, you put them in front of you, and you give them something that they're allergic to. You can give them starting at low doses, like 20 milligrams, 40 milligrams, but gradually you give bigger and bigger doses until you're at 2 pills twice a day, 2 325s twice a day. So it's a lot. The dosing increments are something like 90 minutes, 2 hours, If patients have AERD, they will react, and so you're just watching them to see when they do react, and then you have to treat them. And so it's not a benign process. It can sometimes take a couple of days to get patients on all of their doses. We do pre-medicate patients for this as well, put them on prednisone. Sometimes we'll start singular for a few days to make sure they're going to tolerate it okay. But what we do know about this aspirin therapy after desensitization, or ATAD, is that it seems to do a better job of slowing recurrence of sinusitis than it does shrinking the polyps that are already there. So you kind of hopefully will take out all the polyps for us and open up the patient's sinuses. This is like a leukotrieneectomy, as Larry Borsch likes to say. And then the aspirin therapy helps to sort of reduce the inflammation so that they don't grow back. There are lots of contraindications to desensitization. We don't do this for people who are pregnant. We don't do this for people who have really bad lung function. And we don't do this for people who get like hives or anaphylaxis from NSAIDs. But also just think about taking 4 full dose aspirin a day. There are lots of side effects associated with that. We have to watch kidneys, we worry about people's hearing, but really it's the bleeding, it's the fall risk, it's the GI stuff. And then of course, if your patient is non-compliant and they're not taking their aspirin regularly, they're more likely to have adverse reactions when they do take it. In one of the reviews, there's a forest plot shown that shows the data supporting the use of aspirin therapy after desensitization for patients with nasal polyps. And there's top is the SNOT score, and the bottom is symptom score. And you can see that, that for the studies that were included, it favored aspirin over placebo. So I think there is a role for aspirin therapy. I think you have to choose your patient very carefully. I think you have to be convinced that putting the patient through this process is ultimately going to benefit them. And if it doesn't, then it is a very inexpensive therapy, and we do try it. Mentioning the biologic treatment options for AERD, so the clinical trials for nasal polyps studying omalizumab, dupilumab, they included patients who had AERD. Fortunately, you could do subgroup analyses and post-hoc analyses and see whether those patients had the same benefit of the biologic. And again, this is a paper from Tanya, and she basically looked at the phase 2A dupilumab study for nasal polyps and separated patients out into, it's not really moving. On the left side is baseline, on the right side is at week 16, and then the columns are AERD, non-AERD, AERD, non-AERD. Placebo is in gray, dupilumab is in blue, and the AERD patients saw benefit from SNOT score, Lambda-K score, upset, nasal congestion, nasal polyp score, maybe as much or sometimes even better than non-AERD patients. So really supporting that dupilumab is an option for these patients. I didn't actually have a conflict slide. I consult for all of the biologic companies, so I'm equally conflicted with everybody. But there's good data supporting the use of this, and I think for the right patient, a biologic is a really good option. So in summary, allergen immunotherapy may be beneficial for patients with the CCAD, with AFRS, and patients with AERD, despite the fact that they have lots of T2 inflammation, don't benefit from shots, but they may benefit from this aspirin treatment after desensitization type of immunotherapy or biologic therapies to control their polyps. Thank you very much.
Any questions for Dr. Carr?
Please.
Anecdotally, I've seen low-dose aspirin work fine on tall patients. What's the data that says you have to do 4 pills a day?
That's a great question. So the question was, anecdotally, low-dose aspirin seems to do just as well as high-dose aspirin for nasal polyps. There were a few different studies that looked at aspirin desensitization for nasal polyps that actually kind of published their outcomes. And a lot of the earlier studies used different doses. So the doses that the studies that used higher doses had better outcomes than the studies that used lower doses. And I think there was maybe one study that actually did a dose reduction strategy. I do a dose reduction strategy for my patients. I have them on 2 pills twice a day. And then after about 6-12 months, if they're doing well, if their polyps are clear, if they're feeling good, we'll try to reduce to 3 pills. We'll do like 2 and 1, and then after about 6 or 12 months, we'll try to reduce to 1 and 1. And I go slow because I like to have a chance to see if the polyps are recurring and how they're tolerating that drug. I haven't yet been able to get down to like 1/325 for control of symptoms, and a lot of my patients are on either 3 or 4 pills a day because of their recurrence of symptoms. So, I can't I can't provide you any more information than that. I think it's an interesting intervention that we don't fully understand. Yeah, question?
So I use it kind of as a last resort, to tell you the truth. I don't really think that topical antifungals have shown that much efficacy in my practice. I think thorough irrigation, I think steroids. In these patients, I'll usually do a medial maxillectomy, and we'll talk about that in that case presentation as well. But big holes is what I do for these AFS type patients. Jim, what's your practice been?
I find no role for it. Probably about 2008 or so, my last patients that were doing antifungal irrigation, we let them slide off. And I don't even do itraconazole for them anymore either. But I do have that winter backing me up, quite frankly. So when you don't have the benefit of winter, although it's dry around here, how much fungus you guys got to deal with?
There's a little bit of water in our river right now. I don't know if you noticed. We actually had a little bit in August too. You know, it dries up for a few months and then we get a little bit.
So there you go. Yeah, but the thing is that a lot of those things were done out of desperation, and I gotta, being myself and being blunt, I think if you go back and look at those CT scans of those patients, they weren't cleared out as well as they could have been. I'll take a pot shot at you.
Sure.
That scan you showed of the AERD patient, half that ethmoid hasn't been cleaned out yet.
It was not one of our patients
of course it was
here
not.
at Banner.
You Peter Chris, but I'm just saying, and that goes back to the whole point of what I belabored for an entire half hour. If you're gonna do surgery so the topicals are gonna do the trick, do the surgery. Yeah.
Thank you so much.
Yeah.
So we're going to actually have a panelist of experts come up, and we're going to go over some cases together for you guys. Hold on, let me bring up my cases here. So we'd love to hear about your folks' expertise with CRS, with nasal polyposis. I wanted to introduce some of our panelists. Obviously, Dr. Jim Palmer and Dr. Tara Carr, you all know. Dr. Lay is one of the rhinologists on staff here. He's actually the director of the Neurorhinology Fellowship now. Congratulations, Chris. And he was our first fellow, so Alex and myself had Chris as our first fellow, and it's pretty amazing when the students are out surgerizing the teachers. And so he's incredibly gifted in terms of the types of surgeries and his outcomes. Also wanted to introduce Dr. Michael Marino. Michael is a rhinologist at the Mayo Clinic in Arizona. He did his fellowship in Texas, has a thriving neurorhinology practice. And so thank you for bringing your expertise here as well, too. And then, Dr. Conley, do you want to come up? You're more than welcome to come up if you'd like. I think we'd all love to hear your expertise if you'd like. Not to put you on the spot, but we'd love to hear some of your insight as well.
Oh, boy.
He can reprimand you. He's the only one that's... Or he can say, I taught him everything I know. So I thought we've got a limited amount of time. Maybe what I can do is I can show you some patients that we've taken care of, and I'll give some questions of how you would react in the situation or what you would do. We'd love your insight. This is an open, interactive forum as well, too. So if you folks have any questions, please throw them out there as well. I'm going to make sure I keep my eyes out. So we've got 3 cases that we can go through. Hopefully we'll have enough time for those. My first is actually perfectly in line with Dr. Carr's talk. So she is a 55-year-old nurse. She complains of nasal congestion, facial pressure and pain, postnasal drainage and loss of smell. And she had previous surgery 25 years ago. And she has had symptoms for over 20 years. This is somebody that's educated, that's in the medical profession, and had such a unusual experience 25 years ago. And I think surgery was a lot different back then. Stents, silicone, packing, gauze. And you know, we have an older population here in Tucson, and many of them first got surgery, you know, in the early 80s, I think, when we were, you know, I don't want to say trialing things, but probably it was different. And so she told me she never wanted to have that experience again. But over time, over counseling, I said, look, we've changed things quite a bit, and we did bring her to surgery. But for these patients that have maybe had prior experiences that left a bad taste in their mouth, how do you describe what we do in layman's terms? I mean, maybe for people that are out there in the audience that are kind of trying to describe sinus surgery to patients, they might have seen a lot of things on the internet now. In 30 seconds or a minute, how do you describe what we're doing and why we're doing it?
All right, now I know why I'm here, because I started operating 25 years ago. I mean, we used to put packing. That's probably the one thing. If people have had packing before, they're just terrified of surgery. So, the first thing I'll tell this person is that it's not the same. Without packing, you can't guarantee you won't do it, but you don't expect to, that it'll be a better experience. But you have to explain what you're doing, and I think you have to help them understand what you expect to gain from surgery, because what they want might be something different. So for example, this patient might be most upset about not being able to smell. And surgery alone, 50-50 chance, and it won't last long. Of course, topically treated afterwards, you get a little better chance, bringing other things into play, biologics, local steroid delivery, much better. So I think the thing I talk about is what they want, and then I tell them what surgery will do. And I might rank it out like, hey, the most likely thing you're going to get out of this is you're going to be less stuffy. Mucus, smell, who knows? And then you have to describe what the recovery is like. They have to be prepared for it. I have so many patients who want to go on an airplane and, net jets out to, Europe the next day or so. You have to rein them back in. So, you're going to be around a couple weeks. You need some post-op visits. But probably the most important thing for this patient, and Palmer has driven this home today, is that you have to let them know up front that you're going to do the surgery, but that's only half of the treatment. The other half of the treatment is their part of the job, and that is this careful, twice-a-day, head-down irrigation, or something like that. And if they don't participate in that other half of it, she's going to be like she was 3 years. She got 3 years out of this. So it's a conversation. We didn't know half of that 25 years ago.
Yeah, Dave first taught me how to do Caldwell Lux, and then I would take the rat tail and jam it in underneath the anterior turbinate, for those of you old enough to remember that pulling back point.
Rat tail is still on the tray at county.
The one thing to throw out there also, Dave covered it beautifully, but the one other thing I always think about with these older people, or whatever they are, that had surgery before and they don't want to experience again, is don't try to get them to go to surgery first time you see them. Give them some steroids, give them some irrigations, have them come back a few times and get to know you. Next thing you know, they're okay with it. And they don't, if you try to push people into surgery, it's not a good idea.
Yeah, I think it's building that trust.
I think the trust part is very key.
So I did end up taking this patient to surgery. We developed a great relationship, and she was one of our happiest patients. Because we counseled her, her congestion was much improved, and intraoperatively, interestingly, classic AFRS to me, really thick peanut butter mucin. Pathology was consistent with allergic fungal sinusitis. A lot of these Charcot-latent crystals, but interestingly, the fungal culture didn't show any growth. So I don't know how often that happens to you guys. But she came back 5 years later, had been doing immunotherapy, but stopped during COVID, had occasional postnasal drainage, and she wanted dental implants. So her oral surgeon, they did this full kind of, almost it was a cone beam CT scan, and they found this. And so not super symptomatic. She does complain of some drainage. She said, nothing like what I had before, but she's got this right-sided kind of thick mucus in that maxillary sinus. And so in these cases, maybe Tara, I'll ask you this question as well. Is immunotherapy important for specific fungal subtypes? I mean, is that something that when we're in surgery, this looks like AFS, it's, you know, our pathologist tells us this is AFS. How important is it for us to get a fungal culture and to specifically speciate that fungus?
That's a great question. The allergen-specific immunotherapy will really only change that immune response for the antigens that you're giving them, that you're exposing them to. So we use a mixture of molds, and so I know that the patient's covered for those molds. And you know, particularly when we do the testing, of course, we make sure to include everything the patient's allergic to. But there's 800 different molds that can cause human disease, right? And a whole subgroup of them that can cause allergies, so it's really hard to cover everything. And I think that might be a failure for some patients, why their allergy shots don't help for the AFRS, because maybe you're not covering the right mold. I think patients who have the fungus, like at the fungal culture, or who have fungal hyphae in their sinuses, to some extent, those are the ones that we're lucky about, because then we can really sort of make sure that we're targeting that mold. But I think for a lot of patients, we actually see, you guys say this is classic AFRS, and we look at the cultures and we're like, so we just test them for all the molds and hope that we're finding it. But you know, if you're not getting the shot for the mold that you're reacting to, then the shots aren't going to help you.
The fungal cultures are all over the place for me. And like, you look down at the Mayo crowd and smile and wink. It depends on, like in Rochester, Minnesota, Mayo was doing a different way of culturing fungus, so they found fungus on everybody. That created the whole fungal debate causing chronic sinusitis. It's a whole 25 years old now.
Yeah.
So I got to admit, I don't really worry too much about it, because I think it's more a function of your lab than anything else. This patient gets a big whack of steroids. I clean out that sinus in the office, and as I tell them, I refreshed your warranty. You're still good. Keep washing with steroid wash.
So I'm more and more convinced that AFRS is kind of a spectrum disease. Being here in Arizona and being a trainee in Louisiana and Texas, whatever happens in Louisiana and Texas is very different than Arizona. And so the fungal cultures are all over the place here, and sometimes they don't grow out, and I have a hard time putting that together, but the patient very much seems like, in this case, to have AFRS, and I kind of proceed as that's the assumption, and would probably do the same thing that Dr. Palmer just suggested here for that patient.
So a little embarrassed here. When I was in surgery, I knew that this was AFRS, and I thought maybe I can just get away with doing big enterostomies. And so when I saw this patient, she looked great, and then 5 years later, she's got a thick fungus, and I can't reach that anterior portion. And I'm kicking myself, and I'm saying, gosh, I really should have done a medial maxillectomy. So when we talk about complete surgery, and this is for any of the panelists here, we see AFRS, what do you do? Do you make the enterostomy as big as possible for all of the sinuses? Do you do medial maxillectomies? What are your thought processes? And you know, complete means different things to different people. So what are the thoughts behind how, I don't want to say aggressive, because I think that maybe has a negative connotation, but how open you want to make these passageways?
Well, I think, you know, being in the line of training from Palmer's lineage, I like big holes, big openings, because we tell all the patients this is for sinus drainage and medication penetration. But, you know, I think the AFRS is hard because during surgery, they're asleep. We could irrigate in there and flush and do a really good job. I think if it's a first-time case, make a big, large enterostomy, which our enterostomy, some other people call mega enterostomy. So that would be all of our enterostomies here at U of A. And then maybe for like this revision case, if you give them steroids, a lot of irrigation, topical, and they don't do well, then in that case, you're taking back to the OR, you're probably better off doing a modified medial maxillectomy in that case, because they already failed appropriate medical management, and you can't access that area in the clinic.
We struggle with this question all the time. With our AERD patients, everybody gets a draft 3 now, and it has been helping us a lot. Medial maxillectomies, we are not routinely doing a medial maxillectomy on an allergic fungal sinusitis patient, although now I'm thinking about it. The one thing I probably would do with this type of patient is, and we'll show some videos later about irrigation, is that sometimes we're not, when you're irrigating this this way. A medial maxillectomy does help it get better over in that maxillary sinus. But why aren't you having them put that sinus down, the one that's got the symptoms? Now, granted, she was gone during COVID, so I don't really see this. I see this as somebody that you lost track of, not lost track of, but you haven't really seen them on a day-to-day basis. But yes, I end up changing the way patients are irrigating based on the sinuses I'm trying to target. Draft 3 just only seems to do well in our hands, and there are very little downsides to it. We went through a streak of medial maxillectomies probably 5-8 years ago and had a couple spinopalatine artery bleeds out of it.
Sure.
And we're like, maybe not so often. We'll just do it for the IPs and things like that. So I don't know that I'm ready for a routine medial maxillectomy, but it might be a really good idea in some of these patients.
Yeah, I did end up bringing her back for a medial maxillectomy just on that side so that I could reach that area and get a good view just in case this recurred again. But talking about irrigation, I don't know if any of your patients are doing this, but a lot of my patients are coming and asking me about like these high-powered volume irrigation devices. I think, you know, if you watch football, they must be making a ton of money because they have commercials on for AFC and NFC football games, which is pretty incredible. So what are your thoughts?
My current answer is I got it, tried it out on myself, and Adapa tried it. We all irrigated with it, and then we stuck scopes up our nose to try to look to see where irrigation got. And I think the old squirt bottle actually is doing it just as well or better and doesn't. And it's easier to add medications to it and the rest. So I more or less tell them stick with the cheapy squirt bottle. That, and I can look in the squirt bottle and see if there's infection in it, and you know, all the rest, and you can get 3 for $25 at Costco. So we have not moved to the Navage stuff.
That gadget, I think it costs about $30 a month for their salt tablets that have to be put in it in order to activate it. But then I found a patient who took some glue to the buttons, glued them on, and just throws the regular Neomed salt rinse in there. But I agree with Jim. The squirt bottle is controllable. People can control the volume and the force, and you know, it's easier to get your head upside down at some point during that rinse with a squirt bottle. I tell people to hold on to something so they don't hit their head and fall in the shower, but it's individual. Most people do really well with the rinse. You know, I want to go back to your whole question about how much surgery do you do. For me, it's always a continuum. The more you do, the more complicated, the higher the risk. I mean, I took a patient back just Monday night this week for a sphenopalatine bleed after a megaantrostomy 3 weeks post-op. Yeah. So he also was starting his Eliquis, but you know, everything we do is on a risk-benefit spectrum. And you know, I think the day will come soon enough where we kind of have a better sense heading into surgery who needs the big all-out surgery and who needs a little more focused surgery. And I don't have that answer yet, as much as we try to study endotypes and how people end up.
So before that goes too far on the discussion, I can't leave it alone, Dave. Are you talking about not cleaning out the ethmoid entirely and saying, oh, well, there's some risks there?
No, complete ethmoid clear out, short of nicking the anterior ethmoid artery.
I think one question that comes up from a lot of our patients is when they're doing the irrigations, do they need to use distilled water? Do they need to boil the water? I tell my patients, if you're on a water that's on City of Tucson or some city processing plant, that it's okay to use tap water. But do others do something different? Because there's a lot of my patients on vacation, they will bring jugs of distilled water, which is pretty impressive, I think.
Yeah, it is, and I feel sorry for them because we're pulled in this trap because of like 3 cases, a couple in Louisiana and one in Washington State. So my paperwork says one thing because that's what I end up in court with, and what I tell them is something else slightly. So we're basically on the same page. I say I irrigate with Montgomery County water because I live in Montgomery County. But all our paperwork says boiled or distilled, and then irrigate with your own water if you want, or you know, half the time people have one of those. We have one now from Costco, the Deer Park, you know, drinking water. Just use that. What I do tell them when they travel, and I didn't realize this until later, and I kind of feel foolish for the years that they were dragging distilled water with them, if you can pop the top on the water bottle to drink it, it's okay to throw it up your nose while you're on vacation. So just that, or you take your Xhants and spray the Xhants while you're on vacation. So I give them both. They have Xhants and they have irrigation. Spray your Xhants while you're on vacation. I don't care. Irrigate, pop the top off the bottle. You're going to be fine with that. Just take your salt packets in your bottles with you and then add the medication then. And then there's also the throw up your hands and say, look, if this is going to be your one holiday, don't irrigate, come on back. I'll see you when you get back. We'll see how bad you are. I'll give you some steroids and you start irrigating again. I mean, at some point here, we have to be honest with, yes, twice a day is really important, but when you're 10 years down the line and I did your surgery in 2010 or whatever, are we really sure that we got to be twice a day? I tell this story multiple times in clinic, so I'll tell it now. So, Dr. Palmer, is twice a day really important? I'm like, I don't know. When Alex Chu and I came up with it, we sat and started doing it, and we're like, I don't know. Once a day doesn't seem like enough, and 3 times a day seems like too much. Let's go twice a day. So that's how the twice a day, mantra of, oh, you've got to irrigate twice a day came from. So I have tons of people that have dropped to once a day. I have tons of people that have dropped down to a few times a week. I will regularly tell them I'm seeing them today, and they're twice a day, and they look fabulous. And I say, you look fabulous. Do you want to stick to twice a day? You want to drop down? They go, I want to drop down. Okay, stay on twice a day until a month before your next appointment with me, whether that's 6 months, a year, whatever it is, and then drop to once a day, and I'll see you with a month worth of once a day. If you look bad, I'll tell you, bad, back on twice a day. Look good, stay on once a day. I mean, I think we need to be honest with ourselves here about, is it the wash? Is it the steroid? What's the dosing? We don't know. And there's so many variables that play into that. I think you just have to let the patients go where they need to.
It was just, I think, last week that CNN ran a piece on how dangerous these tap water irrigations are. Now, having grown up in New Orleans, I would not irrigate with Naegleria infected water. But I think its risk, it's pretty low, but you want to be careful. So, if I tell my patients if they want, they can boil the water and store it in a big jug and pour it out and do that every few days and not have to boil water twice a day or once a day or whatever Dr. Palmer tells us to do. Now, I am a little more careful with people who are immunosuppressed. So if they have HIV, pregnant, some kind of immunosuppression, cancer therapy, I mean, I'm really cautious with that. I do tell them use distilled or make sure you really boil water. There's no evidence behind that, but I just think I'm a little more careful because there is stuff in the water that bothers immunosuppressed patients. The CNN article had the wonderful line of, well, it's okay if you drink it because your stomach acid will take care of it, but you're putting this up your nose. So we're going to continue to face a lot of scrutiny from patients and the news media. And it'd be nice to have in your mind some kind of risk-benefit analysis of what is it to be 1 in 100,000, 1 in a million, 1 in a 10 million, because I think that's in the category we're looking at.
I think that's a study you should do, Dave.
I'll need all your patients.
Maybe going on that same vein, I think many of us are now using topical steroids in the rinse, and I think the discussions have kind of relayed that. I typically will do that for about 6 months, and then I'll start titrating down the steroids. And I don't know why. Perhaps it's maybe like my own feeling that, hey, you're doing good. Let's take something away. Do you guys do that? And then what are your, if you do, tell us maybe why better than my answer. And then if you don't, tell us why as well.
So Eugene, I taper down at about 6 months. If they look good, they're feeling good, you go to once a day. And my reason behind it is I hope it engenders better compliance for once a day because I'm making it easier. Otherwise, it feels to me, and I don't know if the patients feel this way, that they're like in some purgatory that I've put them in forever, and that why did we even do a surgery in the first place kind of thing. So I like doing that when they feel good, and I think it works out. I also let them be in control of it a little bit. You're not feeling as well? Go back up to twice a day. Really no harm, I see.
In my mind, if you're going to irrigate, add the steroid. The risks are so small, the benefits are so high. If you're going to go to the trouble to irrigate, add the steroid. I like Xhants so much because it's doing such a nice job. The deposition is getting to all the spots as opposed to like the standard Flonas's, those things, they're just being dumped on the inferior turbinate. It's really all about placement in my mind for the steroid. Flonase, the standard sprays are being dumped on the inferior turbinate. That's why they work so great for allergic rhinitis. That's where allergic rhinitis is the problem. And so I want the steroid further back. And so however the steroid gets there, I'm happy with that. You know, we've done so many studies, 24-hour urines and all the rest, and it just doesn't seem to be an issue. And then, you know, I think this is a patient issue question, right? If they are bothered doing twice a day, let's do once a day, see how you do. I like to have them do it in the shower. If they always make their morning coffee and they make their morning bottle of irrigation and then they get in the shower, compliance seems to be pretty good.
You know, Jim, I'm really glad you did all the studies because I never wanted to do them. And if you think about, let's take budesonide. I'm just going to do a very quick math equation. So if you rinse your nose with 0.5 milligram of budesonide in 240 mLs, probably 97% of that is immediately in the sink. Agreed?
Yes.
3% of 0.5 milligrams of budesonide is 15 micrograms of budesonide. So they're getting 15 micrograms of budesonide in their nose twice a day. That's 30 micrograms of budesonide. Rhinocort spray that's over the counter and also shown to be safe in pregnancy is 50 microgram per actuation. You do 4 of those every day. So do any of us tell people after 3 months of using Rhinocort spray, why don't you back off because you're getting steroids? I mean, we're talking about 400 micrograms of over-the-counter spray as opposed to 30. It's an order of magnitude less. So I was glad you did the studies because I didn't want to do them. The math says that, why are you worried about that? The FDA has already studied budesonide.
Any questions from the audience? I've got a couple more cases, but I feel like this discussion is almost more helpful and interactive than others.
He's lost control.
The question was, sure. So the question, just to repeat, was specifically for the nasal polyp patient, perhaps. We'll just use that as an example. Once you've done the surgery, are there any therapies that you will use post-operatively, perhaps steroid-eluting stents, spacers, topical antibiotic rinses, implants, those kinds of things that you found have been helpful? Am I phrasing that correctly?
I may be an outlier in this group, but here we go. Every summer, I hear about how we should do all sorts of different new eluting, dissolvable stents and things because I get a new set of fellows in. And so every summer, I throw up my hands, we do a few times, and by mid-fall, we're back to middle spacers, which is a sponge inside a glove finger, filling the entire ethmoid and frontal sinus stents, silastic rolled and tucked up in there. And the reason why I think that just those inert things just keep working so well is that they have really great occlusive properties on the mucosa. And I think that occlusive property is actually where the win is. If you go back to the 60s with wound healing experiments with pigs and the burns and all the different things, everything that always won was an occlusive dressing. That's why you put a Band-Aid on a cut. That's why you put Duoderm on pressure wounds. Occlusive dressings make healing better. And so every time I run these experiments, however you get an occlusive dressing on there, I think that's your best bet. At least that's what we found.
So I have no economic interest in this, but every patient gets Posicep in the middle meatus. And then if I don't like the way the frontal looks, completely unscientifically, they get what's called the Posicep vectra in the frontal. And I don't rarely use Propel very often. We have an abstract that will be in COSM where the vectras versus the Propels were the same exact outcome in those two groups of patients. So it's relatively cost effective, easy to debride, and keep it simple.
in my first 2 years of practice, I used the same packing that Dr. Palmer was talking about. I remember the first 6 months of fellowship was learning how to roll that elastic stent for the frontal sinus. That was harder than surgery. And I think when Propel Contour came out, I was kind of skeptical at first, but the more I've used it for polyp patients, I think we had some good results. It's very similar to the stenting, and I just think it's very effective in that patient population. And Posicept, I was a slow adopter as well, because I like to tell the patient we're not doing any packing, but I think over the last couple of years I've adopted Posicept, and it made the debridement a lot easier.
Do I have to?
Yeah.
So I have a conflict of interest with Intersect because I've done a lot of work in the trials on Propel. Having said that, Jim's right. The Penn way is to put this pack in the middle meatus, but my patients in Chicago are not as tough, and they don't like that, and they're really, they're miserable out of their head. So there's a way to get around that, and that is as follows. I stitch all middle turbinates across the septum with a single loop of 4/0 plain gut on a straight Keith needle. Until you do about 15 or 20 of these, you're going to be out of your mind, because it's the end of the case. The needle doesn't go through the septum. It's just but you'll get it down to the point where it takes 4 minutes. That stitch, surprisingly, stays there in almost all the patients for 2 months, and I have to take it out. It collects gunk, cut the tails short. That's how I deal with the middle turbinates without putting a physical spacer in there that holds them out of the way. Otherwise, you've got to stick something in there. You don't want to see those things lateralized. To treat the mucosa, I think it's a combination of an occlusive dressing, and I love steroids, especially for my type 2 inflammatory patients. Polyps are not. Many non-polyp patients are type 2, and they don't heal well. And for that, I like the Propel Contour in the frontal recess. I think there's plenty of evidence that shows us that improves the patency by roughly 50%. This is a place where we're all challenged. 40% of those stenose down if you're not lucky. Not Jim, because he drills draft 3s on all of them. But if you're trying to maintain a frontal sinus, that's a way to keep it open with some kind of local steroid delivery that lasts for about a few weeks. And then Posicept or some kind of polysaccharide gel. I don't care if it has chitin in it. That's a weird thing from shellfish. But don't use it in your shrimp allergic patients. They do not do well. They are inflamed and they bleed. But then you just suction all that out with an 8 French suction. And if you've got your middle turbinates pulled over, you can stick that 8 French suction in there without bumping into the septum or the turbinates. You don't torture your patients that much post-op. But I will give it to you that they pay the price on my debridement. They're more comfortable probably during that first week, but they pay the price on the debridement because no matter how well I have that open, people don't like you bumping into stuff in their nose a week after surgery, and you got to clean them out.
Very good. Well, thank you so much. Thank you, panelists. I appreciate all of your help and your expertise. We'll take a little break, and then Dr. Lay will lead the second session on frontal sinus surgery and advanced techniques.
So the weather's really nice out there. So are you really ready for 45 minutes of frontal sinus? I understand your reluctance, but anyway, here we go. You're gonna have to listen to me prattle on for a while. 20 years of evolution, or is it de-evolution? Disclosure is the same, no change. Again, I like to tell you what we're going to go to, so you know, hopefully you're convinced that complete surgery before biologics is the way to go. Either that or you ignored everything I've said, which is fine too. The surgical event should include and be influenced by your long-term care plans. The frontal sinus mucosa is the same as any other sinus mucosa except for its location. There's not something special and magic about the frontal sinus. So if that mucosa is the same, maybe we should be treating it the same in the way we do other sinus surgery. And so what's good for the ethmoid is good for the frontal. So if that's what's working and making things do well, that's what you should be thinking about. So I'm going to give you my history. So full disclosure, Dave Conley's back there. Fun story, first day of residency, I'm a second year, and as you can imagine, I bounded into the room all excited to be there. Dave's first day as an attending. We got a guy with a laryngopharyngectomy with gastric pull-up we were doing together. And you know, when you're a junior attending, sometimes you get the junior residents, so 18 hours later, we staggered out of that room, and we've been bonded since. We really weren't doing much in the way of endoscopic work at that time. We were doing lots of osteoplastic flaps. Did my fellowship in Savannah. We did a lot of 2A, 2B very aggressively for the frontal, but no draft 3. And the discussion, things that I learned from there, discussions always talk about was the frontal's embryologically an ethmoid cell. That's why I always say to people, well, why are you treating the frontal sinus different than the ethmoids? You're taking out everything to open up the ethmoid entirely. Why aren't you doing the same for the frontal? Frontal recess dissection cures most disease. That's what I was taught. That was wrong. Frontal recess dissection does really well, but if you're sitting in one spot for a long time, you'll see people go bad. Fred used to always say, why drill? Just do a good frontal recess dissection. I'll tell you why I think you should think about draft 3 in some of these patients, not all of them. There was a massive fear of the empty nose syndrome and that the middle turbinate was sacrosanct. And then didn't do any tumors in fellowship, 1 or 2 CSF leaks repaired with free grafts. And that is Dean Clerico, who was a fellow in David Kennedy or Penn in '93 wrote that, and it was like, oh my God, don't touch the turbinate. You're a turbinator, you're ripping it out. This is so terrible. I'm convinced over the years now doing what I do that back in those days, there were a bunch of people who did surgery. They would resect the middle turbinate, and then they'd scratch around in the ethmoid and call that a complete ethmoidectomy. And a lot of those patients had recurrent disease and issues, largely because their ethmoid wasn't addressed well. And they probably weren't irrigating, and they probably weren't doing anything else. And then those patients would end up in the fellowship people's offices. They'd look in the nose, they'd see no middle turbinate, and they'd see lots of disease, and they drew the line in their mind that middle turbinate out meant lots of disease. And that was the hallmark of a bad sinus surgeon. I don't think that is the case. Either that or I'm a bad sinus surgeon because I take the turbinates a lot now. And I'll explain why. So, been at Penn now for 22 years, 23 years, oh my God. I looked at my numbers recently just to see from our fellows. I'm doing 70 to 80 draft 3s per year. That's how often I'm doing them now and how I find that they work well. 50 to 75 intracranial tumors per year, 75 to 100 intranasal tumors a year, 30 to 50 of them are malignant. So that's a big difference. So that has changed the way I think about things. So I'll kind of throw that out there. For those of you that are old enough, you may remember Arsenio Hall. He used to always have a section in his nighttime, late night show called Things That Make You Say, And how come these tumor patients with everything removed don't get empty nose syndrome? If we're so convinced taking out the middle turbinates and doing a bunch of surgery creates empty nose syndrome, how come I take everything out for those tumor people and none of them get empty nose syndrome? Advertisement for the future, John Craig, who is our fellow in 2013, has been feeling this way. So we put together a group of us that take the middle turbinates routinely, and we're doing one of those nose scores, which is the thing to talk about empty nose syndrome, before and after surgery. And of course, we're finding that there really isn't doing it. So we're going to get that published at some point. Next thing, If steroid irrigation is what keeps people doing well for years post-op, why aren't we tailoring our surgery towards its use? So we're still talking about doing these drainage procedures. Why aren't we talking about irrigation maximized endoscopic sinus surgery? There was a period of time around 2000 or so when everybody had a new name for every surgery, and they came up with little IMESS. I'm not going to do that to you, but I do think this way now. Those two right there, that's Charles Tong and that's Pete Papagiannopoulos. They were my fellows in 2018, and that's our little going away fellows birthday party picture, whatever you say, graduation picture. And the reason why they get to be in the slide is somewhere mid-year they said, Dr. Palmer, I can tell you what year you operated on this patient based on what the inside of their nose looks like. And I said, no. And we started looking, and yeah, they pretty much could do a pretty good job of that. And it's because I've been changing, and when I say evolving, maybe I'm de-evolving, but I would say that endoscopic sinus surgery, at least for polyps, has evolved to more complete, at least in my hands, or is it surgeries changing to allow placement of disease modifiers, in this situation, topical steroids, to decrease recurrences while keeping local inflammation in check? That was a really long way to say, and they came up with Palmer 1.0, 2.0, 3.0, and 4.0, and yes, I realize that's kind of, well, sort of cheeky for me to describe surgeries based on my own name, but you were warned by that by Eugene. Okay. So CRS has strong pro-inflammatory origins. I actually would say both CRS with and without polyps, and I think steroid irrigation works really well for the patients that don't have polyps. I know we talk about polyps all the time, but even the Th1 crowd does better decreasing inflammation. You've seen this patient before. The reason why he's here is he was a classic Palmer 1.0. So till about 2006 or 7, I did bilateral all 8 sinuses. I did a full frontal recess dissection. Septoplasty is needed, middle turbinates preserved. Post-op, they got prednisone taper, Nasonex nasal spray, plus saline irrigation. And they went bad. Almost universally, sort of like they all did. I still remember somewhere around 03, 04, one of my patients came to see me who'd been operated on by, it was a pretty impressive trifecta. It was Lanza, then Kennedy, then Bolger, and now in my office, right? And I said, well, let's take those polyps out. We'll make you feel better. And I guess they're going to be back in a year or two. Oh, no, they won't. Guess what? They were back in a year or two. Because we weren't doing anything to change the local milieu of what she was breathing in that caused her to grow the polyps. And so this is why I like this national audit. This is 2006. Claire Hopkins and crew went over all the patients, and 11% of surgeries were back in surgery at 3 years in the UK. And they were claiming at this thing that it was okay to do nasal polypectomy, that was equal to complete surgery. And it's ultimately because lots of them were going bad relatively quickly. They weren't doing any good post-op care for it. And then this is the slide. This is 10 years. This was a while after. And you can see that if you're irrigating with steroids, your mucosa is clean, sharp, and that's a frontal that looks good. So what was it that was making the difference? It was the Pulmicort. Admittedly, I'm using mometasone now. I don't think it's a big deal. I don't want to bash budesonide use. It's just if I have a choice and it's the same price, I'm going to go for mometasone. So what was 2.0 in my life? All 8 sinuses cleared, full frontal recess dissection, septoplasty if needed, middle turbinates preserved, add on this steroid irrigation. And there are so many articles about how well this works. So many articles that say it's safe. We're even to the point of having meta-analysis. So at this point, I would argue if you're not irrigating with steroid, please start when you get home. And then after you do, you'll be like, wow, this is way better. It is way better. I think every sinus surgery patient should irrigate with steroid in the post-operative period. And that post-operative period starts the day they finish surgery and ends when they go to the grave. There. That's how long they should have it. So what about people that need to go to surgery? I'm thinking about surgery now. Well, I don't do surgery that stuff that can drain out because I see those patients usually improve with medical treatment. I apologize. Because their baseline mucosal clearance is not damaged beyond repair. And that's kind of where I want to get back to. If you get antibiotics and steroids and the mucosal clearance returns to normal, then your sinuses are going to return to normal function and you're going to do well. If you have some problem that's not able to handle that, you're going to keep having issues. And so now I do surgery so I can put therapeutic topicals in because the mucosal clearance is damaged. Sorry that how do I get these thoughts popped in there too quick. Let's do a basic science interlude for a moment. These are some Cohen slides modified by Palmer. So whatever the function of the sinuses are air-filled cavities in communication with the oral cavity microbes in the environment, and they have to self-clean. And sometimes I think we get away from that that's really all we're talking about. This filtering system has to be able to self-clean, and if it doesn't self-clean, you get polyps, you get backed up pus, you get fluid, you get obstruction, and you get miserable. And so if you can fix the self-cleaning aspects, they'll do well. And here's the fun slide of mucosary clearance. Instead of Mesolklinger dropping ash on a cadaver and watching the ash run around inside the head, this is a rabbit. This poor rabbit was sacrificed 24 hours prior to this because it turns out the cilia keep running further. And we just wanted to show, because this is back in the days when we were doing a bunch of rabbit experiments, that's the rabbit maxillary sinus. We're going to drop a little ink in there, and you're going to watch the ink go running towards the rabbit maxillary ostium. So this is what happens in a healthy sinus. So ultimately what we need to do with sinus surgery is get the mucosary clearance, i.e. the mucosa, the cilia, and the snot all to return to some version of normal so it sweeps out, and then people will do better. And you can see it sort of work its way out the door there. That's enough watching rabbits. So one of our studies that we did, this won the Cottle Award in '06, and really what it was doing is we were looking at it to see what happened with the cilia. Everybody has a different cilia speed baseline. We then said, let's stimulate it and see what happens, i.e. if you get an infection, you get a trauma, you get a challenge, what happens to your cilia? Controls, patients with chronic sinusitis, what happened? So we take out their sinonasal mucosa, put it on the rig, and you can watch those little cilia guys move. We would then stimulate it, basically just by dumping ATP on it and see what happened. So this is control. It bumped up over 50%. This is chronic rhinosinusitis. Didn't bump up much at all. Let's not worry about polyps right now. That's a whole nother thing. So we're looking at these two, and we say, well, what happened? What was going on here? Because this was just mucosa taken from patients and nothing different. So we take it out, and we checked for reversibility. It's not a genetic underlying issue. And we created this generalized trend. So if you take the mucosa out of patients and stimulate it, controls stimulate pretty well. CRS doesn't. This is 12 hours. This is 24 hours. This is 36 hours, 48, 60. The cultures kind of peter out at this point. What I want you to notice is when we kept doing this experiment, the CRS patients eventually worked up to be about the same as control, except we were changing nothing in the entire experiment, except we kept having to change out the media or the cells would die. So we're sucking the media off the bottom of the cells and then putting back things on. So we said, what is causing this? So our conclusion was blunted ciliary stimulation is reversible. So people with chronic sinusitis, they can get their ciliary function back. The next line is Cohen's, that is so Cohen speak. The working hypothesis was diffusible mediators, microbial factors, cytokines and chemokines negatively and positively modulate sinonasal ciliary adaptation to environmental stimuli. And he actually put that in the paper. And that word salad, if Palmer's saying it, says, so if you wash out the crap over time, the cilia get back to normal function. Which is kind of saying the same thing, believe it or not. We're going to come back to this. That was the end of our basic science interlude. That was going on in the background while I was busy operating on people and thinking about things. 2009, 2012, 14, somewhere there, we started taking out the middle turbinates removed to varying degrees. Why? If we were dependent on irrigation and big middle turbinates were blocking the irrigation and getting there, why was I leaving them? So prednisone, taper, budesonide, irrigation. So there's this surgery called nasalization that the French have been pushing forever. And sometimes stuff that in France doesn't really get to the States very well because they don't speak French and we don't speak French and they don't speak English. So it doesn't get into our literature very often. So Roger Jankowski has been the big pusher of this. And what he would do for nasalization, take out the middle turbinate, plus removal of mucosa down the periosteum, 22% recurrence versus complete ethmoidectomy with middle turbinate preservation, 58% recurrence. And I think that was right. He says it has to do with phylogeny and so on of an embryology of the sinonasal mucosa, I think it's just, if you take the middle turbinates out, there's a lot more room. And those are polyp-creating surfaces that are there no longer. And now you can irrigate right past them and keep things open. So let's do a quick case. 55-year-old female, no prior sinus surgeries, nasal obstruction polyps, computed prednisone, irrigating with budesonide. Here is her CT scan before surgery. She is a full house sinuses. This is 5 years out. I talked her into getting into the scanner just so I could show that. And let's look at her in the office. So we'll move that along so we can look at, there she is. Okay, let's look at that CT scan too, just so you can see both of them. And celebrate middle turbinates being gone, wide open everything's. So her irrigation is reaching all of her sinuses. There's still some middle turbinate there. It's varying degrees, but basically what I think about now is at the end of surgery, I pretend I am a molecule of mometasone being propelled into the nose via my squirt bottle. And I think about what's in the road and keeping me from getting where I need to get to. And if it's in the road, it's gone. And works great. Okay, so that's kind of where we are. So how about till now, 2014 to now? Bilateral all 8 sinus is cleared. Upfront draft 3s in selected patients. How do I select that? We will get there. Septoplasty if needed, middle turbinates trimmed. During COVID, I just took them out. And you know, I didn't notice there was a problem, right? Because we were all trying to operate or deal with things during COVID, and you didn't know if they sneezed on you, it was going to be a problem. How are you going to do a debridement? You need some room in the nose. They wouldn't let us spray people anymore at Penn. It was a whole big mess. So those middle turbinates just started disappearing on all of us. And you know what? The patient's been doing very well. So it, again, gave me more reason to go down this road of middle turbinate. If you're in surgery, if it's blocking things, it's okay to take it out. Post-operatively, prednisone, taper, steroid irrigation, plus minus exhalational delivery steroids. So Xhance appeared around that time. Start experimenting with it. As I disclosed at the beginning, I do a lot of work with them. And it seems to work quite well with the irrigation. What I tell patients is the Xhance leaves the steroid there, so I think that's probably good. David went over the numbers of steroid. Actually, when you irrigate, most of your steroid is in the sink, but it also has the mechanical cleanse. So I think irrigation's got the mechanical cleanse. I think Xhance leaves the steroid behind. I think both are good. I sort of see them as interchangeable. I let people do both. Steroid up your nose 2 times a day. I write them for both, but what I do say, caveat, you gotta irrigate at least once a week. I don't want you to just keep doing Xhance and leaving that steroid up in there, because I'm remembering my days around 2000 when we used to drip steroid in the nose, and then it would dry up into crust back there and fungus would grow in those crusts, and I don't think that's a good idea either. So you need to do some mechanical cleanse. Okay. So we're so fixated on irrigation. Can we model what happens in irrigation? So it turns out the U.S. Geologic Survey has computer programs that model how water hits a dam surface and stresses. I've worked with my collaborators, use a CT scan to create those surfaces, and then let's see what happens with irrigation. So that's John Craig, my fellow at the time. That's Kai Zhao, who is the researcher who's now at Ohio State, who put these things together for me. And then that is from a antique store in Jaffa. So this is a German textbook showing how to irrigate. You will notice he's irrigating straight up, very good, or she, I don't know. And then they're actually getting everything in there pretty well, 1860s somewhere. So irrigation's been around a long time. Okay, so that's me showing where it is. That's from our book. And this is irrigating whoosh, up around the choana, back out the other side. Now the things that I learned from this is more probably flooding the ethmoid than anything else, because you're not really, I used to think it shot in like a fountain. Probably doesn't, it's more of a flood. We'll do a case to illustrate. 34-year-old man, nasal polyps, nasal obstruction, severe frontal headache that's chronic. This is his CT scan when he showed up at my doorstep, 2002. What did I do with him? I took him to surgery. What surgery did I do? The surgery that I was taught and I thought was right. And so here's his before surgery irrigation. So this is coming up and around and going around the choana. This is if we're standing in the guy's neck and watching it shoot in the left side. What do you notice? It first fills up, goes around the choana, and eventually gets into the maxillary and around the other side. So endoscopic approaches for the frontal sinus. Let's talk about that a little bit. Draft 1, removal of the ethmoid bulla, which I always find it funny. That's not really a frontal sinus surgery. That's doing an ethmoid sinus surgery. 2A, removal of Augernazzi cell and the frontal recess cells. That is arguably your workhorse. Draft 2B, removal of the floor, ipsilateral floor. Draft 3, taking out the whole side in between, so taking out all of this central area there. Thanks to Kevin Welch for making that video years ago. So draft 1, go up to but not through the Augernazzi cell. To be blunt, I never do this surgery. If you're going to sleep for surgery, I'm going to take this down. There's our book that we took, that these pictures are taken from. There's Wolfgang Draff. Such a wonderful person. He was one of those guys that always was complimentary. Didn't matter if you were presenting something that he'd published 20 years before, he'd still tell you how great it was, that you were working on it and it was nice, and I want to always be like that. A few of us up in the line there, some looking different variations of younger. Okay, draft 2A, going into the frontal sinus. Draft 2B, taking off the frontal sinus floor. Let's do draft 2A, 2B on a patient, so we can sort of go through it step by step. So here, not a whole lot of disease here, and sometimes these videos don't have a whole lot of disease because it's easier. If there's too much blood and stuff, it's hard to see them. So let's move along. We'll do a draft 1. So that was middle turbinate. We're at the back of the ethmoid, so clean the ethmoid, and then you're looking up. We'll switch over to a 70-degree scope, and what I want to do is look at where the Augernazzi cell is. There's the Augernazzi cell. Behind and medial, we're going to slide up and in, and that's how you get to the frontal sinus. Why? The frontal sinus is embryologically the second ethmoid cell. The Augernazzi is the first, the frontal sinus is the second. By definition, it pneumatizes up, behind, and in front of. So that's why you got to take out that part of the Augernazzi cell to be able to get there. So we're in the process of taking that down. Lots of different instruments help you get there, 45-degree and 90-degree side to side and front to back through biting forceps. That's what gets called a Cobra forcep at Penn. It's actually a Balkert forcep. And what you're doing is you're taking your time to take down each of those little partitions till you can see the frontal, which is where we are right now, so that's nice. So that is a draft 2A, middle turbinate intact, gone in and seen into the frontal sinus. Now, what you'll notice, but not only notice because I'm pointing it out to you, is there are no cells in that frontal sinus. When there's no cells in the frontal sinus, I've now opened it up. It isn't that much different than a maxillary sinus or a sphenoid sinus. There's no partitions blocking irrigation from getting there. So that's when I stop at that point. If it's that open and there's no partitions, I'm good. Now I'm doing a draft 2B now. Yes, you can try and not take the whole middle turbinate, but I've learned over the years it's better just to go ahead and take the middle turbinate so you don't have a floppy thing falling down. And now I'm going to go up and get into this, take this ipsilateral floor down. Why am I taking this ipsilateral floor down? I'm taking it down because there's a cell hiding right under here, an interfrontal sinus septal cell. Now, admittedly, there it is. So if I had not opened this up, the irrigation is probably going to go here and not make its way over to there, that interfrontal sinus septal cell. And that's why I did a draft 2B. End of every case, this is silastic, slid up, and this is my occlusive dressing for the ethmoid sinus. And I put a little bit of Avitine in there just to keep the bleeding under control, and then I tamp it down and then leave that for a couple weeks. So that's draft 2A, 2B. So that's what I did for this patient that we're talking about. I did draft 2A bilaterally. 6 years go by, daily irrigation with saline and nasal steroid spray, severe frontal headache, which is episodic. He needs antibiotic and steroid 3 to 4 times a year. Let's get a scan on you, see what's going on. Feel like a terrible surgeon. That's 2008. There's some junk in there. It's actually not bad, but let's look at the scope. So this is a 70-degree scope. I'm going to look in the dude's nose. And what you're going to see is he's still got his middle turbinates. I did a draft 2A bilaterally, and I did get through the frontal cells that are in there. That's a type 4 frontal cell, and I punched through the top. So I know for sure that sinus drains because I have opened up everything for it to drain. When we go to the other side, you're going to see he's got an interfrontal sinus septal cell and a type 3 frontal cell. And at this point, I'm reminded when I showed up at Penn, and I would be able to recite all the different cells of the frontal recess because that's what I did with Fred Kuhn. David Kennedy looked at me, shrugged his shoulders, and said, "What do I care what their name? They all got to come out." I think he was right. So we've got all these different cells in there. except to get them out, I wasn't able to do that through a draft 2A or B. So I started him on budesonide irrigation. We're now 3 years later. He's continuing to have symptoms, but less. We still having trouble. Let's get another scan, 2011. Things look better. Remember, these are usually scans done when he's at his worst. Look at how good that maxillary looks. You ever thought to yourself, why does the maxillary look so good, but the frontal doesn't look so good? I think those thoughts sometimes. Anyway, let's do a patient that has done well. See, she's smiling. Draft 2A versus draft 2B. So this is a scope going in, 70-degree scope. We're going to turn middle turbinate, draft 2A. Nicely open there, draining well. We're going to go to the other side, and we're going to see draft 2B. So B is taking off middle turbinate and ipsilateral floor, and I did that for that interfrontal sinus septal cell there. The interesting thing is I've learned over the years that maybe those don't drain as well with just a draft 2A or 2B, and I'll show you why. So, draft 3, that's where we were going. There's Wolfgang draft, there's a picture of draft 3. One of my favorite patients because of all the eye makeup she wears to my office. Let's look at her draft 3. So, maxillary, sphenoid, ethmoid clear, spin the scope, that's nice. And she's doing beautifully. So, you know, for a lot of time before I started doing my irrigation models, there was sort of a mystical, why is the draft 3 work so much better? So here's this guy. Here we are, 2011. I've been taking care of him for 10 years and finally got him to surgery, and I'm gonna do a draft 3. Now, I'm gonna save you watching me do a draft 3 on this guy. I mean, there's that interfrontal sinus septal cell I was talking about. That's the incomplete dissection there. And I'm going to drive along to, here we go. Now, I'm cleaning out the frontal sinus here, and he's going to have a draft 3. So this is a person that I knew had a good drainage process because everything was open and it was draining. I had opened up all the cells, but I had not removed them all. Here he is, 8 years past surgery, no oral steroids or antibiotics, no episode of infection. He's just on Pulmicort now. And what I would say is, look how nice that maxillary looks. Look how nice that ethmoid looks. And when I look up at that frontal sinus, look how nice that frontal sinus looks. So what I really did was I made my frontal sinus look like the maxillary sinus, a big wide open with no partitions in it anymore. And because there's no partitions in it anymore, the irrigation's getting there. And there it is, looking nice. I'm happy, he's happy. So I think about this is visiting Turkey. This is one of the underground cities in Cappadocia. See all those little partitions? They're all gone and it's all opened up. That's what I want. Now, here's that magic CFD, computer flow dynamics of what's happening with the wash. Whoop, I just played it up and then it didn't come in. Okay, so it's going in. It's going around the choana, and it's flushing through the ethmoid and going out the other side. Let's look what happened after post-op draft 3. There's washing in and whoosh, right around the frontal sinus and back out the other side. It's also going through the choana, but it's mainly going through the frontal sinus. And that's why draft 3s work. The irrigation now is preferentially going to that frontal sinus where it's having the disease. That looks so good, we got to watch it again. Whoosh. Right there through the frontal sinus. And that's what I want you to think about. I want you to think about when you're setting these people up for irrigation, I want you to think about while you're in surgery, how do you make sure they irrigate well and the irrigation is going to work well. And so what about cadavers? So we've taken the brains out in the posterior wall, John Craig again, putting the scope in, that's the frontal sinus. If you do no surgery, the blue fluid doesn't get there. If you do a draft 2B, and this is why draft 2Bs work quite often in these people, here it comes. I'm looking down in the frontal sinus. We're going to irrigate the cadaver. Whoosh! And you can just imagine all those bad things that were in that frontal sinus being washed out. You can imagine your steroid being applied to that mucosa and making it work better, all sorts of wonderful things. Let's go to the draft 3, and you'll actually see the same thing, slightly different. So again, the wash is going to come, here it's getting ready, whoosh, right through. And so that's what works about these surgeries, is to think about how do you make sure you get them so that irrigation will get there. So another one of the million little attempts to say this with analogies, that's me visiting Cambridge. And so I imagine if you're punting on the cam and there's all these little boats in the road, you're not able to shoot through there. And on the same tour, this is King's College Chapel, Cambridge, UK, and the tour guide claims that this is the first time the flying buttresses were put on the outside of the cathedral. And so because of that, you see how you get that beautiful, straight, wide open shot? That's what I want all my ethmoids to be. I want them to be a cathedral of openness. And the frontal sinus too, because if nothing's there blocking your irrigation's going to get there. So I now do what I refer to as irrigation maximized surgery. History of nasal polyps, AERD, previous surgery 05 by me, got aspirin desensitized, returned to surgery. Here he is at 2012. Now he's only on irrigations with steroid and aspirin. So he had a little bit of disease there. So now I will go ahead and do another. I'm going to whip through it because I don't do my draft 3s exactly the same anymore. But there, he's got a nice wide opening, and there was that stinking interfrontal sinus septal cell that was sneaking up on me. So here he is now. This is in the office about I apologize. This is in the office about a year ago. And you'll notice that that still looks like I want it to, because the irrigation's able to reach there and get through both sides. So he's just doing aspirin and steroid wash. And this is what we'll find on most of our people. If you can get them open so the steroid wash will work well, you'll be in good shape long term. So at this point now, I'm doing what I refer to as a draft 3 with pedicle flaps. The only real difference that I want to point out here with this case is that used to be when I was doing draft 3s, and part of the difference was that I learned from Aldo Stam years ago with choanoatresia, if you can cover bone with free grafts, people will heal much better. So what I do now is I raise flaps around the draft 3, lay them into position, and then at the end of drilling, lay them back down. So on the patient's left, I raise one from the septum and drop it on the back wall. On the patient's right, I take the septum, because that's all mucosa I was going to take out anyway for the draft 3. I put that up on the roof, and then I lay them down, and then I start drilling. So I'm going to take you through. We're going to go ahead and, so we've laid our flaps down, we've opened things up, and now we're ready. We've drilled everything out. So we took the drill and drilled it out. Now that was the flap from posterior. That's why I put the purple on it so you could see that. And this is the flap from back above. I'm going to rotate that into position. And then this one I'm going to tuck up. And so now I have all my bone covered with flaps. And the reason why that's lovely is it used to be when I did a draft 3, I was doing debridements for what felt like hours at a time. It was obviously minutes at a time, multiple times for months to try it until they healed in completely. Now, because they're all covered with mucosa, they heal in pretty quickly. And so that's how quickly they can heal now. This is a month out, slip the stents out, and things are in good shape. So you can do this with primary surgery now. So this is a person, why did I choose to do a draft 3 on this person up front? Small osteoma, and that interfrontal sinus septal cell and that cell right there. Now, back in my earlier days, I would have said, well, I'll just come do a draft 2A and clear all these cells out, and if I get them all out, they'll do really well. But I'm probably not going to be able to get all those out. I think I can, but I'm not. But if I do a draft 3, I'll be able to get them all out. And so this is those are the keys that make me decide that. And then we'll go through all the steps. And then there's one flap covering posterior. And then there's a second flap rotated over to cover the front edge. And then there's the other flap. So these are all flaps that are locally done to lay down into position. And if you wanted, when you're ready to do this, we have some videos on the web you can watch, because this is one of those things you want to look at right before you do it. This was the septum. I'm sorry, I'm going to go here and stop right there. This posterior flap here was the septum that was right here. This flap here, orbit, and then the other side of the septum here is rotated up onto there to get everything covered. And then we put in our silastic, and we got it covered. So we'll do that primary. Now revision, again, same thing. There's a cell blocking. This side looks reasonably good. That side's got a blocked cell right there that I'm probably not going to be able to get the whole thing out. And then, see, this guy would have been called, oh, he's had surgery before, but he hadn't had everything cleared out. And so once we do that, so this is revision. Again, same deal. Open things up completely, take out, lay down the flaps, drill things open. And so here he is. I'm going to stop right there and just take you through it. So we're putting the flaps back down. That's the anterior flap. The posterior flap is rotated here. And we're going to slip our side elastic in. So this is him sees me at a month. And so now I'm just going to slide these guys out. Right here in the office, this is the step-by-step process. I have had them irrigate, but nothing else. And then that's where they are at 1 month. And so at that point, they've healed up nicely. I'm not working to keep that healed, and that's where we get the success rate of these draft 3s. So, now that we've talked about the frontal sinus and irrigation and so on, what else do we learn from our irrigation stuff? Sort of little bonus irrigation thoughts. I'm irrigating, that frontal sinus looks great, but look, we're not hitting the sphenoid at all. So, what about the sphenoid? So this is now a cadaver. We've taken out the brain, put the scope in the back to look in the sphenoid sinus. And what you'll notice is, there we go. So this is the septum, as if we're standing in the sphenoid. Left sphenoidotomy, right sphenoidotomy. Right side of the nose, maxillary, maxillarily, ethmoid, ethmoid. We're going to irrigate on the left side. It's going to flow in there. And what you'll notice is when you irrigate, it just runs right around and out the choana and never hits the sphenoid. So when you run into recurrent sphenoid disease and you open it up, don't think that the irrigation is going to fix your problem if you're doing it in a standard fashion. So what do we do about it? This is John Craig showing that he can bend his head back to 90 degrees. I usually have my patients lie flat in a bathtub or outside. Take the tube out of the Neilmed bottle, and then you just irrigate. Patients immediately say, I'm going to drown, Dr. Palmer. And you say, no, your dinosaur brain's going to take over, your palate's going to seal. You're going to wash through, and then you'll sit up and spit a little bit. But it's the only way I know to get that irrigation into the sphenoid to get all those benefits that we've been talking about of what irrigation can do for you. So young people tilt their head back. I'm too old now. I can't even tilt my head back. I lie flat. You can get on the web, and I'll show there's a video of how to do this with your patients. Just to prove that that's what was going on, this is in the OR, packed off the soft palate, and then here we are irrigating there. This is actually some patients that had already had a bunch of surgery because of tumors, but you notice the irrigation fills up and then fills up the sphenoid sinus. Sort of what you were expecting. Bilateral sphenoidotomy, irrigation nose to ceiling, packed up the soft palate. We're going to irrigate. We'll put our scope in the other side. I want to know whether the irrigation gets to there. Well, if you have them laying flat, it'll bubble right in and get in there. Because the lesson that I've learned from all of this is the irrigation does not shoot in like a fountain like I thought it does. It banks off so many things, it's really a flood. So what you got to do, as I was saying before when we were talking about that maxillary disease, if maxillary disease is your problem, put that low. I realize the idea that it took me 20 years to figure this out really makes me sad. But it's kind of the reality of life. So what you put the low, wherever you want the irrigation to get low. That's why we have everybody, when we're doing the frontal, 90 degrees to the floor, because then you're getting your frontal low. If you irrigate at 45, you're going to go around the choana and back over. And so you got to tell the patients, look at yourself in the mirror and look at your head position. Because if you're doing it this way, you're going to do what? Get the maxillaries really well. Why do the maxillaries always look good? They don't have any partitions, and the irrigation is reaching them. So how do you make the frontal look good? Take away the partitions and get it so the irrigation reaches it. How do you make the sphenoid better? Take away the partitions and get the irrigation to reach it. So the sphenoid sinus not reached by conventional head-down irrigation. Head position can improve it. Lay flat in the bathtub, outside. It's difficult for patients to keep this up, but motivated ones find success, and they tell me that they're doing really well. And then they do it on an intermittent basis later. Okay, remember this graph. Here's CRS coming up, control, 36 hours later, they're pretty much the same. So I'm going to summarize a bunch of experiments and papers that back this up instead of making you look at more basic science things to tell you basically if you wash away the crap over the time, the cilia get back to normal function. So it turns out that the nasal mucosa, the lining of the sinuses, produce mediators that directly inhibit ciliary function. And those inflammatory mediators are locally produced in response to infection and trauma. And that's why a combination of washing and placing steroids that decrease inflammation on the spots locally that are giving you problem make the cilia get back to function. If they get back to function, they sweep everything out and patients do better. So how do we get people back to normal? If we're unable to convert or remove inflammation by systemic treatment, much of the inflammatory mediators are locally produced. Why not remove the majority of the inflammation and keep changing out the growth media, which is what we were doing in our experiments, which sounds a lot to me like surgery followed by topical irrigation. So back to this slide I showed you earlier, our understanding of CRS has changed, but unfortunately sometimes we don't talk about our surgical philosophy changing. And I would suggest that ventilation and diseasal resolve is a thought of the past. The goal of surgical intervention now is to allow placement of disease modifiers after you've removed the inflammation. So when I think about what I see patient-wise, polyps and even rhinosinusitis is more inflammatory than anything else, so I want to do things and open it up widely. As I said before, this group over here, the minimal techniques, are the true people that just have infection and obstruction. And yes, I think that's why there are a subset of patients that do really well with balloons in the office and things that take care of the obstruction. When I think about the patients in general, so this is pre-surgical, they get systemic antibiotics and corticosteroids to get themselves doing better because you're not able to do things locally. Around perioperative time, systemic and topical therapy, and then post-operatively, I want to get them to topical treatment alone with systemic treatment reserved for acute flare-ups. So a little bit of prednisone once or twice a year I think is a lot better than being on Dupixent for an entire year. And so I'd like to think of them that way. So it's really not just a surgery or medical therapy, it's surgery plus medical therapy. And in my mind, my goal is to shift treatment from systemic treatments to local treatments because the disease is a local disease in most situations. So in the immediate postoperative period right after surgery, systemic and oral steroids for the increased inflammation from surgery, because to go back to one of the talks we heard earlier today, trauma is one of the main inciting factors of ruining the barrier of the sinuses that then creates chronic sinusitis. What's the ultimate trauma to the sinuses? It's probably surgery. When you go through and cut all those areas of the ethmoid, that's creating a lot of trauma. So that's why I use steroids perioperatively to decrease that inflammation as much as I can. So that's 1 to 2 months post-op, depending on the situation. My current standard is 20 milligrams a day post-op for at least the first 2 weeks. I see it 1 week and 2 weeks. When I see it 2 weeks, depending on how you look endoscopically, I may drop you to 10 or I may leave you on 20. I see it 2 weeks, which is a month. At that point, I'll drop you to 10 and then off. And I'll do that dropping of it based on my endoscopic exam. Because if you don't get the patients looking normal, the irrigation doesn't hold them doing well for long periods of time. So that's the other lesson I'd like to have you think about is the endoscope is really telling you what to do based on how the mucosa looks. And as soon as the mucosa looks normal, drop the systemic treatments and move to local treatments pretty aggressively. So for topical therapy success, especially the frontal sinus and all the sinuses, cleaned out sinuses do the best for topical therapy, improve the clean out. I use image-guided surgery for every case. I don't hesitate to trim the middle turbinates. I make wide ostia, draft 3 for the frontal when needed, and I use the term radical. I understand that sounds, some people will see that as a negative. I see it as positive to clear all that out. So for chronic rhinosinusitis, mucosal inflammation and colonization, which may be biofilm, create mucociliary dysfunction, and so access, not ventilation of the sinus, is a key factor for treating that dysfunction in the long term. So in conclusion, CRS is prominently inflammatory disorder and surgically refractory disease. Better to give your medical therapy locally due to systemic side effects. We need to start thinking about our surgery as slightly different to improve the success of later treatment plans for irrigation. We need to teach people to get away from the obstruction model and more to an inflammatory cause. And in the future, which we are now in some ways there, I think local disease, systemic manifestation, they get topical pharmaceuticals. For people who are systemic disease, local manifestation, they get systemic pharmaceuticals. And that's how I feel like we should be thinking about surgery, we should think about irrigation, and thinking about biologics, and sort of decide how you put those together. And after that, I have to leave you with the conclusion slide. That's Cohen and me in Turkey. And the reason why I took that picture of genuine fake watches is to sort of point out that this is something in evolution. I certainly wouldn't have thought after 20 years I would be singing the song of do a draft 3 on lots and lots of people. I was once accused if you sneeze in my office, I do a draft 3 on you. That's obviously not the case. But I'm not sure, I'm not sure where we're going to go. And I really appreciate all of you being here, listening, and thinking about these things with me and figuring where it fits for your patients and how we can all improve therapy together. Thank you. Questions while we're working to the next speaker? Who is next up, Chris? Is you? Ah, perfect. I think they're worn out at this point, Gene. Of course. I'm sorry.
When we take the middle turbinate out, we get a lot of crusting. Do you see that a lot? Like, there was that nice case where you took one out on one side and then did a 2D on the other.
Yeah, so crusting in the middle turbinate. I think about it the way Aldo taught me to do choanoatresia, sort of catch people up on that. We don't go banging through the back of the nose with choanoatresia and then taking a drill and drilling a big hole. What we do is we raise mucosal flaps, we drill out that bone and then lay the mucosal flaps down, which is my answer to your question about crusting from the middle turbinate. So when I take the middle turbinate, I actively leave, I don't take it all the way to the skull base, I leave a little bit, and then I'll tease out a little bone and then rotate the leftover mucosa so I don't have any exposed bone. And so if I don't have any, every time I don't have exposed bone, I don't see the crusting. And so in many ways, my surgical debridements have gotten much quicker over the years because I keep thinking of this principle, make sure I've got all the bone covered. It's when the bone isn't covered that the crusting seems to happen a lot. And yes, that middle turbinate, the sphenopalatine coming out of there is always a problem for all of us. And I'm trying to design some sort of automatic clamp or a sponge that I put in there to cause that thing not to bleed on me, and I have not been successful. The other thing is another caveat to throw out there. If when you're looking in the nose 2 weeks out, you took the middle turbinate and you have that crust on that inferior turbinate or along the face of the sphenoid where you cauterized during surgery because the sphenopalatine artery branch was there, don't touch that crust. Leave it alone. Too many fellows and too many times I've pulled it off because I can't stand looking at it because I'm sure there's going to be something bad under there, and then psh, all of a sudden going to the OR for the bleeder.
Great, thanks, Jim. We'll have Eugene come up and Mike Marino, next panel. So like Eugene, I didn't really want to follow Dr. Palmer with our frontal sinus panel after that 45-minute workshop, but here we are. So here are our panelists. So here's our first case, right here. So 50-year-old man with CVID presents with right-sided CRS that fails appropriate medical therapy. We obtained this CT scan of this gentleman. So shows really predominantly right-sided sinus disease, but Dr. Palmer, anything on this for this frontal sinus that you think that would make it problematic, or what's going through your head when you see the CT scan?
So it's a tight frontal on the right side, and the left side not as, both of them are tight. I'm looking, there hasn't had any dissection in the frontal recess. And so I'm thinking medical management, but he's got CVID. We'll see how he does after medical management.
So he failed medical management, so we're going to bring him to the operating room. So what Dr. Palmer talked about, challenges, the narrow frontal sinus recess and ostium, and that very steep prominent frontal beak. So these are some of the approaches that Dr. Palmer talked about. Mike, what would you offer this patient, or what would you do during surgery?
And so I'm assuming we've committed to a surgery.
Yeah.
I think I've come to this kicking and screaming a little bit, and my thought process has changed probably even in the last 6 months, where because that is so tight and the nasal beak is so steep like you were talking about, I would start actually thinking very much about a draft 3, but with an outside-in approach, which Richard Harvey talks a lot about, and I've finally got around to doing, and it actually does kind of work really well for exactly this scenario, because I don't think I can cannulate that frontal reasonably well or leave it in a good place afterwards without kind of taking that all-in kind of approach to it. I think I would, even with a balloon, I'm not sure I would like leave it better off than it was.
Eugene, what do you think?
I have a slightly different approach. With CVID, I know that these patients are going to get recurrent infections, and so my threshold to actually operate on these folks is a little bit lower than most. They do well on IVIG, but many of them do get recurrent infections. In these cases with very, very narrow frontal recesses, I don't think draft 3 is a wrong answer. I mean, I think that's a good idea, but I actually try and do a balloon in these cases. And again, I'm not a proponent of balloons, and these are really the only cases that I'll do them on. And in part, it's because when you do manipulate the bone in these narrow frontal recesses, and this is a classic hourglass shape, you get a lot of osteoneogenesis, and you don't have a lot of room here. I mean, when you're drilling, this is kind of the really hard draft 3 to do. So I will try a balloon first. I have seen a lot of patients where people have done kind of frontal curetting on these, and they get really thick bone, and it makes it really hard to go back there. So that's, I know this is probably an unpopular answer, but I would try a balloon in this case.
I think that makes a lot of sense. Go back real quick. The thing that I would say thinking about this is that I don't ever start out saying I'm definitely doing a draft 3 or I'm definitely doing a 2A. I'm doing what the patient needs at the time it's surgery based on how things open up. So I don't have thick, strict things like, oh, it's got to be a certain AP diameter for me to do a draft 3. It's more where I am. So if I go into that to do a draft 2A and it looks really nice and the mucosa looks nice and I've just kind of gotten it open up, more or less like doing a balloon, I'm done. If the mucosa is trashed because I trashed it getting there, then I'm going to get the drill out.
Yeah, so we talked about all of those things, and I think, in the audience, we'd see that everything that we pointed out. So in this case, it's actually one of the times that we actually use the balloon. So here's this guy, you see the coronal, axial, and sagittal scan, the prominent frontal beak, and the very narrow frontal recess. So standard full house FESS on the right side, and here you see we've done what Dr. Palmer said. We did the 2A. So here is the supraoral ethmoid aerosol here, and then here's the frontal recess, really inflamed. We don't want to stick a cure up there. We think we're gonna rough it up. So here's the McLaren balloon, and I'm sure a lot of people in the audience have used this many more times than us on the panel. So I think we had the rep in that day. But it's Dr. Chu used to always say this. He said the balloon is a very nice instrument, and it's a very nice tool. So in this case, it's one that we found it was very useful. We're able to really dilate that mucosa and push it back without stripping. And then, there's a couple of little aerosols left that we're just going to take down between the frontal recess and the supraoral ethmoid aerosol. And this is it. I mean, it's very steep, very narrow. We could look up there with a 70, not really stripped at all. And then the most important thing, this is him afterwards. So, it's a small opening, but it's still open. We could see it in clinic, and he did fine afterwards. He's still on his IVIG, but we have an open cavity. We didn't have to bring him back for a draft or anything like that. So balloon's a very good instrument.
Chris, can I make one point there? So show us that sagittal scan again, and I think this speaks to what we're thinking as well. Sometimes we'll see patients that have had just balloon surgery, and this is tempting, but in this case, it doesn't work. I mean, if you think about this, look at the frontal sinus and look at that drainage pathway. Jim gave a really nice description of those computational flow dynamic scans. If you take the ethmoids out, there's a natural airway or area where mucus is going to drain out, even if you do have a frontal recess. If you don't do an ethmoidectomy, it's just going to get clogged. So I don't understand why people just do balloons. I think I agree. I think balloons are an excellent tool, but it probably is a hybrid tool, especially in this case with frontal sinus disease. I think you have to do at least an anterior ethmoidectomy all the way up to the skull base, just like you did. And I think that's probably why you got such a good result in your case without having to be more aggressive.
All right, so our second case, a 6-year-old man with a prior history of facial trauma. He came into our clinic just complaining of a right-sided headache. And so we got a CT sinus. So, Mike, what do you see on this scan and what are you thinking?
Well, I guess what's jumping out to me in both the coronal and the axial is what looks like all this kind of osteotic change in the left frontal, and kind of thinking about how that would potentially affect my surgery. Although on the sagittal to the right, you know, it looks like you do have a pathway. Which one's the pointer? So I'm kind of looking at this and thinking about the history of trauma, and you know, what is this bone here, and how is that going to affect things? And you kind of see it here as well. But I presume this is the right side.
Correct.
That looks like it has kind of a reasonable pathway through a traditional approach, although I don't know what the left sagittal is going to look like, and that may influence how we're going to approach that frontal and then start to think about them together potentially. Because if I don't have very much access to the left, that may affect how I approach this. Now I'm turning everything into a draft 3 in my mind, which is kind of not what I actually do in practice, but anyway.
Well, I think the audience will know what Dr. Palmer's answer is.
Well, actually, I don't. Well, so what's interesting, to defend myself, or here, give me a thing, is that he doesn't have any disease. It doesn't have a lot of disease in his ethmoid back here, right? Because this original problem is trauma.
Yeah.
So if you go in there and you get that opened well and you look at it, you say, hey, it's draining well. This is one of the few times I would say draining is fine, because this primary disease is from the trauma. This primary disease is not from mucosal dysfunction. So if I go up endoscopically and open that up and I just don't feel like it's very well open, then yeah, I'll probably move to a draft 3. I don't know what's going on here. Is that inflamed bone infected, or just inflamed bone in response to his original trauma?
So
I'd be interested to see what you did.
Yeah. Not shown here is MRI. So actually that was just like regular bone from trauma, wasn't enhancing. And it was actually, like you said, a mucopyocele in there, just from the trauma. And like, you can't see it well here, but he had a little bit of a, you know, probably a acquired type 4 cell. So we talked about these, some, you know, frontal sinus mucocele, steep frontal beak, acquired type 4 cell. I think we would agree we probably want to do a balloon for this. Maybe not a 2A, so maybe 2B or 3.
Well, I guess, Chris, it would be depending on what I'm not totally clear about what the left side looks like. So if it's just the right side, the mucopyocele, I might do a 2A just there. And if the left really has just got this infilling osteotic bone without mucosal disease, I might leave it be. But now if I have to open up the left, then I'm probably leaning towards a 3.
Yeah, it was just isolated right-sided disease. So here we go in this case. We actually, you know, we went in there like Dr. Palmer says, just trying to get all the cells open, but we eventually had to do a 2B. So here you see the CT scan. And we're going in, Dr. Palmer talks about the middle turbinate. I usually try to trim it because what Eugene said here in Arizona, we get a lot of crusting for the dryness. So I'll try to preserve it if we can. And here we see the skull base. Here we have 7-degree scope. You have the supraorbital ethmoid air cell. And what you're peeking in right now here, where the navigation suction is that prominent frontal beak. So we started at 2A. We thought the beak was too prominent. So here's a 2B. You saw a lot of good videos of a 3. So here's 2B. We're just on the right side. 60 drill. So here we're seeing just the floor of that mucopyoceal. Pulsation is not the brain. That's just the pus under pressure. Here, yeah, some transmission here. So we're entering it with a frontal sinus curette, and just like Dr. Palmer said, just widely open it. Here we're using our Hoseman, or what we like to call the medieval here. And then after we get that out, you see the pus just pouring out. And like Dr. Palmer said, this is obstructive disease. This is not CRSwNP nasal polyps. We just need to make a big opening and ventilate it. So here we're just saucerizing the frontal beak to make it a little bit bigger, because as we know, Dr. Connolly said that this is going to scar down 50%. So we want to make it as big as possible. Here's the 2B at the end, and here is this gentleman after surgery. So it's still open, didn't recur, and we got it away with the 2B in this case.
Yeah, I would say that these are really fun cases because you can just pop into them, and you might not have to do a ton of dissection. The challenge is with that one, it was quite high, and so this is one that I would consider doing like I know it's, external, we're endoscopic surgeons, but I kind of like doing a little hybrid lid crease. You can drill right into the frontal, and then you can cannulate it and just make sure that it pops down. I've done that a couple times. It really hides really nicely in the eyebrows, and it doesn't really give much morbidity.
It's funny, what Dr. Chang is talking about, this eyelid incision, now we have a new term called TONES, or transorbital endoscopic sinus surgery, which is something Dr. Palmer was doing before this came up, and probably Dr. Connolly, but this next generation of rhinologists wants to come up with a new term for something that's been going around forever.
Good to have names.
All right. So case 3, 6-year-old man presents to our clinic, 10-year history of right-sided nasal obstruction, facial pressure, discolored drainage, and they thought it was polyps before. He didn't respond to appropriate medical therapy. In this case, we obtained a biopsy. It returned as inverted papilloma. So then we got our imaging. So Dr. Palmer, I'll give you some kerneled and sagittal. So tell us what you're thinking when you see this scan.
It's big inverting papilloma. And so thank you for getting an MRI. So whenever you see a pacification at the skull base, think about getting an MRI, especially when there's this area of lost bone here. Now, the matching MRI means it's probably just up against the dura, but you're going to find out. So the patient needs to know about that. That's probably a mucocele sitting high up in there somewhere because it grew up all the way. And then this is one that what I would do is I would consent the patient for endoscopic possible open. And I do that quite often, and fortunately I don't have to necessarily do the open, but I won't bat an eye at doing it. The other thing sometimes my patients will do to me is they'll say, all right, you do everything you can endoscopically, then just stop, and then we can come back and do it open if you feel like you need to. And I think they're trying to play a psychological game with me that I'll that I'll get it all done endoscopically and I won't quit early. And I always tell them I'm going to always try and do it endoscopically so I make a pretty video. But this is blocked up mucosa. That's the concern. So if you're coming in with an osteoplastic flap, you'd be able to check out that area. And so I think it becomes a little bit of a game time decision.
Great. Eugene, Mike?
Yeah, I had a quick question, and this is a question to the panel as well as to you folks. So I just recently saw a gentleman inverting papilloma, right lateral nasal wall, really just on the lateral aspect coming out of the maxillary sinus. Do I need to get an MRI on that patient? Does that, if you're not concerned about dural invasion, pterygopalatine invasion, it looks like IP. Certainly, an MRI will give you a lot more information, but in our community, sometimes it's hard to get MRI scans. The wait time, the claustrophobia of some folks, and so I know that has been drilled into our brains, MRI, IP, but what are, practically or anecdotally, is that something we should consider if we can really see the limits of where the IP might be?
So Eugene, with my program director hat on, tell residents MRI is what you say on the board exam, because you can't really go wrong there. That being said, there are definitely ones that have been very obviously circumscribed where we've gone in with the plan to biopsy, and if it's an IP, complete the surgery and have not gotten an MRI in that scenario. Almost exactly the scenario you're describing.
Yeah, I mean, I'm just thinking about how in the early 2000s, we didn't get an MRI, and it was sort of more a medical legal thing than anything else, and if there's a pacification skill place, get an MRI. So I don't think there's necessarily a need. I think the one thing that I didn't go over was you want to think about where there's thickened bone for the IP attachment, and does the MRI teach you any more about that? Not a whole lot. It did tell us, at least in this case, to think about that mucocele up high. This is one where I definitely get an MRI, but do I think you need it every time? No, I don't. I would agree.
Yeah, I think it's the same thing. When they're really big and you don't know the extent of disease, it's been there a long time, you may worry about malignant transformation, you get an MRI. But if it's isolates a spot you could see and you know you could totally resect it, I think MRI is not needed. But like Dr. Marino said, for the residents on the board answer, it's MRI.
Yeah.
So here's the T2 weighted axial, and what Dr. Palmer was going to is like you can see that it's post-obstructive disease right here in the right maxillary from the IP, and right here laterally in the frontal sinus. So in this case, our decision-making challenge is extensive frontal sinus disease. We want a complete resection, and then the other thing we don't always think about is surveillance. Because we want to surveil this IP because there's a high recurrence. There's been good papers out that you want to at least watch them for the first 2 years. And ideally, you could just evaluate it without getting another MRI. So, we talk about, I think for this one, we talked about a draft 3 or osteoplastic flap or a combination of both. Our classical teaching is, the mid-pubital line is the extension of our draft. I think adding a supraorbital incision or osteoplastic flap helps. In this case, that's exactly what we did. We consented the patient for a draft 3 and then a possible osteoplastic flap. So it's the same thing here, inverted papilloma, you see it going all the way back in the right nasal cavity into the nasal pharynx. This is just a bilateral sinus surgery, debulk the IP on both sides. Here you see the middle turbinate, the IP and the middle meatus. Here we're looking with an angle scope up at the skull base. We're tracking it back. It's clean. And what Dr. Palmer was talking about is the key to inverted papilloma surgery is finding the site of attachment. That's how you're going to reduce your recurrence. Based on the imaging, we know it's going to be in the frontal sinus. So here we're debulking it, and this is the right side. We see now we're at the limits. We can't get it all out. So here's our draft 3. Here's our superior septectomy. I do not do the mucosal flaps like Dr. Palmer does. Our current fellow always asks me why. I tell her it takes a long time, and I'd rather just have her debride for a month than spend the extra half an hour out to do it. So here we're drilling it out. We're drilling the inner sinus septum here. We're just trying to get wide exposure because we want to find the site of attachment. And so here you see actually the inverted papilloma within a frontal sinus cell. It's actually in a capsule. So what Dr. Palmer was talking about earlier is this thing actually eroding through the posterior table and going dura. It's not. It's actually just thinning out. And we got real lucky that it was in like a type 4 cell. So here we're just removing it. And then now we trace it back. And then you see that the cell is just attaching posterior laterally on the right side. So we just keep taking on that cell and trace it back to the site of attachment. And it just really expanded that type 4 cell and grew down into the ethmoid sinus and then out to the left side. So we got really lucky in this case. Here we're just taking it down, we're going to drill it smooth and then bipolar that area. But here we are at the end of this case. Nice big opening like Dr. Palmer showed before. You see there's no mucosal flaps. The current fellow just debrided probably for like a month. And here we are 2 years out. This is the key. I follow him at least 2 years. And here we are on the right side in clinic, 30-degree camera. Now we're looking up. So no recurrence, the low-throp's wide open, patient's happy, we're happy. In this case, we don't have to get repeat MRIs because we can see the whole cavity. Any comments from the panel?
Question over there.
Oh.
During the case, did you see that spot where there was no bone you were staring at?
Yeah, so I didn't show it. So the nice thing about a draft 3 is we'll look from the contralateral side from the left side with a 7-degree scope. So you can see over the orbit sometimes, over in that posterior table where there was just missing bone, dura intact, there was no attachment there. That was actually the site where the mucocele actually caused the erosion from pressure, and there actually was no IP in the far lateral portion. But great question.
One observation I can't help but make. You only follow them for 2 years and then you let them go?
No, this guy's still seeing us, but
Because I'm a little bit of a control freak. Surprise there. And so inverting papillomas, we've actually seen them come back on people because what's the biology thereof? We don't know. It is certainly has something to do with HPV, but we don't know everything on why they come out and why they wouldn't. So I'll see them once a year after their, usually post-op period, 6 months, yearly for at least 5 years, and then every 2 years forever. And people say, well, why are you spending so much time looking in their nose? And like, these are the things that give me energy and make me excited, right? I look in there, we did a great job, there's no tumor there, this is great. I high-five the patient, go on to the next one. It gives you more energy for the next tough cases that you do.
Great. Anything else, Mike? Eugene?
No, it was
I
a
follow
beautiful,
them all.
beautiful surgery. I mean, I thought that was a really nice draft 3 approach, and yeah, just looked it looked cool. And yeah, you're right. I'd want to see my good work every year too.
All right. So our last case here, 67-year-old woman with frontal headaches. So here we get a CT scan. You see your axial, coronal, and sagittal here. We'll bring back to Eugene. What do you see here? What concerns you?
I think we know why she has headaches now. She's got a very large osteoma. Typically, osteomas are caused by trauma, so it'd be interesting to know what the story is here, but it looks like it's blocking up and almost completely filling her left frontal sinus. You worry if there's a little bit of contiguency to the other side, but the right side actually looks okay. But yeah, very lobular, looks very benign appearing in my view, but certainly something that is obstructing that side and could be causing her pain.
Yeah, absolutely. She actually did have trauma. It was actually a patient that was sent over from our FPRS colleague who was treating for a really severely deviated external nose and septum. So in this case, the osteoma is attached to the frontal sinus, and like Eugene said, it's very adherent close to the anterior and posterior table and orbital roof. We want a complete resection and ideally some surveillance. She did have that post-obstructive disease from that osteoma, so we want to clear that as well. So I'll give you guys 2 options for this one. Draft 3, osteoplastic flap.
Can I have both?
Yeah, that's the answer. So I did not share these slides with any of the panelists, so I guess it's his 20 plus years of experience knowing what to do. So here, draft 3 osteoplastic flap. As you can see, we actually, for our drafts, if you want to, or our osteoplastic flaps, if you want to use your navigation, you could put it here. This is something that one of the former Penn Fellows, John Craig, published on. And so it's great. You can put it right here and still use it for your whole sinus surgery and still use it for your osteoplastic flap. When I was in residency, we used to make a stab incision here and put a little patient tracker here. But this works really well. So here we are. Here's a bicoronal. And here we have the osteoplastic flap. We traced it out with fusion navigation. Here you see the acute osteoma here. Here you see the resection. You can't really see it right clear in here, but this is the bilateral recess, and here's the plating. Like Dr. Palmer said, we care about ventilating and drainage afterwards, so we did do a draft 3. And here's what she looked like right afterwards. And here, right here, you can see that's where the osteoplastic flap is, and this is where we had the fellow open it up so she could look from above and below prior to closing.
I love osteomas because they're so fun. Sometimes I have to stop myself on operating on osteomas if they're not doing anything. But have you guys ever found the case where if you take a curette, sometimes it pops off? I mean, I've seen them where it doesn't look like it on the scan, but it almost looks like there's like a little stalk. And so just rocking that back and forth often will pop that off. This one was a really big one, so I don't think that would have been possible, but they are fun cases to be able to do.
Yeah, so sometimes they do pop off, which is great. This is beautifully done, Chris. The one thing that, sitting in one place for 20 years, I'm almost disgusted with myself, but it's good to tell the story so that you know. A couple of them I did around 05. I took it all out through an osteoplastic flap. It looked fabulous. I said, I'm not going to do anything with the inside of the nose. It's draining fine. I'm not going to worry about it. And then 15 years later, they show up with a regrowth of the osteoma. So these things can come back even though you think you've drilled them all out completely. Something I learned from my partner, Dr. Adapa, he immediately gets a CT scan so there's proof that it was cleared. So if it ever comes back, he has proof that it was there. But I have one that I had to go back and do the osteoplastic flap again because it had regrown into the area. So the question that I always have, number one, is how do I make sure I've drilled all of it, right? Like if you have that stalk, do you need to get that last little bit of the stalk or do you have to worry about it coming back? I don't think we all follow these patients long enough to know that answer consistently. That's one. And the other is the pain from the blocked mucosa, blocked sinus, or is the pain from the osteoma itself? And the reason why I think about that is I think about over the years, especially Fred Kuhn used to just drill half of it till we got into the sinus, suck out the sinus, and cheer and say we're done. Except that I wonder where those patients are now. So I think these are actually, while they're really fun cases, I've now decided they're tougher than I thought they were. And I don't know what the answer is on it. And so one of these things that I think if you're going to do it, get that CT scan right away. And I think opening up the sinuses from below is really important to be able to keep an eye on where things are.
So I was kind of wondering that question exactly, and maybe I'm totally off here, and maybe I'm a skeptic of my own patients, but an osteoma that's kind of indolent to me and symptomatic always kind of raises questions about whether or not that's something we should go after. But in this case, clearly it's blocked, and I was sort of toying with the idea of can we just drill through this, open the sinus, and the idea being that an osteoma, in theory, as far as I know, is relatively indolent, but I agree, Dr. Parham, I don't really know that because I sort of take that on face value and don't go back and look again, I think, in a lot of ways.
All right, any questions from the audience on this frontal sinus panel? Yeah.
Yeah, Scott Graham, actually, who was one of my colleagues at Iowa, looked at that. And that was a lot of scans over a lot of years. But he said that they grow at a rate of like less than a millimeter per year. So if it's obviously in the frontal recess, you don't have that much room. But I have not seen rapid growth in osteomas. If it's growing that rapidly, there's something else going on, is my thought.
Yes, yes, sir.
The small ones I typically don't see are symptomatic, right? I mean, I think they have to be blocking something. So unless it's a small one in a small place, then I typically don't see them. But I mean, they're so fun that I want to do them, but I don't.
I feel like the question you're asking is somebody shows up in your office, says they got headache, you get a CT scan, and you see a little osteoma in the ethmoid. And it happens to match the exact spot where they say their headache is. What do you do? When that happens to me, you didn't ask, but I'll tell you. I put them together with the scan, I show the spot, I tell them definite maybe that could be causing the headache. It's more or less a coin flip. Choice number one, let's treat you with some, I usually put them on irrigation for steroid irrigation because I give that to everybody just because it's fun. And I put them off for 3 months or so and then I get another scan. If it's any change, I'm gonna make a move on it. If there's no change and they still have headache in that spot, I'll throw the ball in their court because I have taken those small osteomas out and their headaches have become better. Now, is it because they've decided they're better because they went through surgery, or is it because the osteoma was sitting on, you know, a nerve in some way or another was causing the headache? Yeah, that's the Sluder's headache debate, right? Where, so Fred Kuhn used to sit and drip lidocaine on there and prove that it was going to work or not. I usually just throw up my hands and stick it back on the patient. I say, you got enough of a deviated septum, I can do your septum based on the fact that I see a deviation for nasal obstruction. And it's, you know, going through surgery or not. And I let them decide.
For the non-obstructive osteoma with the only symptom of headache, probably take it out eventually, but they're probably going to go through the exercise of meeting with headache neurology first see if that helps, maybe repeat our scans and then work ourselves up to that surgery.
I usually hope that their headaches are not on the side of the osteoma, so I could just wave goodbye to them. All right. Yes. My favorite sinus surgery? I would say frontal sinus surgery. I think it's the most difficult and the most humbling surgery to do. I know other panelists.
The one that works.
I love IPs. I find them fascinating. It's kind of a interplay between inflammation and malignancy, and I love finding the stalks. It's always a fun hunt, and drilling them down, and seeing them forever and ever and ever. So yeah, I like IPs.
Maxillary antrostomies and revision antrostomies in particular, because I think the maxillary sinus is taken for granted, but it can be pesky and tricky if not treated with the respect it deserves as the largest and king sinus.
It's funny, Dr. Kennedy said the same thing like 5 or 6 years ago when he came here and gave us a talk. He said like the maxillary sinus is underappreciated, and he actually does that at the end of the case because he thinks the most important, that's when he's present. I don't know if that's still the same. All right, we'll go on to our next talk, just a sinus surgery complications panel. So, sinus surgery is amazing, but a lot of bad stuff could go wrong. I'm sure a lot of you seen this on the what's on the left side, which basically is a nucleation as a complication of sinus surgery. This was actually published in the Ophthalmology Journal. I think this was out in Baltimore where this happened. And then on the left, on the right side, this is a patient who had sinus surgery many years ago in another state, and presented with a CSF leak, and it looks like there was a injury to the left frontal lobe, maybe with a microdebrider, and she has some encephalomalacia and encephalocele and a CSF leak. So when we look at sinus surgery complications and we look at orbital complications, intracranial and bleeding, we could look at minor complications versus major complications. Meaning the major complications for the orbit stuff is orbital hematoma, blindness, and ophthalmos, and epiphora or injury to the nasolacrimal duct. Obviously, intracranial, we worry about the CSF leak, tension pneumocephalus, encephaloceles, and infections. And then, bleeding is, we consider as a complication as well. More so take back to the OR, but that happens a lot of times when we injure the anterior ethmoid artery or the sphenopalatine, and catastrophically, hopefully no one happens, but injury to the carotid artery. So, when looking at some of the studies for sinus surgery complications, we see, Stankiewicz had his first initial series a while back, and then his new one. And then when we look at the more recent series, complication rates have gone down. I think it's probably because we've done more surgeries, the field has advanced, and we, have a lot of better training. So here's our first case. 40-year-old man, allergic fungal sinusitis, failed appropriate medical therapy, and here's a CT scan. So really classic pansinusitis, allergic fungal mucin, and I put an arrow there for the area that's concerned. But for our panelists here, I'm sure that you guys beat this into your residents, but what do you see here?
You've helpfully placed the arrow on the anterior ethmoid artery, so don't cut it. Or if you do, have a bipolar cautery ready.
That's absolutely right. So, when we're doing sinus surgery, this patient has really bad disease, and you're going to clear the frontals, like Dr. Palmer was saying, because this is allergic fungal sinusitis. You need big, wide openings. You need drainage and topical irrigation delivery. But, you may run into the anterior ethmoid artery, so if you're doing frontal sinus surgery, either don't cut it or have a bipolar there, and not a suction bovie. So in this case, starting out, really happy. We're going to make this patient feel better. This is the right side, cleaning everything out, get the polyps out of the way, flush all the thick allergic fungal mucin. And as we keep going on, after we clear the maxillary ethmoid and sphenoid, here we are working on the frontal, but there it is. We found it, unfortunately. And so you hear this anterior ethmoid artery is here, right? It bleeds a lot, and we have to control it before something else happens. So, on the panel, what do you guys look at pre-op to avoid it? And what do you look anatomically during surgery to identify it?
So this is for the residents as well. The residents know, and I'm sure they don't enjoy doing this, but for every one of my cases that they're in, they need to take a couple pictures of the imaging. So it's typically a PowerPoint that they give me. So the first is why we're doing it. The second is what do we have to look out for. And the third is what's your plan. And the reason why I do that is A, you need to know why you're doing surgery, because if you don't know why you're doing it, then you're not going to have a good outcome no matter how good of a surgeon you are. The second is that we go through a mnemonic, so the closed mnemonic. We look at things like, is the lamina present? Where's the carotid artery? Is there an anode cell? Where's the anterior ethmoid? And the first time you do it, it's hard. You have to learn how to screenshot. You have to, pull up the imaging. But then the more and more you do it, the more and more facile you get at it. And it really is just 3 or 4 different images, but it's amazing that when you're looking for things, when you're looking to avoid complications, then you really minimize them actually occurring. And so they picked up on things that I didn't even think of. A carotid septum that's attaching to the internal carotid artery. That's a perfect example. If you take that septum down when you're doing a transsphenoid and you're not aware of that, that could be a life-threatening injury. And so although it does seem mundane, these mnemonics, these safety mechanisms are there for a reason. I'm sorry, this is a long-winded answer for your question, but for one of them is the anterior ethmoid artery. So we typically look for a small protrusion or a nipple right around the orbit on the medial aspect. And is it bony covered? Is it low? Is it dehiscent? Those types of things are things that we look out for, and it's always right behind the frontal recess. So you're not going to see anything anterior to that.
Yeah, so that was the thing I was going to mention. It is always behind frontal recess, and there's the trainees kind of struggle with that sometimes, but I tell them that it is always there without fail. And my partner, Dr. Law, is very big about that. And also, when I'm doing my surgery, I kind of skip that area now. Go sphenoids, posterior ethmoids, be a little bit gentle, get into frontal, because then I can see posterior table, and I know anterior ethmoid is always going to be behind it.
So your residents have to make screenshots. I like that. Mine have a sheet that there's 13 things, and it's all the stuff we're going to end up talking about before the complications lecture is over. Email me if you want me to send you the sheet. And if you don't have it filled out before surgery, you don't operate. And about 10 years ago, one of the residents got the bright idea that they would stick it to the image guidance machine. So when I walk in, if the 13 things aren't listed out and taped to the image guidance machine, there won't be surgery for them that day. And it really helps remind it. And I do that with every case. I go through those 13 checklists on it, and you just automatically do it. So we've written some articles about it. I think that's pretty standard. It's some mechanism, whatever it is, you need to do it. It's like the pilots taking off before they fly. I mean, you just need to do that.
That's great. So, he's talking about checklists. So I think all of us in the audience, we do this mental checklist because we've done so many cases, but for the residents, this is why Dr. Chang has you do these checklists, is not only to, show that you read, but also to keep us safe. So this is what everyone's talking about. If you're not a rhinologist giving lectures, unless you have these 2 pictures, because I've seen this picture, these 2 photos like 100 times as a resident, a fellow, and as attending, so I have to use it in a talk. But what we're talking about is we see here the nipple sign on the coronal scan. That is a low-hanging anterior ethmoid artery. And like everyone's saying, it's always in front of the supraorbital ethmoid air cell and then behind the frontal recess. And surgically, you'll see it. This is on the right side. You'll always see it at this angle, and you'll see the frontal recess right here, and you'll see the anterior ethmoid artery. So I always say it's a speed bump on the skull base. And you don't always have to find it, but I like to challenge the residents and the fellows to find it every case so that we know when we get into it and to avoid it. Do you guys ever go in a case, there's a lot of frontal sinus disease, and you're going to plan to take it?
Yes, quite often. Actually, before we were done, I was going to say, as a fellow way back when in Savannah, there was such a fear of the anterior ethmoid artery, we would actually open the frontal and not go take that down, even if it was sitting like that. When that's sitting way out into the the combination frontal recess, frontal sinus, however you want to say it, that's supraorbital ethmoid over there, but if you don't clear that area, you're going to run into a problem. So open the frontal, and then if you're ready to do it, get your bipolar, both sides, then cut in the middle.
Yeah, and I think that's a key. During that case, we got into it, but it was in the middle. And I think what Dr. Palmer was saying, that if you're going to get into an accident, make sure you make that cut when you're ready. Or you want bipolar before, but if you cut in the middle, it's less likely to retract. So I think we talked about it, but what are the next steps if you get an anterior ethmoid artery injury?
Don't go crazy. So it's squirting in there. Don't just suddenly grab something and do something. Relax. There is never a person in the world that is going to die from an anterior ethmoid artery bleed. They might die or become blind from you trying to deal with the complication, but it's not going to be from bleeding out from the anterior ethmoid artery. It's too small. It just is not going to be able to put enough blood out there. So put a suction on it. We have a bipolar in the room all day when I'm doing sinus surgery. I don't have it open for every case because it's too costly and too much trouble, but you cut into it, you say a few dirty words to yourself quietly, grab the suction, put it on it, and say, get me the bipolar. And just sit there with the suction on it and just chill. It's going to only take, a couple minutes, and they'll set up the bipolar for you, and then you can go zzz, 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 zzz. The thing you don't want to do is go a little crazy and chase it with your suction bovie and chase it into the orbit, because if it retracts and then goes where we're going, which is orbital proptosis and or medial rectus injury, you've now made something into something bad when you could have just relaxed and put the suction on it.
What would you do if you didn't have a suction, or if you didn't have a bipolar and you got into it? If you're operating at a surgery center and you don't have a bipolar, what would you do?
Me no operate without a bipolar in the room. Flat out. I would. And I also don't operate without having a tonometer available to me. Those are two things that I am not going to do surgery on, because you get blindness, you're never going to forget it. And all you had to do was talk to whoever the administrator was and demand a bipolar exists at your surgery center. They're making enough money off you, you can have a bipolar and a tonometer.
Yeah, I think here we have a bipolar in all our sets. It must be because we're getting the anterior ethmoid all the time, but we have one for every set. So yeah, our goals are control the bleeding, stay calm, prevent the orbital hematoma, and ideally complete the sinus surgery. This is not this patient, but this is what would avoid this orbital hematoma. So we check for it first, tonometer, and then temporize the bleeding, and then ligate it. And we could talk about a couple ways to ligate it, but in our case here, like Dr. Palmer said, we didn't have to wait because we had the bipolar open every case. So here it is bleeding. We're just going to temporize it. First, say a little curse words under our breath because we're really mad. But here, you just put a pledget there if you want. If you're waiting, put a pledget on there, put a suction on there, and get some pressure. And then stay calm. And then now, if this is the case, you can just put it on there while you're waiting for your circulating nurse to set up the bipolar. So stuff it there. And then, it slows down a little bit with the pressure. But here's our DESI bipolar. And there's multiple ways bipolar. So this is our choice here. But then you could just take care of it, burn on both sides, like Dr. Palmer said. And here it is. We're done. And then we can finish the case. But I think I would stress that if you're doing frontal sinus surgery, you're inadvertently going to get the anterior ethmoid on some point, so you should have a bipolar. So in the case I was getting at, let's say you don't have a bipolar and it doesn't retract, you can do, this is a transorbital approach in the left orbit, kind of like a Lynch incision, but with the endoscope. You could still go this way and get it along the medial orbital wall. Ideally, you don't have to do this. Ideally, you have a endoscopic bipolar. All right, so second case here. This 32-year-old man presented with a nasal obstruction and facial pressure, and a CT and MRI were retained. I'll give this to Dr. Marino, since this is one of his patients that he helped present at this meeting.
This is why I don't like operating on osteomas, because of where this heads. So this is a young man, he had this, what wound up, I think radiologically there was some confusion about what this was. It wound up being an osteoma, and he has kind of these non-specific symptoms and maybe sort of a trapped ethmoid cell. And I think after some discussion, we decided we're going to at least open up this ethmoid cavity.
Great. On the panel, is anything on the CT scan that would concern you or think you'd be, something you'd be looking at going to surgery?
You've hopefully got the error on probably where the anterior ethmoid artery is feeding this osteoma, so I'm looking forward to the bleeding that is coming.
That's great. So here we go, the first part. Mike, go take us through this.
So I think we've got it mostly open, and we went back for just a little bit more. Yeah. You know, and there, and it starts bleeding. There's a little bit of orbital fat that comes through, and we were patient, but then we quickly noticed that this was a bigger problem. Yes. And my junior partner now, who is the resident, thankfully started taking images of this. So this is he has proptosis. It's firm. I think our video stopped there, but we realized he had a retroorbital hematoma. We need to proceed to a lateral canthotomy and cantholysis.
So we talked about some of the things to look on pre-op imaging. This goes back to that CLOSE acronym that we have the residents do. But potential challenges, prior surgery, orbital wall defects. You don't have to have trauma to have orbital wall defects. You could have it from a sinus disease, or they could just have it. Abnormal anatomy, poor visualization, and then maybe a low-hanging anterior ethmoid artery. These are all things that could lead to orbital injury or hematoma. So for the panelists, what are your next steps for management? And any consultations you guys would do, or medical management, and then surgical management?
So I want to say from our end, we knew what was happening. We went straight to canthotomy and cantholysis because there's really this was very obvious to me. In my mind, there was no pass go. We want to make sure we preserve vision, and that's the best way to do it. We, had the circulating nurse call for an ophthalmologist, which my expectations were low, but about 20 minutes later, they did actually show up, and we know how to use the tonometer. They had to go fetch it, but we know how to use it in a pinch, and we did that, and it was clearly elevated, and so lateral canthotomy and cantholysis was top of our list to do.
So I always love this subject at sinus courses, so I'll try and not do it too long. There is a story of people that I know that got into the anterior ethmoid artery. They didn't realize it. In the case, they noticed the proptosis. So then they called for ophthalmology. There was an ophthalmologist operating in the room beside them. And he said, I'll be there in a second. I'll be there in a second. Being there in a second turned into 30 minutes. They woke up the patient, finally showed up. Or they actually called another ophthalmologist, came in, did lateral canthotomy, cantholysis, patient wakes up blind. And so my take on this is that if you are doing sinus surgery, you need to be able to do two things without fail. Number one is operate that tonometer. It's cheap, it's easy. You call ophthalmology. Our ophthalmology is at another hospital 6 blocks away. They drive over in the car or cab, they put on their bunny suit, they walk in to hold the tonometer and go, beep. Oh, number's okay, we're done. So find out where the tonometer is in your institution, and when someone is asleep with a regular sinus surgery, a regular whatever surgery, use the doggone thing till you know how to use it, so that you can do normal pressures, and then all of a sudden all your fears of all the rest of your career go away. Because anytime you think, oh, maybe I got the anterior ethmoid, oh, maybe this patient's a little proptotic, you could just get the tonometer and check. And it'll be normal, and you'll say, oh, good, I don't have to worry. Instead of that whole period of time you're worried while you're waking up to make sure everything's okay, you can take that away from your life. So that's number one. Number two, next time you do a cadaver course, do inferior cantholysis, do lateral canthotomy and inferior cantholysis. It's just not that hard. The big key is when you pull up, you should feel a guitar string. That's the way the inferior and cut that. And then if that doesn't work, and one time, unfortunately, drilling on a big osteoma, boom, the eye shot out. Adapa and I were sharing the case. I was out in the hall talking on the phone to somebody. All of a sudden, my phone blows up. Get back to room 56. And Nathan's already doing a lateral canthotomy, cantholysis. I'm going in the nose. I'm decompressing, and the guy's eye still didn't go back, and the pressure still didn't go down. So we did superior canthelysis. So don't forget, you do inferior naturally first thing, but do superior too if you've got to. Pressure came down, eyes fine. You can all have fun and laugh about it later. Blind patients, you're never going to laugh about it later. So learn how to do those two things if you are going to do sinus surgery. Okay, I'm off my soapbox now.
Yeah, I agree. I think canthotomy and canthelysis is very, very important. You can take tenotomy scissors. Oftentimes we have small scissors, even iris scissors. This is a point where you just feel the lateral orbital bone, and then you just go right underneath it. You make a cut horizontally or laterally, and then you make it down to hit that guitar string. And when you do it correctly, and if it's truly proptotic, it's like a suspender that snaps, and so that pressure is immediately released. The other thing, so I don't use a tonometer. I will now, but what I do is, if one eye is bad and the other eye is good, I just push on both of them. And I mean, if it's proptotic, it's usually not subtle. And then again, doing the canthotomy and the canthelysis, nobody's going to fault you for doing a canthotomy and canthelysis unnecessarily. If anything, they're going to be happy because, as David had shown out this morning with the cosmetic thing, you're going to tighten their lid up and you're going to make them look 5 years younger on that eye only, I guess. But yeah, it's super easy, and it's really easy to fix too. So don't be worried. Don't be worried about the repair. Don't be worried about anything like that. These are things that we used to do, when we were rounding with the oculoplastics guys in residencies all the time. And so it is easy to do. It's easy to fix. And the benefits far, far outweigh the potential risks.
I think Eugene's points are perfect. And to add to it, one of the panelists here has a lateral canthotomy. So all of you are allowed to come up and look later and try to tell me which side I have a lateral canthotomy on. I was playing a soccer game in college, tripod fracture, lateral canthotomy. So if in your mind you're like, oh my gosh, I'm worried about the cosmesis, just think about how beautiful Palmer's eyes are and you can't tell which side it is, and just do it. And and the other thing is, one time, this was years ago, it's like, oh, I don't want to do a lateral canthotomy. I'm just going to real quick do a decompression. And damn if that wasn't like the longest decompression I've ever done. Everything came out okay, but just do the canthotomy. It takes you a minute or two, and the problem is solved. How often do I add in the decompression? A lot of it has to do with the tonometer and telling me where I am, right? Get the pressure down, then change your shorts, then think about what you want to do, and if decompression makes sense and the bleeding's under control and everything else, go ahead and do the decompression. At least 50% of the time I'll do the decompression, maybe more.
So
So Diamox and all those things, actually, again, email me. I have the doses. I wrote them, typed them up, and I taped them onto my Karl Storz boat. So I can't produce what they are. Chris will probably have them in the lecture, but I just say, read the thing on the boat and give that to anesthesiology. I sound like this is happening all the time to me in the OR.
So this is what Dr. Palmer was asking about, or referencing to. This is just a nice flow chart. Just look on orbital injury and like medical treatment, consultations on different algorithms. And this is a nice slide on just how to do the lateral canthotomy and inferior canthelysis. Yeah, mannitol's right there. Yeah. So leave it there for you guys to take pictures. So, Mike, what did you guys do?
So, like I said, we did a lateral canthotomy and canthelysis, which I think it helps tremendously straight away. In this case, I think I was, my heart rate was about 150, and I wanted to make sure it was perfect, and it still felt a little firm, so we did a medial decompression as well. Part of that, in retrospect, I don't know was necessary. If I had been a little bit patient and let the blood kind of redistribute, it might have worked out without doing that, but we did the canthotomy, canthelysis first, and then did a decompression as well.
Did the patient have any transient diplopia?
No, he had like no consequence from this whatsoever. No diplopia. We had him see oculoplastics. They talked about, can we do a lid tightening? He was pretty happy. They didn't really feel it was necessary, and he kind of went on his way. And we talked about orbital injury as a pre-op. Obviously this is a potential risk, and he in the PACU, he said, doc, you told me that, so okay, and I can see, and everything's, I don't know about fine, but everybody was satisfied.
Yeah. I think the question about the decompression, sometimes we worry about the transient or permanent diplopia. If you guys think back to residency, there's all those patients with medial orbital wall injuries without floor. They never had double vision. We do decompressions for Graves' disease all the time, medial orbital wall. So I think that when in doubt and you're worried, you're waiting for the ophthalmologist, just take that medial orbital wall down and let that fat out if needed. And this is why I love Mike's video, because we've all done this canthotomy canthalisis if you've done enough cases, but I have not videoed yet. And Mike has this beautiful video, so that's why I love when he includes it. But there's a canthotomy canthalisis, and here he is decompressing the medial wall on the right side. And then he's gonna take a sickle knife and just release that paraorbita to let that rest of that fat herniate into the ethmoid sinus. And here we are post-op. I mean, this is the post-op scan. The patient's doing great and no long-term sequelae.
I think this might be a good time to talk about counseling as well. So it's hard to counsel a patient for surgery and not scare them away, right? I think that's one of the things that we encounter. How do you realistically talk to a patient about what realistic concerns are and what they're not? And so what I do is I tell them that we are operating near the eye, near the brain, near the fluid surrounding the brain. Those are the areas of major complications. Those complications are exceedingly low. I typically use 0.1%, but it actually might be higher depending on what your data has shown. But then what I also say, and I think that this is reassuring to patients, is I say, look, if there is a complication, we will identify it and we will correct it. And I think that brings a lot of reassurance to people, because just like in this case, and that's the goal of this panel here as well, is if you have a complication, take a breath, identify it. And if you're not the person to fix it, that's okay. It's always okay to pass it on, but let somebody else know, because it's always an easier talk when somebody's waking up saying, hey, remember those complications that we had talked about, this happened, but this is what we did to fix it, and you're gonna be okay.
So our last case, a 40-year-old woman, CRS, prior bilateral sinus surgery, out of state, and then presented to us with some right-sided clear rhinorrhea and salty postnasal drip. We obtained the op report, and they noted a frontal sinus balloon dilation. And so obviously we got some beta-2 transferrin, it was positive, and this is for the residents, they've seen this before, but this is a classic, CSF rhinorrhea. And so, when we look at the pre-op scan, what are we looking at for potential pitfalls for to avoid a CSF leak?
Well, the obvious is the thin skull base, but the big thing that I always like to point out to people is that the size of the maxillary sinus versus the size of the ethmoid sinus. For whatever reason, God, evolution, however you want to say it, there's a certain amount of room between the top of your palate and the bottom of your brain. And when the maxillary sinus is really big, the ethmoid's really small. And when the ethmoid's really big, the maxillary sinus is small. Got to watch it on the big maxillary sinuses, because the middle term attaches back there. So when you're opening it up, your skull base comes up very quickly, and your fulcrum, or your angle of attack, puts you into that posterior ethmoid fast. And then that creates your issue. So be very careful about that ratio of maxillary sinus to ethmoid height to see where you're going to be.
So I think we've all seen this, but I think Dr. Palmer was talking about the height of the skull base and the Caros classification. Obviously, the higher Caros classification, the more exposed the cribriform is. And the other thing is, what he's talking about is the height of the maxillary sinus, the ethmoid sinus. So when it's a massive maxillary sinus, then the ethmoid sinus is smaller, so you're actually going to be very much closer to the skull base. The other thing we want to talk about is asymmetry of the skull base. So if you're doing surgery on one side and you think it's symmetric, you may be much lower on the other side. Another thing we always talk about is this deviate septum. I harp this on the residents all the time. But if you don't fix this prior to doing this right-sided sinus surgery, it's going to be really tight with this low skull base. You're going to be in a lot of trouble here. So, workup for CSF leak, we know that beta-2 transference positive. What do you guys do after that in form of like imaging or trying to localize that leak?
I'm pretty regimented. So beta-2, if it's positive, certainly if it's positive, high-resolution CT sinus or your NAV CT sinus, I would say the vast majority of the time that gives me a pretty good hint of where it is, and we go with that. Then after that, if we really don't have an answer, I mean, I try and follow the guideline and get my MR cysternography and radiology. Kind of goes, what are you talking about? And they sort of do it. And between those two studies, we almost always localize it. If we really haven't localized it at that point, then we think about adding intrathecal fluorescein for the presumptive repair. And even in that scenario, I think I have an inkling of where it is, and so we'll use that for confirmation.
I mean, I think you just nailed it. So this is basically a paper out of the Utah group. I think Gretchen Oakley did a few years back. Really good paper. One of it's on diagnosis of CSF rhinorrhea and then management. It's a really good evidence-based review and recommendation. But really, beta-2 transferrin, high-resolution CT scan. And then if you don't find it, you can talk about the MR. Same thing here at U of A. I've switched to, we can't find it on the CT, getting a high-definition T2 space sequence. Because a lot of times you could find maybe the meningocele there, or you may see the CSF fluid coming from the brain into one of the sinus cavities.
I really like intrathecal fluorescein. So I'm beta-2 transferrin, CT scan, because they're going to surgery anyway. And one of my anesthesiologists used to torture me when he was putting in lumbar drains. It'd take forever, and I couldn't stand it. He's like, I can't do this anymore, because he was scared of it, and they'd always bring somebody else in. It became like this 2 or 3 hour ordeal before the patient was finally asleep. So he set it up so they go to interventional radiology, and it's the most brilliant thing ever. So what happens is I do my first regular case. While the patient showed up first thing in the morning, they go to interventional radiology. They put the lumbar drain in under fluoro, so they boom, one shot. Then I go out in between cases and give the fluorescein, and then by the time they're in and asleep, it's just like regular sinus surgery for me now. And now I've got the green to see where I am and make sure I've got it. So we do that every time at this point. And then run the drain for at least a day after, because you want to get all that fluorescein out of the brain. There's officially no side effects from it, but Dave Conley's back there. You were there at Northwestern when neurosurgery put the whole vial of fluorescein into a lady's brain, and she seized under general anesthesia for like 4 or 5 days, but then was great afterwards, so that was good. But that reminds me how I want the fluorescein out. That was a lot of years ago, Dave.
How about you guys on the panel? Lumbar drain, fluorescein dye to localize leaks?
I don't use it routinely, because if I have a good idea where it is, I don't put the intrathecal fluorescein in. But if we are going to use it, we do probably similar to Dr. Palmer, where neurosurgery will do it in the interventional suite. 1, because they like it better, and 2, it's a better workflow, honestly. So they'll do that for us, and then we'll localize the leak that way. I mean, for a traumatic, almost really all leak at the first repair attempt, we do not leave a lumbar drain if we didn't place one. Kind of similar thing though, if we placed it for intrathecal fluorescein, probably keep it in to drain out the fluorescein. It's already in place, so it's kind of a sunk cost in my mind already at that point, but then work to get it out, the next day.
Yeah, I typically, if I know where it is, I won't use intrathecal fluorescein because of the same things that you were talking about, Jim. It just takes forever. And the other thing is when you inject it, you have to realize that it takes a while for it to circulate. So I remember there was this one case in residency, we injected it and we just started operating. And then only till like right when we were about to finish patching it did you end up seeing it. And so it does take about 30 minutes to circulate through that system. The other thing is they pee like this really weird bright green for a day or two, so just let them know that. And then, yeah, it is off-label, so I always tell patients, look, we've used this many times. It's a dilute dosage, but this is off-label. This is not FDA approved for what we are using it for.
One thing I would throw out there, if this is traumatic CSF leak, where you're probably sure where it is. If it's a spontaneous CSF leak, please use fluorescein. I have had one where I went down and fixed one in the sphenoid and cheered and thought it was great, and then the patient showed up next week and they were still leaking. And I wasn't feeling very proud of myself, and I'm like, oh, it's nothing, da-da-da-da. Collected fluid, beta 2 was positive. Took him back again, gave him the green stuff, looked on the other side, and there was a little itty bitty olfactory feeler that was leaking away. So if it's a spontaneous one, just be careful. There's a high rate of them having more than one place that's leaking.
Yeah, especially those patients with idiopathic intracranial hypertension. I think we've all had them where we fix one side and another side popped up, and 5 years later another pops up, and you feel like really bad about yourself. And yeah, I think in those cases, intrathecal fluorescein is very helpful because like there's usually not a big defect that you see on the MRI or the CT. But in this case, it's a traumatic leak. So what we see here, arrows are help you. But here on the kind of the posterior table of the right frontal sinus, and on the anterior skull base and ethmoid, you see this little defect here. And it's probably what happened is probably they put the frontal sinus balloon in and they pushed it too far, and they maybe inflated it, and that's probably how it happened. But here you see the little meningocele right here. See some CSF in the frontal sinus right here. So in this case, we did not use any intrathecal dye or lumbar drain because we could clearly see where it was. And then so for sake of time, we'll pass this part. And then just questions, for you guys. Prophylactic antibiotics, we talked about. What do you guys think about that?
I love them. I don't understand why anybody wouldn't. I'm going to get myself in trouble on the panel. There's always this fun article from the 70s where it was like, oh, you're selecting for resistant bacteria. Dude, if you got a CSF leak, I'm getting it fixed in under 2 weeks. I don't care. I mean, I'm going to find some time on the OR schedule. I'll do it on Saturday. I'll do it in the middle of the night. I am not going to let you leak for months at a time, which is where all those selected bacteria came from. So anybody tells you don't give them antibiotics, tell them Palmer said, give them antibiotics and then get the leak closed.
I acknowledge that there's no really good evidence, but then I do it anyway because it feels like the right thing to do because you have nose open to brain, and it's never been a problem, so I just do it.
All right. For this case, would you guys do an endoscopic or open repair? It's kind of like posterior table, frontal sinus, anterior ethmoid skull base.
Endoscopic versus open.
Yeah.
Do it if you can do it endoscopic.
And then I think graft material, I think we've probably already all agreed that you use anything. I always tell the residents skull base repairs like tympanoplasty, you just need to get some scar up there and seal it. So, use anything. Glue packing, bed rest, post-op activity restrictions.
Now, this is a little bit, you get into the territory where everybody does what they think they do and what they think works best. I do use TIS-seal on all these cases because I like it. I recognize I could get away without it. I hate to get away with anything. It doesn't cost that much. I'm going to do it. Bed rest, 48 hours. I mean, the worst thing is when you do one of these big skull-based cases and you come by to see the patient next day and someone ordered physical therapy to come by and they're like pumping their legs and you just, So I just do it 48 hours. Activity restrictions, it depends on the size of the hole. CPAP I put off for at least 2 weeks. That one's a hard one for me because those people really need their CPAP, some of them, but I would like to not have to deal with a pneumocephalus, and I haven't, so that's why I do 2 weeks at least.
So I use the TIS-seal as well, but I think that's mostly for me to feel better because it looks like it's nice and sticky. Typically gel foam packing unless it's a really, really big defect. And then I don't think I really do strict bed rest, but skull-based precautions, starting, stay in the hospital typically overnight, discharge the next day, and then skull-based precautions, something like 5 or 6 weeks, depending on how it plays out. CPAP I get a little bit antsy about, and probably hold for that 5-6 week period as well, with the idea being that that's kind of a chronic illness. Yes, your CPAP is important for your OSA, but that's a long-term treatment thing, and probably 6 weeks in the span of the rest of your life is not a huge difference.
Yeah, I just do 1 week for CPAP. In part because it depends on where the CSF leak is. If it's like a big leak, like in the pituitary cellular region, I think that's a much higher chance of pneumocephalus than something up in the anterior ethmoid skull base area. And in terms of glue, I used to use Tracheal, but then Chris started using this glue that's colored and that's got the pump, and it's awesome because I like it. And also Tracheal, like when I put it up on the skull base, it would glob right back down at me. And so this one I like because it can like spray. And so thank you, Chris, for showing me that, because that has been a huge help.
Here we go. So here we are on the right side. Here we see the frontal sinus. Here's the encephalocele. You see it pulsating a little bit here along the posterior table. So we tried to do we did what Dr. Palmer recommended. Try to do endoscopic. Here's just drilling the frontal beak, kind of like a draft tube, just getting more exposure. And then here the key is really, now we have wide exposure. You can see that pulsation in the brain there. And we're just going to strip the mucosa adjacent. This is the only time in sinus surgery I tell the residents and fellows we can strip mucosa. And so we really want to get the raw bone exposed there for a graft. And here you see the edges of the encephalocele and the skull base defect. Then we're going to reduce it to make it smaller, just to really to size it. And here's the bipolar again. Again, another reason to get a bipolar, because you're going to want this for your meningoceles and encephaloceles. And then we're just going to debulk it. And here we see it. Actually, it's actually a small defect. It's probably like 5 millimeters in size. So maybe they went in there, balloon blew up. I guess that's how big your balloon opening is. And here we size it. So it's a pretty small defect. So in this case, it's just an onlay graft. You can use whatever you want. Nasal tunnel flap, usually in the reach here, we use the Cook Bio design. And here's what I've started changing. This is why I like the Propel, is I use it in there. I know Dr. Palmer uses the stent, but again, I hate spending 30 minutes cutting it because I'm not as good as I was as a fellow. And I just put it in there. It holds it in place. Then you put the glue on there, packing, whatever you want, and here's the patient afterwards. Nice and healed up, no more leak. And graft looks like regular mucosa. So, yes? Yeah. I don't know. This is a patient that had surgery out of state, and she was leaking for some time before she, got to us, and maybe they thought it was postnasal drip, allergies, but, by the time they came to our clinic, we quickly realized it was CSF rhinorrhea. And so, sinus surgery is amazing, and, the key is being prepared to avoid potential complications, recognize complications when they happen, address them if possible, phone a friend, and we're all really good surgeons. We, have a lot of great skill sets, but we got to remember, like Uncle Ben said, with great power comes great responsibility.
You had a question? One question? Yes.
So we did not do a lumbar drain. That patient came through clinic, so there was not a trial of conservative therapy or bed rest, because they were already leaking for like several weeks. I think it was actually several months.
Yes, question in the back.
So that's a real question. I think when we first started doing, depends on the size of the encephalocele. If it's a really big one, I know you're getting at. We're talking about post-op CT for potential post-op pneumocephalus. So I think when it's potentially a small one, it's not really big, I'm not too worried about pneumocephalus or intracranial hemorrhage. But definitely on a bigger one, that I would definitely get it. Let's see what the panelists would say.
So I typically do get it. They're going to stay in the hospital overnight. It's typically an overnight stay. We get CT head in the morning, one for the pneumocephalus, and two, although this has never happened, just to make sure there's no blood collection forming behind the repair. It's probably overkill, but it's easy enough to do. They're there, they go down at 5 in the morning, they get scanned, and it's ready for discharge in the morning.
I don't, because if I find air in there, I'm not exactly sure what to do. So there likely is going to be, there might be a little bit of air in there just with the fact that you're doing a CSF leak repair. So I typically go on their symptoms. But yeah, I mean, CT scan is super easy to do. But if you find a little air, then do you keep them another day? Do you scan them again? So that's why I don't. I talk to them. I make sure that they're clear, and then cross my fingers.
I think it's personal preference, and you can defend yourself either way. Yes.
So the question was, if you are fixing an encephalocele, do we have any tips to avoid a CSF leak? Is that correct? Oh, so this thing is pumping out. Yeah, so how do you control it during that time in the interim of you patching it? It's kind of like a faucet. I think you just, I don't know, I just put an underlay in. And
So if it's leaking so much that it's really just pouring down and you feel like you're just futzing back and forth fighting it, take a little piece of Dura-Gen, about the size of the hole, roll it up and stick it in there real quick. It'll slow it down, and then you can go ahead and do whatever you're going to do for the repair. If you feel like the CSF is flowing so much it's washing away what the graft you're trying to put on it. Be very careful. If you're in that situation, you might have somebody with increased intracranial pressure and it slipped past you. Again, why I always put a lumbar drain in all my increased intracranial pressure crowd. If they've got a spontaneous CSF leak, they've got increased intracranial pressure. So that's why I like to have the lumbar drain in place.
Yeah, and I think the other thing is if you have a lot of pulsation, it's probably a high flow leak is probably connected to a cistern or something like that. So then that's a different type of repair. You're talking about probably like an intradural or intracranial and extracranial repair. That's when you're talking about more vascularized flaps, maybe fat, much different than in this case. But, when you're doing a craniopharyngioma, you're going to see like the ventricles and just CSF being produced from the choroid plexus. So that's going to be just pulsating out. That's a different story.
Well, for the sake of time, I want to thank Dr. Lay for leading this panel and for our panelists here. Thank you, Jim, for coming and really educating us today. I'm sure all of us are in need of a drink. Fortunately, we do have drinks right next door. So please make your way over. Thank you again. And congratulations on making it. This is the longest day, so you guys made it. Yeah, after the reception, after the drinks at the vendor booth, there will be a non-CME activity. And then we'll have a nice reception at the hotel. So please continue to join us and feel free to come up to us and ask us any questions as well.